And I will talk to you not so much about science, there's no time left for that, but about zirconia implants, why, where, and what to do. What do they look like after 5 years? Now, very fast, my little story. I was a nurse, and having been a nurse in intensive care, this makes me today even more firm in dealing with my patients, affected or non-affected by COVID-19. It prepared me, and dentistry did once more in order to tackle this question. And we have been taught to give our care also to TBC patients. And when you have ever treated a TBC patient, you know how to deal also with COVID-19 patients. I'm a Bavarian German who chose as his homeland Sardinia Island in Italy. And I will skip the definitions, aesthetics, there are some out there. What an implant is, you know, but you can see here the sequence, how we came from titanium implants over zirconia abutments to zirconia implants. And these saw already, many of you saw the downsides of titanium, this grayish, or let's say violet shadow that you have around your teeth. So let me dive in right into my first case. It is a patient, a female non-smoker, 58 years, good health conditions, fillings in the dentulous areas, as many of this age. We did an orthodontic treatment in order to substitute the missing bicuspid and wanted to have a zirconia one-piece implant there with immediate loading in area 2.5. So here you have the radiograph. And after the orthodontic treatment, we had enough space in order to place our implant. This was the first ever, almost 6 years ago, when we did just a tissue punching. There was lots of keratinized tissue there, a circular incision, and then the drilling sequence that most of you know. Here we do it with a zirconia burrs also in order to avoid any kind of contamination. And then we put our implant into the recipient site, reaching a final torque of 45 Newton centimeters of insertion torque. We know from literature that once an implant has an insertion torque of more than 35 Newton centimeters, it is to be loaded, can be loaded immediately. So we did the same with this zirconia implant, but not directly with the provisional, but let's say with all the forces receiving from tongue and from cheek muscles. Here, very fast sequence, how we went on, the postoperative X-ray, and then a healing cap. This was what the patient was using, let's say, as a tooth without a crown in her oral cavity. Then we had the day of impression taking. I will be a little bit faster now. And we were giving to that zirconia implant a porcelain fused to zirconia crown. This was then the result 2 months after cementation. You can see here the radiograph after 2 weeks, and then the radiograph after 5 years. And looking at the radiograph after 5 years, I did not understand why there was hard tissue right next to the cervical area of the implant, and then you had a radiotranslucency. So I was going back to literature, and in a paper from Sancho Puchades, it's written that in vitro assessment of artifacts induced by titanium, zirconium, and zirconium dioxide implants in cone beam computed tomography, the conclusion was that zirconium dioxide implants can generate significantly more artifacts as compared to titanium implants. So what did I do clinically? I measured, and I had a pocket depth of 2 millimeters, which is more than acceptable, which is just, we can say, physiological. Some more literature that I will skip, and this is the result of the implant in situ with a crown after 5 years. Right to my next patient, a 42 years old male. He cracked the tooth, upper right second bicuspid, and as he is exposed to the public very much, and he has to sell, he was very much concerned about his aesthetics and wanted the placement of a so-called aesthetic zirconia implant. He had a pain on the upper left bicuspid, and you can see on the right slide that there was also swelling. He was under antibiotics treatment, 2 grams of amoxicillin in 24 hours, means 1 every 12 hours, 48 hours before treatment. We went for syndesmotomy in order to cut the sharp fibers, and then did finally the extraction with a forceps. I measured the alveolus. Of course, you have to have the measures of your system in mind. And here, with a so-called non-drill procedure, we were inserting the implant up to the final length in a central position. And oftentimes the question is coming up, what are you doing with the uncovered space of the alveolus? And my answer is nothing. No bone substitute, no membranes, nothing. This socket has only one information, and nature will help it, and this is heal. And it will heal in terms of bone regeneration, connective tissue regeneration, and gingiva regeneration. So this is the situation. What we do immediately is to give a support to the dentogingival fiber complex. So this means that the position of the gingiva remains exactly in the position where it was before with the tooth. We adapt our provisional precisely to that. We do it with flowable composite and a prefabricated crown, the flowable composite, in order to make the fit precise to the implant. And this is how the patient goes home. So what I want you to remember is just this blue line. And we will see where this blue line is after years. Radiograph, impression taking, not so important. You have copings here, which the industry is giving you. It makes it simple. And then the final restoration. Just to go to this work from Masaki, who concludes that it is necessary to obtain stable and long-term aesthetics by combining connective tissue and free gingival grafts in addition to hard tissue augmentation. So you have seen nothing of that has been done in this case. So you remember the blue line and you see where the tissue level is, the soft tissue level. Nothing has changed. It goes further, the final radiograph, and then after 5 years, I skip this, and this is the clinical situation after 5 years. And if you still have the blue line in mind, then you will see that also in 5 years, almost nothing has changed, if not a little transversal loss, so less voluminous. I skip also this one and go to my final patient. I still have 11 minutes left, so I can have a little more time with you about this case. A 50 years old female, she cracked an upper second bicuspid. And she was crying because the bridge that she had was only fixed on the canine. And she was very concerned about her aesthetics. She said she was also working in a job. She is the chief of post office, so exposed very much to the public. And we decided to have a partial extraction of the cracked tooth. Here are just some literature which was done by Aurora and co-workers, and they evaluated the hard and soft tissue dimensions around zirconium oxide implants supported by crowns in a 1-year retrospective study. They concluded that in addition to favorable implant success rate and peri-implant bony response, the soft tissue levels and overall aesthetics around single immediately placed and restored implants can also be maintained on a mid-long term. I skip this one. So you can see the radiograph, the cracked tooth. We extracted just 1/2 and left the patient for 2 weeks in order to have a soft tissue fill in, which happened, as you can see here. Then we extracted the other part, and this was to have immediately a gingival seal around our implant. Measured again, we needed a slight drill after the removal of inflammatory tissue. And then we inserted the implant, same procedure as you have seen in the sequences before, and she went home with a provisional bridge, substituting the upper left lateral incisor, and the bridge was supported by the canine and by the just placed implant. So then we had to deal with the substitution with a zirconia implant of the upper left lateral incisor. And we did a mini flap in order to preserve our connective tissues. We had to deal with, if you remember the radiograph, with the horizontal and with a vertical defect. So we preserved this tissue, did our preparation, and you can see on the right slide that we did also bone augmentation with a bone chisel or a bone spreader, picked up our implant, we're inserting it here again, just to remind of what Masaki all wanted to do in order to obtain stable and long-term aesthetics. And then we were drilling up to the final length, inserting the implant and fixing the soft tissue transported to the vestibulum. And here on the right side, just to see the dimension of the horizontal defect. This is the radiograph after the implant insertion. Then all the procedure, we go further with the copings, pickup and impression taking on the implants, and of course also on the natural teeth. When the trial in was coming with the zirconia mesostructure, then we adapted with the coping the zirconia abutment. You can read in the instructions of industry that this is almost forbidden. But I can tell you, if you can drill with a zirconia drill, if you can grind zirconia with, let's say, all the precautions that you need, the right speed, and of course, the right cooling, then this will be a predictable procedure and you will have no failure with this implant. I skip this one. And then you can see here the horizontal defect after surgery and how the soft tissue stability was maintained once we had cemented the final crown and bridge work. You might see that the canine is a little bit longer. The money of the patient was not there to do a mucogingival procedure there. So she accepted it as was. And this is the final front view of it. We did an analysis with red aesthetic score and white aesthetic score. And you can see the only defect is the more cranial soft tissue level around the upper left canine. Although overall a very good aesthetic result. This is the radiograph after 2 years. And this is the situation after 5 years. This situation was, it was photographed in January of this year. She was instructed, she confessed that she was doing horizontal brushing. She was instructed by our dental hygienist, and the tissue was slightly coming back and almost covering this grayish or brownish line that you can see. You can see also the radiograph after 5 years, and with this, a smile from the patient, and big thanks to my teacher and friend, Dr. Joachim Mühling from Heidelberg University in Germany. He was my teacher, and this was, let's say, all what I needed in order to deal successfully with this case with zirconia implants. The question is now, do we need zirconia implants? And I would say, well, in the aesthetic zone, and if you have a shallow gingival type patient, or upon the patient's request. And let me share here with you my conclusions. Zirconia one-piece implants are as easy to handle as titanium one-piece implants. The absence of a microgap promises long-term bone stability over time and decreases the risk of peri-implantitis. Primary implant stability beyond 35 Newton centimeters, so nothing different compared with titanium implants, makes immediate zirconia implant loading predictable. Infra-occlusion is maximum muscle strength during healing time is indicated, and the risk factors for the development of peri-implantitis around zirconia implants are the same as for titanium implants. Out of approximately 30, we have one case, and this was due to the psychological change of the patient and, of course, let's say, the loss of daily oral hygiene habits. What will come up in the future? Well, zirconia implants, it was said that they are exposed to a higher fracture risk. I did not lose one so far. Industry has probably looked into that and can give us a good guarantee for a zirconia implant survival. All ceramic solutions are far away from modern solution in terms of compensating the periodontium. New prosthetic materials are facing the challenge to substitute porcelain infused to zirconia crowns, satisfying biologic and aesthetic needs, and new implant materials will contribute to better compensate functional and in part parafunctional occlusal forces. And new implant surfaces will ameliorate tissue healing and reduce healing time. With this, I recommend that once you have, of course, science and knowledge behind, and you have adapted your skills, nothing is very much different to dealing with titanium implants. Please believe always in yourself. And at this point, I say shukran for your kind intention. And sorry if I was rushing a little bit too much through my presentation. I hope you liked it the same. And if you want to write me, please feel free.
You were in time. Thank you for your presentations. We'll have just a couple of quick questions. First one, why did you do partial extraction instead of the whole extraction for that case?
The reason for this was that the rest of this tooth gave a little stability to the provisional bridge that the patient had. On the other hand, we had a soft tissue fill in, as you could see, and it was possible at the time of implant insertion to have immediately a soft tissue seal around the implant.
The second one, what are the contraindications of zirconia implant, if you have some contraindications?
I would definitely say that if you have a bruxing patient, so parafunctions, probably I would not feel very safe to insert a zirconia implant.
Thank you for your timing. It was a pleasure and to have you on board. It was a quick, informative. White, I think it is the promising future maybe for dental implants. On behalf of the scientific committee, would like to present a certificate of appreciation for being here. Thank you so much, Dr. Gerhard, and it was nice to have you on board. Thank you so much. Appreciate it.
Thank you, and sorry for the initial dilemma.
Thank you. Bye-bye.
Thank you very much. Bye-bye.
Our next speaker is Dr. Salah Hawais. Dr. Salah is the founder of the Osseodensification concept. He's the inventor of the Densifying. Dr. Salah is a full-time private practice at Jackson, Michigan, and also a adjunct clinical professor at the University of Minnesota. Dr. Salah, are you with us?
See me? Thank you.
Yes, we can see you. Yes, we'd like you to on board of the presentations, and if you can share your screen, please.
Yes,
you can
I will share my screen in 1 second.
Yeah, please.
Share screen. Okay. Do you see my screen now?
Not yet.
Do you see it now?
It's coming. Yes, I think yes. The floor is yours.
Okay, thank you very much. I'm going to put this on the side. Where do I go? I don't want to play. I just want to.
Go through.
Just go to the play mode, full screen.
Yeah, I see. Okay, very good. We're ready to go. Hello, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. I am Salah Huwais. I'm speaking to you from Jackson, Michigan, where it's snowing pretty dogs and cats today. We have a lot of snow on the ground. It's about 2 degrees above zero. So let's hope this lecture will bring warmth to everybody around the world. I'll be sharing with you today a new concept in bone instrumentation. This concept in bone instrumentation is related to bone plasticity. And so we're going to talk about what is bone plasticity, why when we preserve bone bulk, we enhance its strength, why when we preserve bone bulk, we enhance its healing, what's the significance of implant micromotion. So we'll go through some of the science of bone instrumentation and why bone preservation is giving us a better outcome in our healing as well as in implant stability. Then we're going to dive into some clinical protocols that has to do with subcrystal sinus lift, ridge expansion, immediate implant placement, and guided expansion graft. Whatever I'll share with you today, it will be in evidence-based. So we started with the biomechanical evidence. We moved on to large animal histology, and then we moved on to clinical evidence that will be shared with you all today within this hour. We all knew from 81 that the implant procedure is not fully optimized. The reason it's not fully optimized because bone density was always a factor. The implant stability in the maxilla is always a factor, specifically the posterior maxilla, and the borderline ridge was always a factor. The same scholars in 81 came back 28 years later to shed a light that bone instrumentation will make a difference. And the surgical technique will make a difference. The key to osseointegration, we all understand, is implant stability. But implant stability has two components. A mechanical component, what start the day of surgery, and then biological component that will kick in after that. But because bone is not wood, it's a living tissue. It's a viscoelastic tissue. It will tend to creep away from pressure. We understand that. Bone is the most cowardly tissue we can deal with. It will run away from infection, will run away from insult, will run away from mechanical pressure. So the more we squeeze implant into small holes, the more damage we'll do to the bone tissue. And the bone will creep away. So we'll end up with a pretty low stability at 3 weeks. Meanwhile, the biological stability start kicking in. And we hope usually the patient health and the environment, the healing environment is good enough for us to get basically a good result by 6 to 8 weeks. Why stability is important? Because without a stability, there is unpredictable osseointegration. And specifically now, all of us were leading into the immediate load, we're leading into early loading. Therefore, implant stability is very good. So for us, really, at the end of the day, as a scientist, as long as we place an implant below the micromotion threshold that's defined in the medical literature already, we will get osseointegration even if the implant or the screw is loaded. Paolo Turrisi came in 2009 and said, immediate loading is not the problem. The problem is the implant micromotion. Then he did a fantastic study in 2016, and he related two clinical parameters that we can use to make sure that our implants is below the micromotion threshold, which is insertion torque need to be about 40 Newton per centimeter and above, and ISQ reading 68 and above. So the key is for us to establish the stability. We don't only need a very, very highly designed magic bullets. We need to step back as well and look the way we instrument the bone. Look the way that we drill bone. We tend, all of us, to use drill bits that are designed to cut everything but bone. They're designed to cut metal. They're designed to cut wood. They're designed to cut plaster, but they're not designed to cut bone. So when we cut the bone, extract it out, we're jeopardizing the host. We're jeopardizing the healing potential of that host. And we're not alone in this. The medical profession way before us, basically is asking for a better way to instrument the tissue of bone. So a lot of us used osteotomes. Osteotomes did well in so many hands due to their taperness, specifically Summers osteotome. As long as the osteotome is tapered, it did produce a good result. It gave us improved bone density, improved bone to implant contact. When European used straight osteotomes, the results were not that great, because with straight osteotome, we shock the tissue further. You create fracture in the tissue, as you see here. And every time we create a microfracture in the tissue, we have to wait longer for healing. On top of that, it's really technique-sensitive procedure because it depends on how much hammering we do, the force of the hammer, and the rate of the hammer. But at the end of the day, a hammer is a hammer. When we hammer the bone tissue, expect specifically when the osteotome is not tapered, expect microfracture like this we see in histology. Rodrigo Niva and his team compared between osteodensification, 6 weeks of healing, and osteotome in a large animal. And we showed in a large animal, due to the bone fracture you get delayed healing that you don't see with osteodensification. So the key for us truly to understand the difference, that osteodensification is not bone condensation, and I'll explain more. Bone condensation, as we knew it, related to a hammered osteotome, is completely different concept than osteodensification. The second thing we did, all of us in soft bone, we drilled a small hole and we placed fat wedges, larger implant, aggressive threads implant. So we created a misfit and we put a wide diameter implant to gain stability, specifically in soft bone or posterior maxilla. In my opinion, this model creates a lot of stress right where we do not need it, at the crest, and that's where the cortical bone is. So we create a large amount of stress, we ended up with crestal bone loss. So the model is not because of the implant design creating crestal bone loss. Every time we create a misfit or downsize the osteotomy and squeeze cortical bone, we'll end up with a bone loss. Great study by Paulo Coelho team here, published in 2014, showed that undersizing did not improve bone volume and did not improve the mechanical strength of that procedure. So did not improve the pull-out testing or the torque value, even when we downsized by 25%. So why bone is different? We all understand. Bone is not wood. Please remember that. Bone is a living tissue, is a viscoelastic tissue. The magic in the trabecular bone is its collagen contact. What does it mean for a material to be viscoelastic? It's very important. It is basically a material that very sensitive to the time of load, to the rate of load. When we shock it with a hammer, it's going to stiffen up. When it stiffen up, the chance of micro crack is higher. But drilling by itself is with the chatter will increase stiffness, therefore will increase the microfracture possibility. So bone is mechanically and structurally changing when we drill in it. So if we don't have the enough amount of bone, as you see here, for us to drill into it, we'll end up with dehiscence like this. The reason mainly is the following, is the chatter of the drill bit. Because we have, all of us, look at this, we have two mediums. We have a moving target that the viscoelastic tissue. It will move underneath the drill bit. And we have the barbaric drill bit that chatters. Look at your drill bits, ladies and gentlemen, in your drilling kits. They're truly designed, the same structure of a drill bit you buy from a hardware store with extra expensive price tag. That's basically it. So when that drill bit doesn't have the integrity and will chatter in that viscoelastic material, it will tend always to create a hole larger than the intended diameter we need. So if we don't have the enough amount of bone here, we all ended up with dehiscence like you see. So what's difference about bone from wood or aluminum or plaster? Bone is a plastic tissue. It has a pretty wide zone of deformation. But we need to understand how to enhance its plasticity. Two things. We need to apply time when we are mechanically stressing the bone, and we need to preserve collagen. So we need to apply a time-dependent stress. Stress is force. To have time-dependent strain. Strain is the change due to the force. But we need to preserve collagen, and we need to make the tissue wet. So irrigation and wettability is very important. Second classic. When we preserve bone, we shorten the healing time. It's very important for us to understand that. So when surgery extract enough bone to let strain in the remaining bone to reach or exceed the bone microdamage threshold, bone remodeling unit needs at least 3 months to repair the damage. So the more we extract bone, the more we have to wait for healing. Classic 2, we all understand that when we expose the bone matrix, we enhance osteoblast proliferation. That's why all of our implant has a rough surface. That rough surface will scratch the matrix and enhance osteoblast activity. We all know as well as when we increase collagen matrix density, we enhance vascular proliferation as you see here. So if we preserve the collagen, we enhance bone strength. When we preserve bone, we can enhance its strength, we can enhance its healing. And therefore, it's not due not only to the implant stability, to the fact that we preserve the tissue. So let's rethink bone instrumentation. We have these 4 patients. We used really to enjoy the second picture here on the left, because it's a cortical bone, high stability. That's the original Bronnemark model in the lower symphysis. But now we know very well, the more trabecular bone we have, the better the healing is. But how we can basically have the tools to help us, number one, diagnose, which we have that, and to help us understand what's the advantage of having a trabecular bone versus cortical bone, and the advantage of instrumenting trabecular bone to enhance implant stability. So from there, we develop this tool. We call them densifying burrs. So these densifying burrs are designed specifically to create what we call a hydrodynamic wave, to create hydraulics. This hydraulics is sort of like, will create a tornado in a bottle. So this will allow me as a surgeon, even in soft bone, to have this haptic feedback that will let me be absolute in control of the operation. Many of us have a lot of times we used a drill bit in a soft bone and we get sunk in. We have no control. With the densifying burr, because of the irrigation, the hydraulics, it will create sort of what we call a tornado in a bottle. So every pressure point you put in there, you get an equal reverse reaction force. So that's where the haptic feedback and the precision and control will come in. The second thing we discovered by chance, it's created the hydraulics due to the irrigation and the collagen material and the bone that's grind of its tip. If we take a regular drill bit or anything in the market that claim to be a reamer to run in reverse, all what it does, if you run in reverse, it will basically burn the tissue. It's not designed to produce the hydraulic wave. As you see in this experiment, we took a collagen material, we run a regular drill bit in reverse, and we saw the following. When we took the densifying burrs and run it in reverse in a collagen material to see what will go on, what will happen with this, and that's what we discovered. It produced basically a hydraulic wave, as you see here, ahead of it. And that's what helped us in the crystal sinus lift procedure. We went on and we changed the tip. After Dr. Nilsson Pinto shows this experiment, we changed the tip. So even if we touch the Schneiderian membrane up to 3 to 5 millimeter with it, it will not cut it. Clinically, the maximum entry in the sinus with this is 3 millimeter. Please remember that. We'll go over it here soon. So the second thing is, because the burr grind bone and centrifuged back into the trabecular space, it's create what we call a compaction autografting, as you see here. So that bone there is a space for it to go, which is the trabecular space. It shows the effect in the tibia and the vertebra. It showed the same effect in the mandible. It showed the same effect in the maxilla. So now we understand it's a reproducible procedure. It is reproducible effect as long as we have a trabecular bone. And we even look to see in a real patient, when we do osseodensification, how long it will take for the vascularity, for blood supplies to and this is an experiment done by Dr. Nelson Pinto, 40x endoscopy in a human maxilla. Within seconds, you see the blood supply and the rate that's happened into that site. Please remember, trabecular bone is the most highly vascularized tissue in our body. We will not be able to cut its blood supply. Please also remember, when we enhance collagen density, we will enhance the vascularization of the tissue, revascularization of the tissue, and enhance its blood supply by result. And the burrs are basically, they can be used in clockwise or counterclockwise. If I am dealing with cortical bone, I use it in clockwise and will become a cutter. It's smooth cutter, as you see. And I use it in the mandible more than 50% of the time in clockwise mode. And when I have a soft bone in the maxilla, or I'm using ridge expansion, or I'm using crystal sinus lift, I tend to use it in counterclockwise. The key to osseodensification is bone preservation and not bone removal. It's very important. And we truly validated this concept on different level. We validated biomechanically, histologically, and clinically. So let's look at our biomechanical data. We looked at the heat generation, and we found out it's within the natural limit of the healing process. And we looked at what's the appropriate speed for us to run it with the least amount of force and torque. 1100 RPM was the appropriate speed to produce the least amount of force and torque into this operation. So this is what we get between a hole done by bone preservation osseodensification versus a hole done by extraction drilling using the exact same burr size versus standard drilling. We noticed these two holes were produced by the exact same burr. This hole, the burr run in counterclockwise. This hole, the densifying burr running clockwise. So why this hole is smaller than this? Because we learned later, when we preserve the bone and autograft, compact autografting into the trabecula, it creates what we call a spring back effect. And that spring back effect, as you see it here, will create a better bone to implant contact, regardless of the softness of the trabecular bone that in the surrounding area. So all what we're doing is, rather than extracting bone and feed it to our suction machine, we're preserving it and we put it back where it's mattered the most, next to the implant thread. And as you see in trabecular bone, this bone autografting goes right into the trabecular space. It's very important for that tissue to find space for it in the trabecula to enhance the healing. And we measured that spring back effect. It's about 0.4 to 0.7 millimeter. So regardless of not downsizing the osteotomy, from there, we came up with a recommendation. There is no need to downsize your osteotomy using the densifying burrs, because they will produce bone adaptation that will allow us a better implant stability. And that's the number one mistake that we all do, because we're used to downsizing osteotomy in soft bone to create a misfit. And then we put a fat wedges into the small osteotomy. Sometimes it works, sometimes it doesn't work. And we all understand that, we all know that. It's all based on the adaptation of the tissue. But if we create an osteotomy that's pretty close to the implant diameter, then allow the bone to spring back into the implant rather than the implant compress the bone. That is the future, and that's where we proved. We proved you'll get a better stability by adaptation rather than compression, and you get a better healing. And this is what published in 2017, Dr. Meyer and myself. Please refer to that study. And there we defined osseodensification as a time-dependent low plastic deformation of trabecular bone. It works very well in trabecular bone. It doesn't work in cortical bone, and it relies on hydrodynamic bone instrumentation. So we preserve the tissue and we allow it to spring back into the center. So any claim for osseodensification by any other tools, we need to look into it. Dr. Raul Bravo out of Chile looked into other claims to osseodensification. Basically, a lot of people start looking into reamers that they can use, as you see here, that will run it in reverse to create osseodensification. As long as a tool will extract bone, as you see here, even if run in reverse, it will not produce osseodensification. It will not produce the halo that you see basically that produced with the densifying burrs. So it's very important for us to understand. It seems like I am frozen here on my. Can we take a second, please? It seems like I'm frozen. My screen is frozen for.
Okay, take your time, doctor.
Yes. I can't. I'm frozen. So I'm gonna shut down and get back to you guys. Give me about 1 to 2 minutes, please.
We'll get back to you soon after just a couple of minutes. Some technical issue, you know, with the overloaded and the Zoom technology and online conferences. Maybe the server is burning out. Dr. Salah, are you there?
Waiting for Dr. Salah. We're
Yes.
gonna resend back the message of the Hemophilia Day. All people asking about the World Hemophilia Day. This is an invitation of Dr. Zikra and the Saudi Dental Association. Anyone interested in joining the World Hemophilia celebration, they can capture the screen and take the link down. So here we see the message of the Saudi Dental Association about the hemophilia, and we want all of you to join this celebration during the COVID-19. Dr. Salah, are you back with us? Dr. Salah?
Not yet, still.
Still, okay.
I think the connection with the Zoom now.
Yeah, you can imagine, for example, now we have like 2,400 attendees on the Zoom platform only, and more than 10,000.
Only in Saudi Arabia. Imagine other countries worldwide.
Yes, I can check on Facebook live streaming. We have more than 10,000 seeing this live. So you can see Dr. Huwais in Michigan, you in Saudi Arabia, me in Jordan. It's so complicated. It's a new technology. So all of this, yes.
Maybe the line is frozen because he said too much snow going on.
It's snowing in Michigan, yes, and too much information in his presentation. So I think this
Mashallah, yeah.
loaded.
Lots of things to remember.
We're back
Okay.
here, ladies and gentlemen. How do I
Oh,
share?
thank you. Yes.
Okay, you can go back,
Welcome back,
Dr. Salah.
You could share your screen now.
Yeah. Here's my screen. We're back where we stopped.
Thank
Are we
you.
good?
Yes, we are. So go ahead.
Excellent. Our apologies. I think we're the snow causes everything. So basically, as you see here, the claim for osseodensification has to absolutely be combined.
Dr. Salah, you need to share the screen.
I'm sorry?
You need to share the screen.
Okay, can you help me, guys? I thought I did. Okay. It's better now? Is it good?
Yes, we see your desktop.
Do you see my screen or not?
Yes. Okay, now,
great.
yes, perfect.
Okay, great.
Thank you.
So what's really the most important thing is to understand that it's not about running a tool in reverse. It's running a tool that's designed to be run in reverse to preserve bone and without extracting it. And then we looked at the histological basically model, and we proved that basically what we do is we preserve bone and put it back in the trabecular right next to the implant thread, regardless of the bone density. Here's a study done Paolo Teresi, where we took a 5mm ridge, expanded to put a 5mm implant. So as long as we have trabecular bone in the center with thin cortical layer, we will be able to expand the ridge and put the implant, and that was healing in about 12 weeks. Another study, we looked at 6 weeks healing, and as you see here, it will enhances the implant stability, the counterclockwise, and will put bone right next to the thread, will enhance the implant, or it will enhance the osseointegration of that specific implant, and this is a large animal histology. Versus regular drilling at 3 weeks, the body's still trying to get to the implant, versus when we do preserve the bone and put it right next to this thread, healing become more optimized. And then we look at machine versus rough surface implant. And we found with machine rough surface implant, when we preserve the bone, the surface was not the only sole factor in enhanced bone to implant contact. I'm not advocating for smooth surface implant. What I'm saying is maybe the implant surface roughness doesn't need to be too rough. Maybe a slight roughness, or for us to get smarter on how much roughness we can adapt to our surfaces, as long as we preserve bone, we're still gonna have an optimized bone to implant contact as we see here. That's very important for us later on where we're dealing with perioimplantitis. Why we need pretty rough surface implant close to the soft tissue? Why we need the rough surface implant that's all the way to basically to the occlusal level of that implant? Why don't we have a hybrid implant where we have a smooth surface at the coronal third and rough surface at the 2 apical third? Maybe if perioimplantitis will hit that implant, we'll be able for us to maintain it better. So we stand proud with our team. After 33 years, we're bringing another element to osseointegration, which is bone instrumentation. It's very important. Here's our main study, 253 implants in 184 patients. It's a multi-center study where we went in and we used different design implant, and we measure insertion torque, implant primary mechanical stability of surgery, and we measured basically the ISQ reading over the first 6 weeks of the healing of that implant. And we followed these cases up to 65 months. It showed 97.2 success rate. They did not change the overall success rate of the implant. What it really changes the stability of that implant during the healing process. So basically, we placed the implant, we measured insertion torque, we measure ISQ over 6 weeks, and we measure reverse torque before we deliver the restoration. We can take a tooth out, graft the socket. I come back usually in about 6 to 8 weeks, preserve the tissue, densify it, place the implant with good stability, And then we basically measure this ISQ reading over 6 weeks period during the healing. This case was restored at 10 weeks, and this is 1 year follow-up. We all know that according to the literature, if the implant plays 40 Newton and centimeter as a mechanical stability day of surgery, and we get an ISQ reading over the time of the healing that's 68 and above, that implant is indicated for loading. Please also remember, ISQ reading, it doesn't mean anything as one-time measurement. It's designed to be a measurement over the healing period of the tissue. I see a lot of studies, bench studies, where they use a rib, like a cow rib or porcine tibia, where they measure the ISQ as one-time measurement and to reach conclusion about the healing process or the implant stability. Please remember, ISQ reading as one-time measurement doesn't mean anything. It's designed to be measured over the early weeks of the healing. Here's another case where we took a lower site, we expand the site due to quite amount of trabecular bone in it. As you see, if we have the minimum amount of trabecular bone, we can expand the thin cortex out, and we were able to take a 4 millimeter site and produce 5 millimeter osteotomy. We make the bone plastic. Trabecular bone is plastic tissue. When we preserve it, we enhance its plasticity and we enhance its healing. So when we push the envelope here and we wanted to place a 6 millimeter implant in a 4 millimeter site, the tissue failed. So please remember the rule, +1. You cannot be placing an implant of 6 millimeter in a 4 millimeter ridge when you start with ridge expansion. The maximum implant you could put a 4 millimeter ridge, maybe 4.5 millimeter up to 5 millimeter, +1 rule. So there is a limitation even to bone plasticity with these instrumentation. You could take 3 millimeter implant, 3.5 millimeter implant, put it in 3 millimeter ridge to initial ridge, 4.5, 5, and 4 millimeter ridge, 5.5, 6, and 5 millimeter ridge. Remember, this has changed the minimum amount of ridge width we needed to place an implant. Historically, we needed a minimum 7 millimeter ridge to place a 3.5 millimeter implant. That's completely changed with bone preservation and plasticity as we see it here. So this is basically a case, 5 weeks restoration. This is 1 year follow-up. This is 2 years, 3 years follow-up. So we looked at this data. All the implant placed with a decent insertion torque, as well as the ISQ reading started high and stayed high. And that was published as an abstract at the AAO meeting and will be published soon in the literature. We took a second study. We basically compared between standard drilling and osseodensification in the same patient in the same quadrant as we see here. In our patient, distal implant will be basically, we're going to do a sinus augmentation, at the same time place an implant. The middle implant went with osseodensification as well. And the mesial implant went with standard drilling, where we extracted the bone and we placed an implant. And that's the difference we saw in these patients. When we preserve the bone, we enhance not only the primary stability, we enhance the secondary stability measured by ISQ reading. It's truly not solely about the concept is bone preservation. All what we have for you is a tool that will allow bone predictably to be preserved and enhance the site. If you do not want to use the densifying burrs, it's no problem, but make sure, please, when you drill into the bone, do not sacrifice that bone that comes out in your drill bit. Preserve it, put it back in the site before you put your implants in. We prove to you on different level, biomechanically, histologically, clinically, that bone preservation will enhance and will optimize the implant procedure. This is 16 weeks restoration. This is 2 years follow-up and 4 years follow-up. So the key is, the standard drilling, as you see here, really jeopardized the implant primary stability. When we preserve the bone, we have a better implant stability and better secondary stability. That was published in 2014, now become a multi-center study around the world that will include 232 patients, 460 implant, different implant design. And here's the preliminary result that we see. When we preserve the bone, we enhance implant primary stability, predictably, reproducibly, regardless of the implant design, regardless of the implant, if it's magic bullet or not. And when we look at the healing process through measuring ISQ, we always start high with the secondary stability, and we stay high when we preserve bone versus when we extract bone. So it's a key element for us to understand. When we preserve bone and instrument it in a time-dependent stress, will enhance its plasticity, and that will help us in the ridge expansion. So here we took 21 patients, we placed 28 implants, and we measure the crest, we measure width of the crest, and we measure width to 10 millimeter from the crest, before instrumentation and after instrumentation. And then we calculate the data. We got the most amount of expansion in the narrowest ridge, that's 3 to 4 millimeter ridge, versus when the ridge was 10 to 11 millimeter, we got 0 expansion. The reason is we had enough trabecular bone in that core that absorbed that hydraulic wave. When the bone was 4 millimeter, it was expanded outwardly and give us basically about a 70% expansion. It's become closer to 6 and 7 millimeter wide bone. And this study was published, you could access it, was published in August 2019. And from there, we start generating protocols, because the key to all of us, ladies and gentlemen, is the following. Whatever technology, new technology present to us, it must be predictably reproducible in every trained hands. If it's not a medical procedure. It's just a poetry. It's just a poetry for us to enjoy, listen to, and walk away. So any new concept, any new technology must become predictably reproducible in every trained hands. For this, we introduced protocols in the literature for plastic ridge expansion. And here's what we need. We need a minimum of triangle-shaped ridge, and we need a minimum of 2 millimeter of trabecular bone in the core with 1-to-1 ratio. What that's will give us is a 2 millimeter of trabecular bone in the core and 1 millimeter in the buccal, 1 millimeter in the lingual. Your ideal ridge for plastic ridge expansion is a 4 millimeter ridge. Half of it is trabecular bone. How about if I don't have that 4 millimeter ridge, I have a 3 millimeter ridge. As long as it has trabecular bone with triangle shape, you'll be able to expand the crest to match the base. But if you have the crest and the base to be an equal type of width, like you see on the right side of the screen, you will not be able to plastically expand this site. So this site will become a site for guided bone regeneration. This site can become for a plastic ridge expansion using osseodensification. So here's the protocol. It's very important. 2 millimeter of trabecular bone in the core, 1-to-1 ratio is very important. No need to create a vertical cuts. We need to use the burrs in smaller increments, meaning do not go from 2 to 3, 3 to 4, 4 to 5. You'll shock the tissue. We need to go from 2 to 2.3, for example, before we introduce the 3. Why? Because time is very important to create plasticity. We need to oversize the osteotomy and allow the bone to spring back to the center. But again, this procedure only will allow you to push the tissue outside of the way to put the implants in, to preserve it and plastically expand it. But if you don't have the enough amount of bone, you need a 2 millimeter of bone thickness and 2 millimeter of soft tissue thickness. Without that, we will not be able to save these implants long-term. For long-term success, we need tissue thickness. Rich plasticity or creating plasticity or osseodensification only will allow you to expand the bone enough to place an implant within autogenous bone walls. Then we have to produce the thickness by using a guided bone regeneration procedure. Here's another example. Here's basically a triangle-shaped bridge, but it's less than 4 millimeter. So with this, we create a trough. This trough will allow us to enhance the plasticity of the tissue. Now the implant goes into within autogenous bone envelope We place the implant with good stability. We add now an allograft as a veneer graft, and we add a membrane. We close the case to come back. Biology is the same. There is no change in the biological principles. All what we're doing is we are taking advantage of trabecular bone plasticity to instrument the site in a better way, to allow us to preserve and optimize the outcome that we see. Here's the case, as you see, was restored. Here's 2 years follow-up and 3 years follow-up. And here's the protocol. So we published these protocols. There's 6 of them today, and there's 2 more in the pipeline for the IDR technique and the socket shield technique as well. So if you have a site like this, where you don't have a triangle-shaped bridge, the densifying burrs is not gonna help you. Nothing will help you except the GPR. There is not enough tissue for us to create the expansion. Second, guided expansion graft. This is basically a 2-stage approach. If we open up a site like this, and the site is a triangle-shaped bridge, we can expand. If you're expanding and you start seeing this, where the tissue start basically, the strain become too much in the tissue, please do not place titanium. In this instance, please graft the socket, graft outside the socket, achieve an optimized closure, as you see here, and come back later in 12 weeks. This is before and after. No bone block, no screws. Basically, all what we've done, change the topography of the defect from one wall defect to contained defect to a socket. We graft inside the socket, we expose the bone matrix, we graft outside the socket, put a membrane and close it. Nothing different, the biology is the same. We just change the topography of the defect in a favorable way to enhance the outcome of the healing. Then we go in, we preserve the bone, we enhance its plasticity, we densify the site, and we place an implant with good stability. Look at the amount of bone that's available on the buccal of the implant. Remember, we need 2 millimeters of bone around the buccal of the implant and 2 millimeters of soft tissue for this to become a long-term success. And this is where we started, and that's where we ended up. So it's the same principles. We're gonna basically enhance bone width, but we're coming in the middle of the healing cascade of that site, and we introduce titanium. Titanium is a highly vascular, highly osteoconductive surface, and let everybody heal together at the end. And here's the protocol. It's available for you to print and study. The same thing, immediate implant placement. Please go ahead and prepare the site with densifying burrs and running in reverse to prepare the apical third of that socket. But before you place an implant, we're gonna put an allograft that hydrated at least for 20 minutes. Very well hydrated, an allograft that's a cancellous bone. Then we're gonna densify this allograft against the walls using the densifying burr in slow speed, 200 RPM with no irrigation. This will allow the implant completely to go into with a better stability. But please remember, the main stability of that implant is coming from the apical third of that socket. It's not coming from the densified graft that you put in there. If you're gonna rely only the densifying graft in the socket, the implant and the graft will come out a week later. The implant must be anchored and have its primary stability in the apical of that socket. What this will do is enhance basically for us the time to get to the restoration as you see here. And this is the protocol and we published it. Implant stability must be achieved through the apical engagement, not through the compacted graft. And we could do the same thing in the septum. If you have a septum, you could expand the septum, enhance its plasticity. Then we put the implant right in the septum, graft around that implant, seal the socket with healing abutment. In this case for Dr. Emil Verben, 8 weeks restoration. This is 4 years follow-up. And that's basically the protocol for it. And of course, the most popular use of the densifying burrs is the crystal sinus lift. Some people call it the Densa lift. Some people call it Osseodensification lift. The key is the following. We learned there is a hydraulic wave created by the burr. If this is coupled with irrigation and bleeding as well as grounded bone substance, This will allow the lift of the Schneiderian membrane and deposit of autogenous bone underneath it, up to 3 millimeter. The maximum you get with this autogenous bone autografting is 3 millimeter lift. Please remember that. If you need more than 3 millimeter, you need to use an allograft. Here's a case, 8 weeks restoration, 1 year follow-up. And we created a protocol basically to teach that. It's available for you to see or to study. For example, here's an 8 millimeter case. Pilot goes 1 millimeter below the floor. We enter with specific width of a densifer, like of densifying burr 3.0, lift the membrane, put autogenous bone underneath it, and put the implant, and we are done. You could do the same thing with basically an oblique shape, measure the shortest distance to the sinus, and that's become your working depth. As long as you do not enter in the sinus maximum more than 3 millimeter beyond of that working depth, you will be able to lift that Schneiderian membrane and deposit autogenous bone. And this is protocol 1 of the Osseodensification sinus lift protocol. Protocol 2, in a site that has 4 to 5 millimeter, please remember, the shorter distance to the sinus, the wider the ridge need to be, because you need to shave more bone off the walls and push with the hydraulics to lift the membrane and put this autogenous bone in. And look where we skip. We basically skip the pilot, because the pilot is the highest risk for a perforation in this type of situation. And the same thing, we're gonna go ahead. Here's another trick. When you do osseodensification crustal lift, please make sure don't do crustal shape incision. Go more into the palate, because if you perf here, you'll be able to still close and have a primary closer to come back later, finish the procedure if you wish. But this is what happens. The burr will shave bone off the walls and put it back into the site after lifting the membrane. Here, the preparation all finished. We push enough autogenous bone up to 3 millimeter. Now we put a well-hydrated and allograft that's mainly cancellous, an allograft, and we push it with the same densifying burrs in slow speed, in specific direction, specific way to put this allograft into the sinus as you see here. Here's a good stability. Here's the sinus graft material as you see it. And there's 12 weeks healing, this 16 weeks restoration. This is 3 years follow-up. This is 4 years follow-up. And this is 5 years follow-up of the same case. Remember, we started here. Allograft or autogenous bone will remodel to resemble the host bone. And this is protocol 3 as is actually protocol 2 for osseodensification with the sinus lift. How about protocol 3, 2 to 3 millimeter? Minimum bone width is needed at 7 millimeter, so we need more bone width. We skip the pilot, we skip the narrower burr. So we enter the sinus with a wider burr. It's very important. The shallower you are into the sinus, the wider your entry need to be. It's all biomechanics. Here's a 2 millimeter case. We enter with a wider burr. Please look after you enter the sinus. If you will see the Schneiderian membrane with some bone on top of it. If you see black hole, you perfed. And you have 3 options. Close it and come back in 4 to 6 weeks. I usually come back 6 to 8 weeks actually to redo the procedure, or use a shorter implant, or use a lateral window. We'll talk more about the rate of perforation and how you can deal with. Here's implant went in with good stability. Here's the type of grafting that we achieved. So this is started at 2 millimeter. We place a 10 millimeter implant based on that crystal lift. And of course, this procedure, it's reproducible. You see, a lot of people are sharing their results, their good success with this. As long as you follow the protocol, you reproduce the results. This is Dr. Schwimmer. There's another case of mine, 3 millimeter, where I lifted, placed a 10 millimeter implant. Here's another case of Dr. Scott Lawson in the United States. Another case for Dr. Schwimmer. This is 4 years follow-up. If you see a chimney effect in your X-ray, that's a perf. It needs to be a really gradual increase, like speed bump into the sinus. This is a perf. This is actually a tremendous large perf. This is what you need to see. Would that implant work? It depends how much of that implant are into this graft, into the perf. If the majority of the implant in actually the crystal bone height of the host, that implant may heal and the sinus may heal with it. But if the majority of that implant is beyond the perf sitting in the sinus, it's not gonna work. How about in multiple lift? Please always start in the mesial, lift the mesial first, then lift the distal and place the implant. Here's an example of case, 14 weeks, 2-year follow-up, 4 years follow-up. Here's our study. Our original study, we placed 261 implants in 222 cases or sinus lifts. And we followed this for 5 years. And we look at, in that study, we looked mainly at the implant success rate in this procedure. It was a 97% success rate. We did not record in this study the perforation. We did not measure it as a variable because we were measuring the implant success rate. So we looked back and we're conducting a multi-center study. It will be published soon that look at Osseodensification sinus perforation. And it's between about 8 to 12%. And you see it, it's gonna look like a black hole as you see here. And these perforation happened in less crystal bone height. So the shallower you are in the sinus, the higher your chance to, the higher the risk of perforation. Flapless surgery will create more perforation. You need to expose the bone, even with the mini flap, so you can hydrate the tissue and create the hydraulic wave. Smaller size burr sequencing, meaning if you go from 2 millimeter burr to 2.3 millimeter burr before you introduce number 3 burr, you'll have a more chance of perforation. You need to increase your burr size by a full increment increase. And that will allow you a better lift and less chance of perforations. At the end, please, traditional guided surgery, it's a high risk for failure because traditional guided surgery is a drill press, will allow you only one path in and one path out. So the chance for you to luxate and create the hydraulic is not there. Avoid densifying xenograft. Please remember, xenograft will regenerate bulk, but it will not regenerate structure. It will regenerate a lot of bulk, but it's a destructured bulk. And without a trabecular bone regenerated structure, there is less plasticity in the tissue. Do not use the Densibur in counterclockwise in cortical bone. Do not do osteodensification cortical bone. Use the Densibur in the densifying burr in clockwise, then reverse out. Do not downsize your osteotomy. In the maxilla, the site or the osteotomy is only maximum 0.5 to 0.7 millimeters smaller than the implant. And in the mandible is about 0.2 to 0.3 millimeters smaller. It's clinically insignificant, almost equal in the mandible. We oversize the osteotomy in ridge expansion cases. And please, in ridge expansion cases, you still need to do a veneer grafting with bone and soft tissue to enhance tissue thickness. In subcrystal sinus lift, if you have a ridge that's less than 4 millimeter width, it's a high risk for membrane perforation. The width is needed to create the hydraulics and to allow you to shave bone off the walls and push the Schneider membrane and deposit bone underneath it. Here's an example of complications. Here's one of the doctors, took basically a mandible, over-densify a mandible, basically a cortical bone, placed the implant. That implant will come out in 3 weeks. Please do not densify cortical bone. There is no space for your autografting to go into dense bone. Then the healing will change and the healing will be jeopardized. The more you densify cortical bone, the more your cases will fail. Please stay away from cortical bone densification. In cortical bone, in dense bone, use the burden forward and reverse out. This case was even basically a guided case, but the guided was too much into the lingual, so the doctor densified that lingual cortical wall, and allow the implant to fail. Here's what the perforation will look like. Why does perforation happen? Because the doctor attempted here to lift the membrane through the septum. What's the width of the septum? Is it 4 millimeter or less than 4 millimeter? If it's less than 4 millimeter ridge, you will have a perforation. You need an adequate width, minimum 4 millimeter, for us to be able to lift the membrane and deposit autogenous bone safely. In this case, he chose to basically, wisely so, to close the case completely, let that area heal, and come back in 8 weeks to redo the procedure. The last one, the last case is my case, where basically we don't have the enough amount of bone width to do the crystal lift. So we went to lateral window, empty all that bone, then basically do a ridge expansion, stress the tissue, and place an implant all at the same time. I overstrained the tissue. This procedure will make you overconfident. Please do not be overconfident. Biology is biology. So here I overstrain the tissue. I empty all that bone for the lateral window, place the implant. Let me ask you this. What is the titanium to actually autogenous bone ratio in this site? We have more titanium. I have more bone out of the bottle than the actual autogenous bone to feed all of this. This case failed and failed miserably. Please remember, biology dictates. All what we have is the ability for you to have a gentler and more reproducible instrumentation to preserve the bone and enhance the site. It's all about moving the bone and not removing it. Thank you very much.
Thank you, Dr. Hawais, for the nice presentations. Just quick couple of questions. Do you use irrigation all the time with the
Absolutely.
drilling?
Yes, absolutely. Irrigation is key. Remember, there is no bone plasticity without irrigation. And the irrigation, it has to come from the top of the burr, not the side of the burr. So your irrigation need to be in a handpiece, that the irrigation clumped in the handpiece and come as a rotation. So if your irrigation with the syringe that's coming only in the middle of the burr, it will not gonna help you. Remember, the burr is designed to produce a hydraulics. The irrigation at the top is very important. And it has to be almost 70% irrigation to be able to to achieve the reproducible success.
Great. Another question is, how frequent you will change the drills? I mean, how many osteotomies you want to change them?
We really tested that. It's between 12 to 20 osteotomies. After that, based on what type of bone you use it with. If you use it mainly in a soft bone, they will last for 20 osteotomies. If you use it in the ridge expansion that you deal sometimes with less than soft bone, they will tend to dull out faster. And the dulling will happen in the tip, and everything is in the tip. When the tip becomes dull, they'll become a jackhammer, and that will produce a lot of stress, a lot of force on the tissue, and will not be good.
Thank you. Another last questions because of the time. Regarding the, do you recommend taking a CBCT for all the cases for Osseodensification to analyze the bone topography?
Very good question. In my practice, I think it's a clinician preference. CPCT is absolutely the best tool. And I use it all the time to assess for ridge expansion cases. If I have a case that I need a ridge expansion, I will always take a CPCT to assess the amount of trabecular bone in the core. I take a CPCT for my sinus lift cases. But if I have a straightforward case that you can tell clinically there's plenty of bone, I do not take a CPCT in every patient, no. I take him for the patient that will be able to either do a ridge expansion, the sinus lift cases, and to be able to learn more about the amount of trabecular bone versus cortical bone.
Thank you, Dr. Salah, for a great presentations. Thank you so much. On behalf of the scientific committee, we would like to present certificate appreciations. I hope you stay safe and stay warm in the cold weather. I miss Michigan. I went to school there. I missed it a lot. My sincere appreciation to all of you guys. Thank you.
This is what we're dealing with. Just to share with you, we have a lot of snow here in Michigan. There's about 3 inches on the ground, and you live here and you know what it's all about. Thank you for including me. You have a wonderful weekend. Please stay home, stay safe. Thank you.
Take care. Thank you. Appreciate it.
Thanks.
Our next speaker. So we'll go to the next speaker, and Prof. Boozer, inshallah, should be there. It's an honor and pleasure to present one of the well-known speaker worldwide, Prof. Danny Boozer. I cannot say anything. It's 400 publications, a lot of national, international conferences worldwide. Great to be with us this afternoon. Prof. Danny?
Yes.
Are you there?
The
screen is for you.
Yes. Do you hear me?
I hope you're fine. The screen is for you. You can start sharing, please.
Okay, let me see if that I have to press a button here, I guess. Yes.
At the bottom, share screen, yes.
Yes, okay. And now you can see my screen. Good.
Yes, it's all yours.
Okay. Thank you, my friends. What a pleasure to be part of this international online conference. Excellent idea. As we all know, we are living in a really harsh time everywhere. And I hope that the good thing coming out of that one will be a much better international collaboration between countries, religious areas and groups. And let's see. I give you my best greetings from Bern, my hometown in Switzerland. And before we start with the topic, I want to give you also an update how we are doing. You see, the coronavirus pandemic hit us mid-February, and we started to realize that it came mainly from Italy, the northern part of Italy. So we had the first restriction by our government on February 27th. And then the lockdown was then actually mandated on Monday, March 16th. Since then, the schools are closed, universities are closed, hospitals only for emergency treatment, restaurants, public transportation, the borders are closed, and we were asked to stay home and go for office home. So yesterday, actually, the government told us that we start to open again in 3 steps, and the first step will be on April 26th. That's in 10 days from now. And then also the dental offices go back to work, also the dental schools. So we start to go back slowly, but of course we all know this virus will keep us very busy for a long time to go. Now we have had a lot of infections. We are a very small country, 8 million people live here. But you can see that this really very strict reaction to the crisis really paid off. So the daily reported cases in Switzerland have now dropped significantly in the last couple of, let's say, 12 days. Also, the fatalities are going down, and also the hospitalizations is going down. You see, it was harsh. It's for sure. I stay in my house for 4 weeks now, and only go out from time to time for a ride with my bike, but no contact to anybody else. Okay, now what is the impact on dental education? You see, the congresses have been cancelled, some of them postponed. We know ITI World Symposium, for example, big one, was scheduled in May in Singapore, will be moved to 2021. A lot of international CE courses cancelled. I just had a conversation with Sasha Jovanovic. Nothing is going on except online. You see, it's very uncertain. We have master courses in Bern that have been postponed from June to fall, and we'll see if it works. And I think the positive side is that digital technology will gain a lot of strong momentum. You see, I'm also learning fast in the field of social media. Of course, with many of my postdocs and my young friends, I learned a lot. And I'm very active now with webinar lectures just to help out in many, many countries, like Saudi Arabia here, of course. We're going to do tomorrow a first Instagram live lecture that will be very interesting if that works, and so on. Okay, So I think social media will will gain momentum. We have a Facebook group for 3 years now. Almost 8,000 people are part of it, and we will increase our activities. This is a surgical Facebook group, also implant surgery, together with Vivian Chapuis, my success as chairman. Then, of course, we established actually an Instagram account last Monday for this Instagram, and you see how many people signed up. It's amazing. And I have learned that Instagram and Facebook are working very closely. So this has a lot of potential to really share knowledge through these areas. We also have a YouTube channel where we have video clips of our group to show surgical procedures and so on. So a lot of people have signed up there as well. And then, of course, we do CE courses at university, but we'll see when we can start to do them again. I will show at the end. Now, what is the topic today? The topic is a topic I have presented multiple times now in the last couple of years. We talk about failure modes of dental implants. And of course, very important, how to prevent them. Now, 50 minutes, we're not allowed to go into all these details, but I give you a very nice overview, what kind of failure modes you will see. And the most important message is how to prevent. And when we look back, you see, I'm in that field now for 35 years, hard to believe. I did my first implant surgeries in the mid-80s. And I would say since about the millennium change, we are in a phase of routine application. Of course, we treat many, many more patients since 2000. We have seen a strong shift to partial dentures patients. We have made a lot of progress with bone augmentation procedures. We treat many, many baby boomers. So the average age of our patient pool in Bern is now 63, sometimes 64 years. The implants are very predictable, and aesthetic outcomes have been improved significantly. So these are all positive aspects in the field of implant therapy. When you look at the long-term cases, I show you only 4 here. You see in the field of aesthetics. You see when we start on the right side, this is from 92. The first case I treated with Professor Belzer with a solid screw, and you see an excellent outcome, excellent home care. And then late in the 90s and so on, up to 10 years, the most recent one on the left side, this is a contour augmentation case. I will show you that case later on. But these, of course, are only case reports, but they show that implants can last for many, many years. You see, I'm now retired. When I get 80, hopefully, that's in 15 years, I'm gonna see patients that have implants for 50 years. I'm absolutely convinced we're going to see that. Implants lasting 40 years, 50 years when these are young patients. So this is excellent from that point of view. When we look at the studies we have done, you can see that they're very predictable. And the predictability have been documented in Bern with all these papers you see here. I show you only 3 of them. Those are 10-year studies. Soon we're going to have a 20-year examination of one of the patient groups here, cohorts. And you can see that actually the success and survival rates are in the high 90s, 95, 98%. You have to stick to the protocols, and you need to have a patient with a good home care, good maintenance care program, and then you can go for long-term success. So these are all the positive aspects. What are the negative aspects? I see more and more patients coming to our department with complications or failures. And I hear that all over the place. When you go to the congresses like me, and then you meet all the old friends, you see Sasha and all the others. And at the dinner table, then they talk about their current experiences, and they all have the same observation. The number of complications is rising. The number of disaster cases is increasing. And this is a big concern for all of us, because when too many complications occur, they will destroy the good reputation of implant dentistry. And I can promise you then time will come that then the politicians will start to take action and will tell us that implant dentistry doesn't work, you see. I'm absolutely sure that this is not the case, but what I see is the weakness in the treatment quality of some colleagues. So when we talk about the failure modes, we will talk about these 4 failure modes. You see from the left, implant failures by infection, so peri-implantitis. Then the second one would be aesthetic failures, mainly by mucosal recessions. The third one is by, implant failures by disintegration. That means an implant that gets mobile without any sign of infection. And then the last one would be implant fractures. And when you analyze these failures or complications, and then when you analyze then the factors that are important, and now I'm talking just about the surgical factors that are important to influence the treatment outcome. You could also say these are the success factors for successful outcomes, or the key factors. Then we have been using since 2008 from a treatment guide of ITI with Stephen Chen, these 4 circles. So we have here the implant surgeon, we have the patient, we have the surgical approach, and we have the biomaterials. And when you look at all these complications, then you can identify very quickly that in one of these 4 factors, something went wrong. Something went wrong. And I have to say, you see, in my experience, in about 80% of the cases, something went wrong with the clinical performance of the clinicians. So many of these complications are inflicted at day of surgery by the surgical procedure. This is an honest examination, and I think we have to face the problem. We have a problem in the market because of that one. So when we look at these failures again, you see, then you can see how often are they. On the left side, peri-implantitis most often. Then quite often lately, aesthetic failures, then quite rarely implant disintegrations. And in my opinion, or my experience now lately, very, very rarely implant fractures. And I will go through these 4 failure modes now, and I start with the least frequent, as I start on the right side, also the fractures. So we talk about implant fractures. What are the risk factors to get an implant fracture? And then when you know the risk factors, you know how to avoid them. In my experience, and I've seen these fractures beginning of late 1990s, when 3.3 millimeter narrow diameter implants have been released to the market, we have seen a significant rate of fractures with CP titanium implants in the late 1990s and early 2000s. At that time, ITI came up with a recommendation to splint these implants to other implants to avoid these kind of fractures. So it was not recommended to use them as single standing. In our experience, the introduction of better materials, one of them is rock solid. You see that was around 2010. This really improved the situation to our advantage. So in my department or in our department, I have not seen one fracture of a rock solid implant in the past 10 years, you see. So this really is a big help. A second risk factor we have always to consider is bruxism. Bruxism can be very devastating, and in particular for small diameter implants, because then the anchorage in the bone is not the same to a standard or to a wide body diameter. So you have to be very careful with patients with parafunctional activity or heavy tooth wear. The third risk factor, this is the time. So you get these fractures not in the first year of function. It takes time to get these fatigue fractures. It's a material problem. So this normally occurs after 5 to 10 years or even longer. So these are all the risk factors we have. Now here you see this is this NNC rock solid implant that was introduced to the market about 10 years ago. This is an implant I love to use when we have borderline cases. Then we go for this implant. I have not seen one single fracture of an implant like this. I don't know if Straumann has seen them as a company, but in my experience, I did not see that actually. So this is a very nice way to avoid this kind of problem and so on. Another bruxism, I want to share this case with you. This is a patient that was treated in our department, was a bruxing patient, and what we figured out later on, heavily bruxism. And you see that he got actually a standard diameter implant, was restored with a crown and a distal cantilever. And it took him about 3 years to fracture that implant shoulder. This is very infrequent, but it should only show you that bruxism can be a problem, and therefore be very careful when you have patients with bruxism. Okay. Next group of complications or failures, disintegration. You see here the risk factor again is bruxism. Patients with parafunctional activity, you're going to be very careful. Second one is if the implant has an insufficient bone to implant anchoring surface. That can happen if you have a short implant, or you have a narrow diameter implant, or you put an implant in and the implant has no buccal wall at completion of treatment. So actually there is no osseointegration on the buccal aspect, and then the osseointegration is limited to the mesial and distal aspect and to the parietal aspect. So that is always at risk because many of these implants can get loose, disintegrated after 5, 8, 10, even longer years. The next point is depending on what kind of implant restoration is in the opposing arch. I learned the hard way in the last couple of years that if you have as an opposing arch, you see, also implant supported crowns or bridges. That means you have implant supported restorations biting on each other. This is an increased problem because when a patient has natural wear on the natural teeth, then they reduce the height of these natural teeth, but they don't reduce the height on the implant restorations. That means the contact on these implant restorations gets stronger and stronger. And when these occlusal adjustments are not made, then that is then a problem. And also here, the time is a risk factor as well. So these integrations are not seen very early. I have seen patients after 15 years. I have seen patients, I think I showed that to you, after 26 years. Also, this is also a point. I learned that we have to pay much more attention to the occlusion on these implants, in particular when you have implant bone and implant bone restoration chewing on each other. So when you analyze your patients, you see, then when you analyze the patient with all the risk factors associated with your patient, then among the dental risk factors is the bruxism. So you really have to analyze that. Even a patient is a bruxing patient, you have to select your implant accordingly. When I see that a patient has a lot of tooth wear, I try to put an implant in that is the strongest possible implant. That means large diameter, long implant, so a lot of anchoring surface. So the bone integration will be able to sustain the heavy functional load of this implant. So when we select implants, you see, today we primarily use titanium. We are not big fan of Zirconia implants, only on demand, and it's still less than 1% in our department. By the way, in our department, we place about 900 to 1,000 implants a year. So this is a big, high volume clinic. We go for screw type implants to provide good primary stability. And then we need proper dimensions. And this is based on prosthetic and anatomic considerations. So the diameter of the implant body and the diameter of the implant shoulder, but also the length of the implant. We also clearly prefer a micro rough surface, and we go for hydrophilicity, also hydrophilic micro rough surface, to achieve a faster and a better implant anchorage in bone. And we predominantly use Straumann implants, not exclusively. And when we go for a Straumann implant, then we use the selective implant surface, which is a hydrophilic surface. We have seen lately a lot of recommendations to go for short implants, and then we talk about 6 millimeters, sometimes even 4 millimeters. I want to give you a very strong recommendation here as a rule. Don't give up implant lengths if it's not needed. Also, you only go for shorter implants if there is an anatomic need for that. That it can be the nerve, of course, can be a lingual undercut, or can be the floor of the sinus. You don't want to go into sinus floor elevation procedures. When you go for short implants, then I have a strong emphasis that I always splint these short implants to other implants, with a few exceptions. I will come back to that, you see, because when you look at the literature, and these are 3 papers published recently, non-splinted 6 millimeter implants, then you see a much higher failure rate than what we normally see. When you look into this, the table here, then you can see that the survival rate at 5 years is between, you see, 85 and 90%, or the failure rate is 9 to 14% at 5 years. This is absolutely unacceptable from my point of view. So you're going to be very careful to use 6 millimeter implants if they cannot be splinted to other implants. So the last point is, again, what I mentioned before, is the occlusal loading. What do you have to expect? So what is the occlusal there? Are there signs of bruxism? What's your opposing arch? Is it an elderly patient with reduced bite force or not? So I'm willing to make a compromise on 6 millimeter non-splinted implants when these patients are old and when they are, let's say, 85 or so, or 82, then I don't want to do a sinus floor elevation procedure. And then, of course, then I use a 6 millimeter implant, non-splinted. I show you one case with this interesting observation. This is a case I treated many years back. You see, early 1990s, 2 implants splinted, 2 6 millimeter implants. Everything went fine. 2010, I did another implant in the maxilla in area 2.6 with an implant restoration. And then we did not see that. Slowly but surely this gap opened up. She was maintained in private office. And then after 26 years, she was biting on a heart, something hard in the food, and then had a pain, and then both implants were mobile. So that shows, you see, that this 10 millimeter implant in the maxilla was stronger than the 2 implants in the mandible. So this occlusion must be really considered very carefully. I think we have to pay much more attention on the occlusal adjustments. So this is the take-home message, you see. An opposing implant restoration and bruxism are both risk factors for this kind of failure, disintegration, and therefore the occlusion must be checked much more seriously during follow-up examinations than what we did probably 2, 3, 4 years ago, you see. So this is an important message as well. Okay, next one, aesthetic failures. Much more often than disintegrated implants. And here, the big problem is the malpositioning. I have treated with Professor Belson now roughly 100 failed cases, some horrible, horrible disaster cases coming from all over the place, from outside Switzerland, inside Switzerland. Most often it's a facial malposition. Can also be a misangulation. 20 years ago, often colleagues used oversized implants in the neck region, you see. That means 7 millimeter implants that lead then to this facial malposition. Another risk factor can be that there is unfavorable local bone anatomy at the implant placement. So actually then the patients have no facial bone wall, and then you see the recession of the mucosa. Not very often peri-implantitis that causes aesthetic failures. That's very rare in my experience. So these are the kind of disaster cases I refer to. You see, many of them we have treated, not all of them, and you can see the facial malpositioning is a big problem. Sometimes too many implants is a problem, you see. So these are all mistakes done by clinicians. Poor implant positioning, wrong number of implants selected, and so on. So here you see these analysis of the potential causes, 90+% aesthetic failures with this malpositioning. It's always a poor treatment quality involved of colleagues. So it's actually inflicted by clinicians. And the peri-implantitis is not really big in the aesthetic zone. So here you see this is from the Stewie Frome book on dental implant complications. I had the pleasure to write with Stephen Chen a chapter on this one. If you want to have the PDF of my lecture later on, then I can also send you then the PDF of this book chapter, because it's a very nice summary of the problem here. And this is the paper from an ITI consensus conference in 2004, because we came up at that time with this concept of comfort zone and danger zone. And the goal was clear. You see that we said that the implant shoulder should be located in the comfort zone, as in the green zone, mesiodistally, corona apically, and orofacially. When we go into these 3 dimensions, then of course you shouldn't place an implant shoulder too close to a natural tooth, because you need there some space for vascularity. Then you should not sink it too much apically, about 3 millimeters. It should not be in a coronal malposition, otherwise you see the metal. And then of course, orofacially, you have to put the implant shoulder about 1 to 1.5 millimeter to the palate, to develop then the emergence profile, and that really served us extremely well. So that's what you have to consider. Then we come to the last most prominent discussion now, that is peri-implantitis. Here we have a lot of risk factors, and some of them are very well documented. One is that we know that there are periodontal risk patients, either with non-treated periodontal disease or with a history of periodontal disease but treated. We know that these patients, that's about 7% of the population, have an increased risk for the development of peri-implantitis. Then we know medical risk factors. Untreated diabetes is one of them. Then smoking, big problem. In particular when they smoke more than 10 cigarettes per day, very well documented. Then a very important risk factor is an exposed micro-rough or even rough implant surface to the peri-implant sulcus. I will talk about that. That is my main concern. Then unfavorable local anatomy, also lack of peri-implant bone, lack of attached and keratinized mucosa. And last but not least, insufficient plaque control. Also poor oral hygiene or poor prosthetic design, which does not allow proper access for oral hygiene. It can also be cement, you see, because of cemented restorations. These can all be risk factors for the development of peri-implantitis. Here you see some cases. In Bern, we have not treated many of these cases. In this 10-year study I mentioned before, we had 3% biologic complications. In a 10-year study, more than 300 patients. But you see, when we get patients to treat, I always discuss the cases with Gianni Salvi from the perio department. And then we often decide what should be done. When you look at all these cases I've gotten from Gianni Salvi, then you see that the exposed micro-rough surface always is present. and sometimes big time. One case here is with cement remnants, but you see this is always exposed to implant surface. Look, this one was a patient I treated. You see the implant was placed, but the implant has no buccal wall at all. It's all exposed. So also this is a very significant risk factor from my point of view. Now, I have been involved in the development of micro rough surfaces. That was end of the 1980s and early 1990s, and that was already discussion then if this will increase then the susceptibility of implants. Because the Bronnemark type surface was a machine surface, and there the frequency of peri-implant pathology was not very often. So that is actually what we have seen. But of course, when we developed this micro rough surface, they were made to increase the anchorage in the bone to foster the healing of the peri-implant tissues. So micro rough surface exposed to the peri-implant sulcus is a risk factor for peri-implantitis, and you as a surgeon, you have to do everything to avoid such an exposure during surgery, and you have to consider the post-surgical bone remodeling during healing. That means when your implant surface is not exposed that day of surgery, this does not mean that it's then also not exposed 3 months later or 2 months later, because there most failures or mistakes are made by the surgeons. And that's what I want to focus on now. So when we look at this, you see, as a surgeon, you analyze your patient, and you have then all these risk factors involved. You see, you know what the patient has. Anatomy is most important. The anatomy is an important aspect to decide on the surgical approach. And from a surgical point of view, I try to do everything to make the right decisions. And you see, we have 4 bullet points on that slide. That means I have to select an implant of sufficient length, of sufficient diameter and strength. I discussed that already. When I made the proper selection of this implant, then I have to put that implant in a correct prosthetic position. That's not only important in the aesthetic zone, it's also important in the posterior areas, non-aesthetic areas. We often use the term restoration-driven implant placement. And then the third point is most important. You must make sure that this implant will be completely embedded in bone at completion of healing. So it can be a healed site, then you need to have a thick buccal wall, or when it's a defect site, you have to augment the bone. And the last point is the location in keratinized mucosa. So when you look at this, you see this is an aesthetic implant here, this schematic drawing. You see, you want to have an augmentation on the buccal aspect, not only to support your soft tissue, but to make sure that your implant is fully incorporated with the micro rough surface inside the bone and has no access to the bacteria of the oral cavity. Same in the mandible, right? The mandible, so you have a nice implant surface embedded in the bone. Right? So the third point is most important to avoid from my point of view, peri-implantitis, because most of mistakes are made in that field. So we have to talk about surgical technique now here, how to prevent it. And when we talk about implant surgery, then we have 2 types of implant surgeries. We have implant placement in post-extraction sites, and we have implant placement in healed sites. When I started in implant dentistry 35 years ago, we only did healed sites. There was no post-extraction sites with defects. They were all healed. Today, of course, we do about 60–70% actually post-extraction implant placement. And today we know that we have to differentiate from an anatomic point of view in post-extraction sites, thick wall phenotypes, thin wall phenotypes, or no facial wall. Whereas in healed sites, we have a differentiation that we treat patients where you can get a thick buccal bone wall at surgery or a thin buccal bone wall. And I will explain that. When we have defects, and we have seen in the other speaker before me, you see, You can have horizontal bone defects and vertical bone defects. And when we go for horizontal bone augmentation, then we talk about 3-wall, 2-wall, and 1-wall defect. When you have vertical bone defects, then it's a 1-wall defect. That's also important to mention here. So now, when we go into healed sites, and I want to show you here a most recent study by Alberto Monche from Spain. Excellent paper that really opened up our eyes a little bit. We had to revisit our way of thinking. All the research was done in post-extraction implant placement in the last 15 years, triggered by these original papers by Araujo, also Maurizio. And now this is a study that actually looks at healed sites. So what Alberto did, he put implants in and then had either a 1.5 millimeter buccal bone wall at placement or had a thin one. And then 2 months later, the analysis was done with histology. And we were really surprised to see that when the facial wall was a millimeter or so, or even less, we had significant resorption, So here, this is a clinical view of a patient like this. You see an implant is placed, and in posterior sites, I always use an implant that has a micro rough surface and on top a machine surface. We will come back to that. This is a so-called hybrid design implant. It's a tissue level implant of Straumann. And then I put this micro rough surface always below the crest, and for more than 20 years now. So today I say a millimeter at least, sometimes even 1.5 millimeter. The goal is that where the micro rough surface starts at surgery, you see, the thickness of the facial wall should be at least 1.5 millimeter. So then it will not resorb. And then you have a fully embedded implant surface at completion of healing. So the results of the study by Alberto Monche showed that. And the bone resorption is explained by so-called avascular necrosis. That is the same what you see in bundle bone resorption. That's also avascular necrosis. When you do an extraction or when you put an implant in and you have a thin buccal wall, you have no blood supply to that bone. It was also mentioned in the previous lecture. You see those start to move around cortical bone because this is then avascular necrosis and gets resorbed. So this case he showed with this fractured buccal wall will never work. And then you have to take it off and augment it or whatever. So this is from Alberto Monche, an animation video that explains these biologic events. You see an implant is placed and the buccal wall is rather thin, and then submerged. Now you see what happens. So you see this is a thin buccal wall. It's mainly cortical, and now there is no blood supply from outside and there is no blood supply from inside. And what happens in the next 2 months, you see osteoclasts are moving in and eat up the bone. So actually then the bone goes down. When you open up, then your implant is exposed. And that means that the implant is at risk already now. So then the implant is then restored. And you have here a high risk factor for the development of plaque accumulation of biofilm, and then for the development of a mucositis, later on a peri-implantitis. That surface should be machined, then it's much less problematic. Okay, so here you see that now when this is a micro rough surface, of course there are different grades of roughness. Electropolish would be very smooth. Coated and rough is with microporosity is the worst. Now this so-called hybrid design implant design is a term developed by Tarnow, Dennis Tarnow, in a paper in 1993. And he came up and said we should have their machine surface on the top and then micro rough in the osseous portion. When you look at the market, then you see that actually there are different hybrid design implants on the market. You see, of course, most prominent the Straumann tissue level implant, because it was from inception in 1986 like this, but also from Thomann, from Triple I, from Nobel. You see, you have these hybrid design implants. So I strongly believe that we should move the market to hybrid design implants to reduce the risk for the development of peri-implantitis. So when you look at these two scenarios, thick buccal wall, more than 1.5 millimeter on the buccal, and then you put the implant in slightly deeper, and then you get the remodeling done, you get some saucerization here, but this is then a very stable situation, and that will go for long term without any problems. When you put an implant in and it's thin, it's only 0.5 millimeter. It looks very good at surgery, but then during healing, then the implant, the bone is resorbed, and then the implant bone starts below the micro rough surface, the soft tissue goes down, and then you have an installed risk factor for the development of peri-implantitis. Believe me, many of the cases reported with peri-implantitis have made this kind of mistake during surgery. So be very careful not to make the same mistake. This is a very important take-home message, how to prevent peri-implantitis. Don't compromise on the thickness of the buccal bone wall. Use hybrid design implants and locate the micro rough surface, always 1 millimeter below the crest. Now, when we talk about 3 and 2 wall defects, we are moving into the post-extraction implant placement scenario. And here you see the different options you have. And this is dominating our daily practice today. You see, we have this immediate implant placement approach. We have late implant placement. That was the original Bronnemark and Schroeder approach. And in between, we have a compromise. This is so-called early implant placement. This is a definition developed by ITI at multiple consensus conferences. You see, the first report was in 2004 by Christoph Hammerle, and then Stephen Chen made several of these, then Dean Morton, and so on. So when we talk about different approaches, I can tell you very openly, today I use them all. 5 years ago, I did not use any immediate implants, to be frank, but I learned how to do it. So the important is that you select these approaches according to the anatomic situation. So when immediate, when early, when late. This is a review paper in Perio 2000, published 2 years ago, so 3 years ago now, with Stephen Chen, Vivian Chapri, and Urs Belzer. So when we go into immediate placement, and that's not very often, that's less than 10%. We only do it in ideal cases. That means you have a fully intact buccal bone wall, at least 1 millimeter in thickness, no infection at the site, and enough bone apically to stabilize the implant. And then we do it flapless, and we do an immediate restoration when the primary stability is sufficient. That means this is for sure the most attractive approach we can offer a patient, because patient comes with a tooth and moves out with an implant-borne provisional crown. I showed you only one case. This is always done by our group with computer-assisted surgery. We normally use these bone-level tapered implants because it helps to improve the primary stability. We take, of course, the intraoral scan, cone beam CT, we do the planning, the matching, and then we get a surgical stent. And then with that one, you see, we are ready for a nice surgery. This is prepared with Dr. Abu Ayash, a senior prosthodontist at the Prost department at University of Bern. And you see here, the surgery was done a year ago. And you see here very nicely, very easy to do, slightly palatal. You do an internal grafting, can be an allograft, can be something else. It should not be bio-os, because we need something that resorbs, remodels. And then you see the provisional crown has been prefabricated. So this is a very nice crown done with CAD/CAM technology. So here you see the patient 3 months later with the provisional out of occlusion. Samir Abu Ayash, the prosthodontist, and then he converted it into a final crown. And we're going to see that later, this patient in May for the 1 year follow-up now. So I'm very pleased with this, but we have only done 20 patients, also myself, in 2.5 years. So that shows not very frequent. I'm sure we're gonna expand our indications slowly but surely, but I'm very careful not to overstress the application. When there is no thick buccal wall or there is no buccal wall, then we go for early placement. That's our favorite approach for many, many years. And then we take the tooth off and we wait 6-8 weeks before we put the implant in. And here I just show you an overview on some cases. This is a 10-year follow-up case. The surgery was done in 2005, 2006. See, it's a 2-layer composite graft on a routine 8 weeks post-surgery, as opposed to extraction, autogenous bone chips locally harvested, done bio-os here, so a low substitution bone filler, bovine, and then a collagen membrane and primary closure. Excellent outcome. You see the same here when you have 2 central missings, one of the really nicer cases. Same technique. That surgery was done about 4 years ago. And very nice outcome. You see here the excellent facial bone wall that has been reestablished by Mother Nature during the first, within 2-3 months of healing. Here you see another with 2 central incisors, now 10 years follow-up, 11 years follow-up. That was done in 2006, 2007. Also here, very stable situation. And last but not least, I want to show you the first case where we have done this technique in January 1998. And this is a 20-year follow-up, the first 20-year follow-up case we have seen with early placement and contour augmentation. If you're interested in this technique in more details, then join us tomorrow evening on Instagram. There will be a first time an Instagram session. It's more a discussion. And then of course we share cases together with Diego Becelli from Buenos Aires. And this is then a full hour on this subject alone. So this is one of my favorite topics. We spend a lot of time on research on that subject. And I think it's very fun. Okay, before we come to the conclusions, the last point, the location in keratinized mucosa. Very important. I think today there is no dispute anymore. We have multiple papers to really document that. Of course, in aesthetic sites, there is normally no problem to have a sufficient band of keratinized mucosa. When it's a post-extraction case, it's no problem because then the extraction is done flapless and you always maintain enough keratinized mucosa. Today, you see as a surgeon, we don't do often soft tissue corrections to reinstall keratinized mucosa. The main application of these techniques is in failed aesthetic implants, where there is a huge recession and then, of course, a lack of keratinization. And then we do soft tissue grafting in these patients. Then another point I want to mention is the maintenance care or supportive care program. Of course, that's not a surgical topic, but that's for the maintenance. We treat all the patients in a team. So actually, I always check with the referring dentist if they take care of the patient or we take care of the patient. So it's important to really do that. And depending on the risk profile of a patient, it's the dental risk factors, also including the perio risk patients. And the smoking, you see, you have to select an appropriate interval to do that. So I would say on a routine basis, an implant patient comes every 6 months to our department or to the dental hygienist. When it's a high-risk patient, then every 3 to 4 months to really do a good job on that one. That's an important aspect. So this is just, if you want to have good long-term results, you need to establish a supportive care program by yourself or with your colleague when you work in a team. So this is a very important aspect as well. I just want to mention it because that's also, of course, a preventive measure, how to prevent peri-implantitis. When you see a patient like this, you see this is one of these long-term cases. Then you see excellent home care. Patients are using Superfloss, and that, of course, helps a lot to maintain the peri-implant health. And these are the kind of cases we're going to see for 30 years, 40 years, as long as we are all active in the field. With that one, I would like to come to conclusions. I need another 2-3 minutes and then we are done. You see, how can you avoid complications and failures as described? I would say, as I said already, utilize an implant of sufficient length, diameter, and strength. So that's very important. Put them in the correct position. And then make sure that your implant is embedded in bone circumferentially at completion of healing, not at day of surgery. If it's a healed site, you need a thick buccal wall. If it's a defect site, then use a technique to rebuild the bone. Then the implant should be located in keratinized mucosa, as I mentioned at the end, and offer the patient a good supportive care program with a dental hygienist if available. So then you can best maintain these patients so they are healthy peri-implant tissues. As I said, it all comes back to these 4 circles. You as an implant surgeon, you need to understand the risk profile of every single patient. Is it a high-risk patient? Is it a medium risk or a low-risk patient? You need to understand the various treatment approaches from a surgical point of view. You need to know the involved risk for that one. If you have a high-risk patient, then I normally use a procedure that offers a low-risk procedure. So don't go for always too risky stuff. And then you have to select biomaterials that help you to achieve your treatment objectives. So implant selection, very important. Membranes and bone grafts and bone substitutes then for the bone augmentation procedure. As a surgeon, you see, most important, you need to have certain skills and talent. You should be well educated and you need to have enough experience. That means you should have enough patients to build up the experience and maintain the experience, not only for you, but also for your staff, for your team. Also 5-10 patients a year, forget about it. Don't do implant surgery. Look for a top colleague to do the surgery for you and you concentrate on your prosthetics. You see, that is a much better, but when you have enough patients, then of course it's fantastic. I have never done any prosthetics on implants. I always use the team approach. And this team approach served us extremely well. So the surgeon, most important because you do all the stuff I said. And if that goes wrong, you see, then I always say the surgeon is the biggest risk factor for the patient. So therefore, don't go in that direction. You should be the most important success factor, the key factor for success for your patient. With that one, I would like to give you quickly also a short appetizer on the 2 master courses we offer in Bern. One is on aesthetic implant dentistry with Professor Belzer. That is normally beginning of September. The other one is a master course in bone grafting procedure, very popular for more than 20 years now, together with Professor Chapuis and myself and excellent faculty. Had to be postponed now from June, and now the new date is November 18 to 20. And we hope that Corona will allow us to do it. I'm very positive, should not be a problem. With that one, I would like to thank you very much for your online presence. It was a big pleasure for me. If you want to have a handout of this lecture, don't hesitate to send me an email to this email address. And then we're going to serve you with not only the hand, but also some publications. Thank you.
Thank you, Prof. Boozer, for the wonderful presentations. It was an honor to have you on board. There is a couple of questions.
Of course.
What is your thought about using rock solid 3.3 at the posterior region?
In the anterior region, in the aesthetic zone, I would say when it's a lateral incisor, I have no hesitation at all. It's more or less a routine. When it's a central incisor, only when there is a need to do that. And of course, I have done a few patients Normally, it's not necessary because the anatomy of a central incisor socket is enough to accommodate a 4 millimeter implant. But in some cases, there must be a need, and then we have done that. You see, it's no problem.
So would you use the 3.3 at the posterior, like in the premolar or the molar area?
The 3.3 millimeter implant we use, of course, with big pleasure in premolar sites. Also, first and second premolars, I'll use it sometimes also in molar sites, but they're not in a single tooth gap. So it's a distal extension situation. To add, then they adjust one implant and the premolar size unit, the crown. Crown cannot be a molar on a 3.3 millimeter implant. So I did not mention that, but I think in the last couple of years, the narrow diameter implants in our department made more than 20% of implants used. So it's a very prominent implant type, because it not only helps us in borderline situations, it also often helps us to avoid bone grafting or to avoid a staged approach bone grafting. So actually, I'm very happy with this implant, yes.
The questions came, if you plan to have a delayed site, or like maybe not immediate, would you graft the site and would you come back 6 weeks later or 8 weeks later do the implant, or only just extraction and let it heal for a...
That's a very good question. Now, I would say when I do an extraction in a, let's say, aesthetic zone, central incisor, and I know that in 6 or 8 weeks, I can place the implant, then I don't do a grafting, because then actually what I want to have is that then the soft tissue will grow into the socket. And then when we do the implant surgery, then I can work with a thick flap, because in that socket, in the crestal area, is mainly soft tissues. And then you do a palatal incision technique and take all that soft tissue as part of your flap. And that helps you to avoid a soft tissue grafting for your implant patients. When I know that an implant cannot be placed at 6 or 8 weeks, I have to wait longer. Then I do a socket grafting, normally with Bios collagen, and let it heal for 4 months. And then we go back in. Often I use that technique more and more frequently in elderly patients, because then it helps me to do then a flapless procedure with a narrow diameter implant, computer assisted. Because then the implant surgery in an elderly patient, 80+ years, is then of course minimal invasiveness for the patient, and it's much easier for the patient to cope with the surgical technique. So in the last 2 or 3 years, the socket grafting and then the flapless placement of an implant has increased to about 10–15% in our department. So this is a very attractive additional option we have.
Thank you, Prof, for your time. It's almost running. So on behalf of the scientific committee, we would like to present a certificate of appreciation for being here. It's an honor.
It was my pleasure. Mariano, what a pleasure to see you. I hope you're doing fine in Madrid. When I know I suffered many times for the Spanish people with all this Corona stuff, my goodness. So I wish you all the best. Stay safe, stay healthy, take care of your families. Time will come back that we can meet again, but in the moment, I think we have to be just very realistic and stay home and don't give the virus a chance.
Absolutely.
Thank you.
Danny, it's a real pleasure.
Okay, Mariano. Bye-bye.
Take care.
All the best. Bye-bye.
Thank you, Prof. Abdul Karim, the floor is yours with Prof. Mariano. I hope you wishing the... Thank you. Appreciate it.
Dr. Khaled, before you leave, we want to thank you for running this session. I wish I can be beside you to handle you this certificate, but for now, we're going to do it online. Thank you so much. This was an amazing session. Thank you, Professor Boozer. Thank you, all the speakers from all around the globe. Please stay with us. Now we have Professor Mariano Sanz, and we have Professor Tarnow and Dr. Alvaro. So I will handle the mic to Dr. Abdul Karim for starting this session. Thank you, Dr. Khaled, and the mic is yours, Dr. Abdul.
Okay.
Appreciate it. Thank you.
Assalamu alaikum. Can you hear me?
Yes.
Okay. Assalamu alaikum. Masakum wa bakhair jami'an. I'm Abdul Karim Al-Hamidan. I'm a periodontist, and I want to thank the Saudi Dental Society and in the form of the president and the scientific committee for hosting such a great event, bringing such elite speakers in the field of dentistry, different fields. We're very thankful for them. I want to thank also the people who registered and all the attendees. Thank you very much for attending. And most of all, I want to introduce our giant speaker now. Let me go ahead and, can you see my screen?
Yes.
Is it? Okay. So it's really hard to summarize Professor Stein's journey in research and in clinical and teaching. Actually, when I saw his resume, I was super amazed, because the only thing that came to my mind was, how long would it take me to be half of him? So it's going to take me probably forever. So I just want to say a brief introduction about our guest, and we're honored to have him. Professor Sands attained his dental degree from Universidad Complutense Madrid, and then he went for UCLA for his periodontics training, and then he had a PhD back in the same university at Madrid. Professor Sands is the director of the master's program in Madrid, in the same university, and he is a current and a former president of so many committees, and as well he's a member of the editorial committee of so many journals, Journal Perio, Journal Clinical Perio, Journal Implant, Clinical Oral Implant Research, and so many elite top high impact factor journals. It's really an honor, sir, to have you with us today. I'm going to pass on the screen for you. If you may please share your screen with us, Professor.
Okay. So I hope you are able to see my screen.
I can do that, sir. I can see it.
Okay. So good evening to all of you. Salam alaikum. It is a big pleasure to share the podium with Professor Busser and other highly recognized speakers in this session organized by the Saudi Dental Society. And once again, we are going through rough times all over the world, but I think it's important that we keep up for educating our colleagues and for sharing our knowledge and our experience. So in that sense, it's a pleasure to be with you. And during the next 45 minutes, I will like to basically address with you basic concepts on bone regeneration and the rationale on how to use the appropriate regenerative technologies in bone regeneration of the alveolar ridge when placing dental implants. Of course, you may think that bone regeneration is something that we do rarely, but I have to say that it's all the opposite. Smaller or bigger bone regenerative procedures are much more the norm than the exception. And the main reason is very obvious, that we don't extract teeth without a reason. And tooth extraction is normally based on hopeless teeth, which has become hopeless due to infections, to trauma. And all of these background diseases, of course, cause resorption of the bone. Even the mere tooth extraction cause significant changes in the dimensions of the alveolar ridge. So if you see these statistics, which are not more than statistics, but give you an idea that the selections
of bone regenerative technologies have an enormous impact, not only in the health of our patients, but also in the economy of our clinics, and of course in the costs for the patients or the governments who pay for these procedures. So it is important to understand which are the indications, and clearly the indications are the resorptive processes that occur in the alveolar ridge after tooth loss. And these resorptive processes have been classified since many years back by Siebert in United States in basically 3 groups. Group number 1, when the resorptive process is fundamentally horizontal, buccal bone is resorbed. Group 2 is when the alveolar ridge is resorbed fundamentally vertically. And group 3 is when there is a combination of horizontal and vertical resorption. As you may foresee, the most frequent of the 3 groups is group 3, which occurs in about 60% of the occasions, with the vertical component of resorption being more or less profound, which will imply the need for more or less extensive bone regenerative approaches. The defect type 1, which is basically a pure horizontal defect, occurs in about 1/3 of the cases. And of course, this is a defect where our main efforts are going to be headed towards lateral bone augmentation, and we will always have a palatal wall to lean on our technologies, which of course that will have important surgical implications. And defect type 2 is a very rare defect where we have a pure vertical resorption. And of course, this defect will need, if we want to restore the full vertical dimension of the alveolar ridge, extensive bone regenerative approaches, which of course have a different dimension. What you see in the screen is an amplification, modification of the previously described classification. This one is by the group from University of Zurich, by the group from Hammerle. And as you can see, it has 5 groups. And in these 5 groups, it goes from type 0, which is basically an alveolar ridge, which has not resorbed and has ample of bone, both horizontally and vertically, to place an implant, to a type 5, which has a huge collapse, both vertically and horizontally, that will demand extensive bone regeneration. And you have the different situations, groups 1 and 2, where we have the presence of the socket, which will occur in a recent extraction. And there we may attempt to place the implant immediately, or groups 3 and 4, which depending on the amount of basal bone, we would be able to place the implant in the ideal prosthetically driven position and regenerate simultaneous with the implant placement, or as in group 4, we will need to do stage bone regeneration. So irrespective of the clinical indication and in respective of the implant approach that you are going to follow, what I'm going to be focusing in my presentation mainly is to present to you some very basic biological principles which are fundamental in our understanding to select the appropriate technology. We will then discuss what is the decision-making process, what are the criteria that we use to select the appropriate biomaterials, and then we will wrap up and summarize on the regenerative interventions. So let's discuss briefly on the bones of the jaws, which are, of course, our terrain that we are going to be working when placing dental implants. And as you understand very well, these bones are membranous bones, which means that ossification will always occur through a connective tissue matrix, will never occur through cartilage as endochondral bones. So these bones are normally flat bones, which if you observe them macroscopically, as you can see in the screen, they are comprised of an external cortical part where the bone lamella are very tightly packed one on top of the other. And then you will have the bone trabecula of the bone marrow, where the different lamellae are localized in between high voids where the bone marrow is located. And if we blow up one of these bone lamella to a higher magnification, we will have the typical structure of live bone, where these circumferential lamella are organized around the vessel, forming this Haversian system or osteon, which is the basic unit of bone, which is the basic unit of live functional bone that we want to recreate with our bone regenerative approaches. But even if we even blow magnification of one of these Haversian systems, we see here, this is the ultra structure of the bone, which is a very highly porous three-dimensional structure where the hydroxylapatite crystals, the inorganic component that comprises basically 70% of the bone, are located around these porous, these voids of about 250 microns, which are needed for the vascular ingrowth. Bone is a highly vascularized tissue, and it needs the space to basically nourish the cells and the the non-organic component of the bone. This non-organic component, this organic component of the bone is basically collagen and non-collagenic proteins. And collagen is highly needed. This is what will give the flexibility to the bone, the elasticity to the bone, and of course the combination of the collagen and the hydroxylapatite crystals will provide the compressive strength of the bone, which is fundamental to maintain the three-dimensional structure of our body. You know very well that bone is continuously modeled and remodeled according to functional stimuli, and we have three types of cells inside the bone. Those that form the bone, that we call osteoblasts, those that resorb the bone, that is the osteoclasts, and the osteocyte, which are basically highly differentiated osteoblasts, which will become the regulatory cell that will intervene in the coordination between bone apposition and bone resorption. So you see in this graph how the osteoblasts, which are derived from the mesenchymal stem cells, will differentiate to bone-forming cells, and they will provide the connective matrix deposition and the calcification of that connective matrix to form a new bone. And osteocytes basically will control the molecular elements that will promote the differentiation of the preosteoblast into osteoblasts, or contrarily, they will inhibit this differentiation and will promote the differentiation of the osteoclasts. Osteoclasts are not mesenchymally derived cells. They are cells derived from the hematopoietic system, which means that they are cells from an immune base. They are basically modified monocytes, which become giant cells, which become the bone resorbing cells. And of course, the interaction between the two types of cells, the bone forming cells and the bone resorbing cells, will shape the bones that we have in our body. And the intimate molecular pathways that will stimulate bone formation and inhibit bone resorption are key in our understanding on how bone regeneration takes place. So if we have to use the bone regenerative capacity of our jawbone, we need to understand what occurs in the healing of a defect that takes place in the jaws. So you see here in these diagrams, what happens, what is the natural bone healing capacity of a defect that is formed in the jaw from day 1 to day 7 to day 14 to day 28. So you see, it takes about 30 days for a defect to be filled with mineralized structure. That doesn't mean that this is mature lamellar bone, but it is mineralized structure that with time and the appropriate functional stimuli will evolve into fully mature lamellar bone. But in between, from day 1 to day 28, there are a number of healing events which are fundamental for this bone regeneration to take place. You see, at day 1, what is key is the formation of a blood clot that will fill the space of the defect. This blood clot needs to be stable in order to be able to release the content of the platelets and other immune inflammatory cells, which will release a high number of proteins, both cytokines and also growth factors that will be the responsible proliferation and differentiating factors that will tell the bone that bone forming cells need to come to the area of the bone defect. And most important is the growth factors that will stimulate the neovascularization, the neoangiogenesis. You have to understand that the area below the blood clot is an area very deficient in oxygen. It's an area where ischemia is more present than any capacity of nutrition of newly formed cells. So if we don't have between the day 1 and the day 7 the angiogenesis, it will be impossible for new cell differentiation and proliferation able to deposit new bone. The first has to be the neoangiogenesis that will bring oxygen, will change the microenvironment, and this microenvironment will be conducive to this barrier of osteoblasts that will begin to deposit the connective tissue that secondarily will turn into bone. And as you can see at day 14, not all of the defect has been filled. Still, the most superficial part of the defect is granulation tissue that shortly, but little by little, is being replaced by this barricade of bone-forming cells that follow the neoangiogenesis and deposit. First, woven bone is an immature bone that doesn't resist, doesn't have the compressive force capacity to withstand load. But with time, this woven bone is transformed into lamellar bone. What you see is that in these 28 days of this model, we need that the area of the defect is stable so that there are no other forces or no other elements that are going to interfere with this self-regenerative process. And then the question is that if we want to maintain that space for these dynamics, is there a possibility that within the oral cavity we can maintain for 28 days the unaltered space to produce these bone healing events? Well, basically, yes. And this is what occurs when we do an extraction and we have a fresh extraction socket. If the socket has maintained the socket walls, all the space within the socket will be protected from any external forces. And if we are able to maintain the blood clot within the socket, basically that socket will be eventually filled with bone. And the same phases that we have described that occur in the defect will occur inside the socket. We will have first the blood clot during 1 week, then we will have the granulation tissue, that is the replacement of the clot by an immature connective tissue. And then you see from the borders of the socket, that is from the bone forming cells will be deposited, and from the borders, the bone will be formed, and basically in about 2 months, we will have in an experimental animal model where these histological images are derived, we will have the full socket completely filled. Of course, there will be dimensional changes in the socket walls, but the defect will be filled with bone. The problem we have when we are dealing with the alveolar crest, which is where we are going to place implants, is that we don't have spaces that will maintain the anatomy during this period of 1 to 2 months, because normally the soft tissues will fill the space. And unless we protect the space, we will never have self-regeneration of alveolar ridges. If you see this model where we have the defect after the extraction, basically, unless we have all the socket walls, if we have not all the socket wall, the soft tissues will ingrow inside the space and will prevent the alveolar socket or the alveolar crest from self-regeneration, and therefore the result will be a defect. And of course, this is an X-ray from one of my patients, which can be for sure from one of your patients. You see, we have huge concavities. That means that the patient has lost the whole volume of the alveolar crest, because it is impossible that these defects will self-regenerate. They will be filled with soft tissue, and this resorption will grow. So the question is, how can we overcome these problems? And of course, we can overcome these problems using the appropriate regenerative technologies. And of course, when we are dealing with bone regeneration, we always have to look at this triangle of the basics of tissue bioengineering. And in this triangle, we always have at the base the scaffolds or matrices, the molecular mediators, and the cells. Of course, if we have a defect, we need the scaffold to fill the space, because as we have alluded, unless we fill the space will be filled by soft tissue. We need molecular mediators that will help the existing cells from the borders of a defect to differentiate into bone-forming cells. And clearly we need the cells, because without the cells, we will never have the appropriate bone. So the question is, of these elements, which are the key elements that I need to introduce during my bone regenerative technologies in order to, in a predictive manner, achieve the whole regeneration of my defect? You see that apart from the cells, the scaffolds, and the molecular mediators, it is fundamental, it is the core of the triangle, the blood supply. The blood supply is the key to bring the bone regenerative capacity to any of our technologies that we utilize. And you see on the outside of the triangle, that is always key, and sometimes we forget that we are doing these bone regenerative interventions within the oral cavity. And of course, the oral cavity is one of the most contaminated natural orifices that we have in our body. The oral microbiome will always elicit inflammatory reactions when bacteria are able to enter into the tissues. So it is fundamental to establish a very tight seal of the soft tissues during surgery and to impose strict measurements of biofilm removal in our patients during healing, so we can have the appropriate environment. Because if we don't have the appropriate environment and we have bacterial contamination, the net result will be inflammation, will not be bone regeneration. So with these basic principles, when dealing with the jaws, it is fundamental that we achieve primary wound healing, because this will be the only way that we can separate very tightly the contaminated oral environment from the healing wound. It is very important that we enhance the cells from the walls of the defect, and it's very important that we allow them for differentiating into bone-forming cells. So we will discuss the need of using the appropriate barrier membranes to prevent the cells from the soft tissues to colonize the area and thus prevent the bone-forming cells to form a bone. It is very important to protect the integrity and the stability of the wound. First, of the blood clot during the first week, and then of this immature connective tissue matrix that secondarily will calcify. And therefore, during this period of 2 to 3 months, the area has to be protected and stable. And you see that these things may seem synonymous, but they are not. They are complementary. Primary wound closure implies the closure of the soft tissues to prevent bacterial contamination. The integrity and stability of the wound implies the avoidance of the external forces to compress and to change the three-dimensional structure of the bone we want to regenerate. We discuss about the stability of the blood clot, and of course, if we follow those principles, The next thing we need to understand is what kind of technologies we can utilize to promote self-regeneration and to help the regeneration of these defects. If we utilize the homing effect, and homing in bone regeneration is not to add cells, but to use the cells from the walls of the defect to regenerate the defect. Are these cells enough? And this is a good question, and you understand that there are research projects all over the world evaluating the possibility of adding cells, bone promoting cells, either mesenchymal stem cells, which are differentiated into bone, or using own bone mesenchymal cells, which naturally will differentiate into bone. However, still stem cell therapy is not safe enough, it's not cost effective enough to be utilized in patients in a regular fashion. We are doing lots of research. I am personally heavily involved in several multi-center clinical trials in Europe, and this will come, but still we do not have the appropriate technologies to safely manipulate the cells to differentiate them very closely to what we want them to do. So if we are not using cells, we are utilizing the home effect of the cells from the walls of the defect. It is fundamental that we maintain that wound stable so that we allow for the proper neoangiogenesis and new tissue formation, first connective tissue and then calcified mature bone. So for that, we need to basically use two elements, a scaffold that is solid enough to maintain the space and provide the adequate architecture for the new bone to form, and a barrier membrane that would avoid the unwanted cells from the soft tissues to fill the defect and to prevent bone formation. So space provision in both senses to reconstruct the three-dimensional area we want to regenerate, and space provision in the sense of creating a barrier so that only the cells that form bone can colonize the area is fundamental. And therefore, it is crucial that we select the appropriate scaffold and the appropriate barrier membrane. When we are dealing with the scaffolds, of course, during many years, we have utilized autologous bone from the patient. And it seems, at least biologically, that this is the ideal bone graft, because it will have, of course, the tissue we want to regenerate bone. It will have the molecules that differentiate bone. In this particular area, it will contain bone morphogenetic proteins. And even if we remove or harvest the bone to an area very close to the area we want to utilize that bone as a scaffold, it may even bring some cells, and in that case, it may have also osteogenic capacity. So using the autologous bone graft as the standard of care, we have defined, depending on whether we are bringing the cells, whether we are bringing the bone differentiating factors, or whether we are using only a scaffold that is conducive of bone apposition, a scaffold that chemically allows for bone to deposit on its surface, but it doesn't have the ability to provide differentiation to the bone forming cells. This would be the osteoconduction. And nowadays, in the area of biomaterial research, we are utilizing a lot of elements that not only will differentiate cells, but also will allow for specific cells to deposit the biomolecules that are needed for the differentiation of the cells. So today, we no longer utilize the autologous bone as the standard of care, because biomaterial research has helped us to understand what are the specific needs, what are the specific properties that the ideal biomaterial should have as a bone replacement graft that we use in our bone regenerative technologies. And these have been discussed, and you see in the screen a recently published paper where a group of experts gather and discuss what are the ideal biomaterials for bone regeneration in our area. This you can retrieve, is open access in Journal of Clinical Periodontology. So you see that these properties, biocompatibility, mechanical properties, so that means that the biomaterial I should use should be resistant to compressive strength. That is, if the bone has a compressive strength of basically 200 megapascals, I would need at least the same amount of compressive strength, because otherwise the lateral forces of my soft tissues will deformate that scaffold and will not serve the purpose for the three-dimensional reconstruction of the alveolar ridge. I need porosity. You saw the ultrastructure of bone. If I don't have pores of at least 250 microns, it will be impossible for the neoangiogenesis to occur. And you have seen how important that neoangiogenesis is. Also, these biomaterials should have surface characteristics that are conducive to osteoblasts apposition, and not only osteoblast apposition, we can modify the texture of the surface to even promote differentiation from pre-osteoblasts to osteoblasts. And today, there are beautiful studies in biomaterial research of synthetic biomaterials that promote the differentiation of osteoblasts. So that idea that osteoinductivity could only be achieved by autologous bone, today, at least in the laboratory, we can achieve very clear osteoinductivity with the newly developed biomaterials. And of course, the osteoconductivity, as we have discussed, is a key element, because we need the bone to be deposited in the surface of the scaffold. And we would need that scaffold to be present enough time until we get the full maturation of the bone. And we established before that it needs time. It needs at least 3 to 6 months for full maturation of the bone. So if I have a bone that resorbs, or a scaffold that resorbs very quickly, then I will not have this scaffold effect that I need to maintain the integrity of this newly formed bone. So whenever I buy biomaterials for bone regeneration, it is fundamental that I look at these properties. And it is fundamental that I look at the scientific documentation of the biomaterial that will assure me that these properties are met. Because the problem with autologous bone grafts is that not only I need to harvest them from the patient, which of course increases the morbidity, but also this mostly granular autologous bone resorbs very fast. And sometimes I will end up by losing a lot of the volume of the bone that I'm using. And therefore, today, the standard of care is not autogenous bone alone, although we would use more or less degree autogenous bone to boost the osteoinductive properties of other purely osteoconductive biomaterials. So combinations, of course, is something that we use all the time. You see, biomaterials can be divided into natural or synthetic. And most of the biomaterials for bone regeneration that we utilize today are natural, either from the patient itself or from cadaver donors, allografts, or from animal source, xenogenic. I'm not sure what happens in different parts of the world, but in Europe, allograft use is very restricted. You need to be consider a bone bank to be able to use allografts, and therefore the standard of non-autogenous bone in Europe and other parts of the world is more the xenogenic bone. And xenogenic bone has very good mechanical properties, very good osteoconductivity. It does not have osteoinductivity, and therefore many occasions it is combined with autogenous bone to boost that osteoinductive properties. However, probably the future will not be the use of animal-derived bone for many reasons, and therefore there is a high innovative research in the development of bone regeneration synthetic biomaterials. Modern synthetic biomaterials are basically ceramics, mostly different combinations of calcium phosphates, which we can add different ions to boost the osteoinductive properties. And also perhaps the future will be combination of ceramics and polymers, what we call composite biomaterials. And we can utilize the elasticity of the polymers with the compressive strength of the ceramics, and we can basically make combinations that will suit exactly our purposes of porosity, compressive strength, and also the surface texture that will allow osteoinductive properties to these biomaterials. Also, the combination of polymers and calcium phosphates will allow us to use 3D printing devices where we are able nowadays to customize the shape and the form of the defects for allowing a much definite shaping of the newly regenerated alveolar ridges. But we said that not only the scaffold is enough, we need to avoid the ingrowth of unwanted cells, and therefore the use of barrier membranes is still a need when we are dealing with bone regeneration of the jaws. And as you can see, similar to the biomaterials, we have two main groups, the bioabsorbable membranes and the non-absorbable membranes. Basically, the non-absorbable membranes are restricted to those areas that we need to do vertical bone augmentation. We need to expand beyond the borders of the existing ridge, and therefore we need not only very stable frameworks, but we need also frameworks that will maintain the space beyond the borders of the bone for extended periods of time. And for that, we are going to need these space-making elements that, together with the non-absorbable membranes, are able to provide us that extra space. For most of the defects, however, we would use bioabsorbable membranes, which, depending whether the defect is bigger or smaller, we would use purely natural collagen membranes or cross-linked collagen membranes if we need extended resorbability. And in order to support what I am saying, let me share with you a proof that where we can basically make a rationale whether we need or do not need the use of a barrier membrane. This is a study, an experimental study, which I did together with Tor Berglund and Massimo De Santis, highly reputed periodontists, because we were puzzled with the idea that we are using bone grafts and membranes for bone regeneration. But when we ask ourselves, is there a need of a membrane? Is there a proof that we really need a membrane? We couldn't find a very good proof. And therefore we designed this study, trying to experimentally validate the need or not need to use a barrier membrane for bone regeneration. So basically, in experimental animals, in dogs, we created these standardized defects in the mandible, and then we allowed the chronification of those defects. And you see that allowing basically 3 months after defect creation, these defects will heal like a typical two-bone defect, where we have a high palatal wall and we have a whole collapse of the crest. So this is the typical defect where the aim is lateral bone augmentation. And as you can see, the defects have similar morphology. And then we randomize for 3 technologies. You see, in one of the defects, we place a membrane only. We tuck the membrane to prevent its movement, and we just have the membrane as the bone regenerative technology. In the second group, we have the combination of a biomaterial and a membrane. And in the third, we have the biomaterial only. In this case, we utilized xenogenic bone substitute, and we utilize a bioabsorbable collagen membrane. Basically, the biomaterials that we utilize normally in our patients. And of course, we utilize quite sophisticated histological approaches to quantify not only the volume of the new bone, but also the content of the new bone in terms of new bone, which is depicted in red, the presence of the particles, which is depicted in yellow, and the ingrowth of connective tissue, which is depicted in blue. And in this way, we can measure which of the technologies achieves the most amount of new bone and the most amount of volume, which are characteristics that we need for placing our implants. And of course, we look at the osteoconductive and osteoinductive properties. But let's look at the final results. These are the results at 6 weeks, and what is interesting is the long-term results. And you see, let me help you read these slides because it's very interesting. This is the membrane only. And in the membrane only in the center, what you see is the thick blue, which is the thick connective tissue layer, which is basically the remnants of the membrane. Everything inside the membrane is new bone. So the membrane really does its job of blocking the ingrowth of soft tissues and allowing for new bone formation. However, when we measured the volume was significantly inferior to the other 2 groups because part of the volume is the compression of the soft tissues. When we look at the group of bone graft alone without the membrane, what we see is that we created a lot of volume. What we see is that we only have bone in the interior of the defect, the part that is close to the borders of the defect. But you see that most of the volume is comprised by connective tissue, which has occupied the space and even has encapsulated most of the granules. So that means that we create a lot of volume, but this is not bone. This is basically connective tissue encapsulating the granules in most of the external part. And you see the third group, which is the combination. Here we get very good volume, and we also get, by the use of the membrane, the preventing of the connective tissue in growth, and you see how most of the granules are within the bone structure. And this is what we want of the scaffold effect, to maintain the space for long periods of time for new bone formation. So this basically sums up the meaning of my lecture. We need, for regenerating the alveolar bone defects, the appropriate scaffold, the appropriate biomaterial, and the appropriate use of the cells from the walls of the defect and the molecular mediators that will create the regeneration of the bone. For that, we need not only the scaffold.
Professor Sands?
Yes?
Professor Sands, thank
Yes.
you. We have a few more minutes before we need to take questions. Can I bother you if we can just a little bit try to finish as much as possible within the next
Sure.
5 minutes, please?
Sure, this is the last slide.
Okay, cool. Sorry about that. Sorry. Thank you.
So that means that by using the appropriate scaffold and the appropriate membrane, we will be able to basically have the bone regeneration that we wish to achieve. And therefore, in this presentation, basically, I reviewed with you the biological principles of bone regeneration. We make a rationale for selecting the appropriate biomaterials, and also for selecting the key elements in the regenerative interventions. And with this, I thank you very much for your attention. And of course, I'm happy to answer questions that you may have. Thank you very much.
Thank you, Professor Sands, for the very nice, very informative, very scientifically based lecture. We learned a lot, and we can still learn from you. I have a few questions. Actually, I have a lot, but I'm going to have to pick. I remember your article in 2016 where you packed around the implants. You were comparing grafting the gap distance with a xenograft versus no graft. Why xenograft? And do you still, the difference you showed in that article within 0.5 millimeter. So would you advise the clinicians who do immediate implants to graft? Would that have any effect on the implants? What's your preference, sir?
Well, that study showed us a very important thing is that one thing is that the gap size is not relevant. So whether I have a gap of 2 millimeters or 6 millimeters does not change the predictability of the gap to be filled with bone, irrespective whether we use a graft or not. And the second thing that showed us is that what the graft does is not basically help to fill the gap, but help to prevent the external resorption of the buccal plate. So what we demonstrated is that when we have very thin buccal plates, the ungrafted gaps were heavily resorbed. When we had, I mean, in comparison with the grafted ones. But when we have thick buccal bone, the graft did very little because the self-capacity of regeneration was very big due to the protection of the external part of the bone. So if we translate this into the clinic, I would say, if I am using an immediate implant in the anterior maxilla, where in 90% of the times I will get 1 millimeter or less of buccal bone, I will always graft. If I am in the premolar site, and if I have a buccal bone of 2 millimeters or 2.5 millimeters, I will never graft because the impact of the graft will be minimal.
Sure. Nowadays, socket or alveolar ridge preservation, extraction, and socket preservation, a lot of people, they use variable membranes. Some people, they use the non-resorbable membrane in an intact socket, four-wall defect. And some people, they use the resorbable collagen cross-linked, and some people, they use a fast-acting, like a collagen plug or collagen tape. And everybody comes up with his, whatever he was trained on back in the days. So from a histological and clinical evidence, what's your preference in this? What kind of membrane would you prefer for rigid preservation?
If I have a socket with intact walls, basically I have the perfect space for bone regeneration, as we have shown. So what I need is basically to close the opening of the socket to prevent connective tissue ingrowth. Basically, if I do the extraction and I allow the socket to be filled with a blood clot, and I can maintain that blood clot completely stable for the first week until it's filled with immature connective tissue, I would not need a membrane, because the blood clot will prevent the connective tissue ingrowth. However, that blood clot in the coronal part of the socket is going to be exposed to the oral cavity. And since it is exposed to the oral cavity, of course, there will be the external part of that wound killing would be in conjunction with inflammatory reaction. And therefore, it is advisable in order not to have a soft tissue crater and to fill completely the volume of the socket and to have a convexity instead of a concavity in the coronal part of the socket, I would advise to close on top of the blood clot to prevent that bacterial contamination. And for that, you may use different things. We have used connective tissue grafts from the patient. We have used collagen matrices. We have used membranes. I don't like to use membranes because membranes will not provide me with any tissue thickness. So I would either use a collagen matrix or a connective tissue graft for that purpose.
Some people, they use the periosteum of the patients because of its great regenerative ability. I'm sure you, sir, have a lot more information and
sure. I mean, in theory, from a biological standpoint, the periosteum could be a good membrane with osteogenic capacity and also with a barrier effect, without any doubt. The only problem is that the periosteum varies a lot in thickness. In some areas, it is as thick as a third of a millimeter. No, a third, I mean, 1 or 2 millimeters, sorry. So that means that if I have a very, very thin periosteum, it is not very predictable that that periosteum during wound healing will remain stable, will remain absolutely patent during the whole healing. So I may have areas of that periosteum that are resorbing and are new forming, and therefore is not predictable. So in principle, yes, but in reality, in practicality, I don't think you can trust unless you do very specific periosteum saving techniques. For example, there is a doctor in Italy that utilizes a beautiful technique for bone regeneration using only the periosteum, but still is rather cumbersome, and you need high manual skills to do these techniques.
Well, I really want to thank you, Professor, for being with us today. We are very pleased and honored to have someone like you with a lot of information, a lot of experience, a lot of science to actually help us make clinical decisions based on science. And on behalf of the Saudi Dental Society, I'd like to provide this virtual certificate due to the current situation. And we're very thankful to you, sir. And thank you for having for giving us some of your time.
Dr.
Thank you
Dr.
very
Abdul
much.
Karim, Dr. Abdul
Thank you.
Karim,
Yes.
can I use the chance? Sorry, but this is a hot topic now. If I use the chance because having Professor Mariano with us, can we know his opinion about using the BRF instead of membrane?
Well, exactly the same. The problem with the platelet aggregates is that they resorb quite fast. They have the advantage of bringing growth factors and not so much differentiating factors, but proliferation factors. So I think these platelet aggregates would provide a beautiful environment for soft tissue healing. I'm not so sure whether they would provide an added value for bone regeneration. And as a matter of fact, if you look at the different systematic reviews evaluating the efficacy of these platelet aggregates for bone regeneration is very limited, but I'm sure for soft tissue regeneration, it provides a very good environment. But you need to evaluate whether it is cost effective to do it in your patients. But I don't think it has the long-term barrier effect to prevent or to serve as a barrier membrane. I would definitely use a barrier membrane and perhaps to place platelet aggregates on top of the membrane to improve the soft tissue healing and to prevent membrane exposure.
Thank you so much. Thank you.
Thank you.
Okay. Thank you, Professor Sands, again. And thank you very much for your time. Hope you stay safe.
Thank you.
Hope we see you sometime soon in Saudi Arabia. Thank you so much for your time.
I'm sure it will be a pleasure. Thank you very much.
Thank you. All right, now moving on to our next speaker. We have Dr. Alvaro Ordonez. Just want to make sure that he was with us today.
Yes, I'm over here.
Hey, how are you, Doc? You doing okay?
Very good. Very happy. Very happy. I love you guys.
Thank you for being with us, and allow me again. All the speakers today are really top-notch speakers, and again, you know, it's never enough to say talk about their CVs and their biography. But I'm gonna just select the few things, and then I'm sure your presentation is gonna tell us a lot more about you and your experience. But so Dr. Alvaro got his dental degree back from Javeriana University of Colombia, right? Is that,
yes.
Am I saying this right? Okay.
Oh, good. Perfect.
Okay. Okay. And then he also had his special training in temporomandibular joint disorders at Tufts University. He's also an attending faculty at Tufts and Nova University and so many other universities, including the university that he works at, Columbia. And I've actually seen yesterday your office, your dental office in Miami. Is that right?
Yes.
Okay. It's very beautiful, I got to tell you. Today he's gonna be fascinating us with a lot of information that it's really a very very tough topic to talk about when we're placing an implant. I personally have a lot of questions for you because I don't know, and I think you're the best person who can answer these questions. So without further ado, please welcome Dr. Alvaro, and I'm gonna now stop sharing, and I would like for you, please, to share your screen with us.
Okay, give me a second. Done. Can you see it?
I see. Yep, I see the first beautiful. Is that? Oh, that's Miami. All right. Okay.
No, that's Cartagena in Miami. Cartagena,
Okay.
sorry. Cartagena in Colombia.
Okay. Okay. Cool.
So it's a real honor, a real pleasure to be able to present today. And I want to thank everybody, Khalil, the Saudi Society. I want to thank you. I had the opportunity to visit your beautiful country last year, and I had a blast. I had a great time, and I was very sad that I couldn't go diving because it was one of my plans, but it wasn't possible. but I'm looking forward to go and visit again. I was extremely impressed with the city, with all the developments, with the food. The food is fantastic, man. It's unbelievable. I also went to school with many people from Saudi Arabia, and I have many dear friends that I love. My best friend at Tufts University, very crazy guy. Probably many of you know Alamar, Abdul Rahman Alamar. If anybody know him, please extend a big hug for him.
Great guy. We know him.
How is he doing, by the way?
Last I checked, I think he's doing very well.
I understand he's working in a hospital, running a hospital or something like that.
If we're talking about the same guy, I think, yes, he is the same one.
If he's wild, it's the same guy, right?
He is, but I can't say that out loud.
Okay, good. So this is a new period in our career, in our life. It's a new period in the history of humanity, perhaps. And this is the way we are working now. We're working with respirators in biological suits, utilizing different layers. I have been very involved with the treatment of patients treating emergencies because the governor of Florida closed all the dental practices. And I've been very involved treating dental emergencies, and I have treated several patients that are positive and symptomatic for coronavirus. So you can see over here my assistant and me working on respirators, UV lights. I mean, it's really a trip to do this. I had to design a portable personal air conditioner for the suits because we are inside 3 layers and we sweat a lot. So now we have an internal system that I fabricated at home that recirculates the air, and it pumps out the heat and it injects cold air. It's really cool. Hopefully I'll be able someday to share with you that system. This is Miami. And last year, after I visited you somewhere around the 20th of January, I came back to Miami. And on the 2nd of February, I don't know if some of you know, probably my closest friend in Saudi Arabia know, I was bitten by a shark, by a bull shark, gigantic bull shark, probably 12, 14 feet. And it basically destroyed my right hand. It bit my wrist, broke several tendons, and I had to spend about 6 months of rehabilitation. As soon as I could, I was back in my practice, and I was practicing with the left hand. So since I visited Saudi Arabia, it was a lot of recovery time and downtime, which I utilized to incorporate more digital technologies and different softwares in my practice. This is the doctor that did my surgery, the woman that drove the ambulance, the doctor that rehabilitated my hand. And let me tell you, it was an incredible period of thinking and really trying to put myself back so I could continue practicing dentistry and back to normal. And I'm very thankful to God. And you would say, Alhamdulillah, right?
Yep, that's right.
So one of the main messages that I want to send for you today is that TMJ, facial pain is one of the best places to become humble. It's a very complicated field. It's a field that it keeps you studying, it keeps you practicing. One of the things that I usually don't say when I'm lecturing in implantology and to people that do implants is that most of my cases are cases that started with a TMJ problem, and they were symptomatic, and they had dysfunction, they had limited range of motion, they came here in pain. Yes.
I believe we're seeing a little bit incomplete screen of yours. The right side of your screen, yes, there you go. There's like a column in there masking some of the work.
That's the Zoom column. How do I minimize it? Is it better now?
No, it's better now. Yes.
Okay, perfect. So basically, most of the cases that I present, and I never talk about it, very rarely I talk about it, are patients that came here with dysfunction, with pain, and we had to spend a few months, several months, trying to get the patients back to function, eliminating pain, to then start the second phase, which has to do with reconstructing the dentition and putting things back to normal. In a facial pain center, the main objective is to eliminate pain, restore function, And we have the tendency to work with conservative therapy. Very rarely we have to refer a patient to an oral surgeon. And yes, there are cases that needs to be referred to an oral surgeon, but most of the time there's a mutual benefit working with the surgeons. When the surgeon does the surgery, if we do the appropriate management for the patient, the surgical procedure is going to be more successful. And if we need the surgeon to perform a surgery and they do it right, also the patient is ultimately the person that benefits from the work. But most of the cases we are able to handle conservatively. And I'm talking most of the surgical indicated cases can still be treated with conservative therapy if somebody that knows what they are doing handles the case. However, it's not 100%, and there's a big space for surgery in TMJ. Implant dentistry is one of the alternative techniques, just like orthodontics, just like restorative, to restore missing teeth in these patients or to align some of the malocclusions that are happening within these patients. When we do implantology in people that have had TMJ, we know that our implants and our restorations are going to be under heavy parafunctional forces. They are going to be under attack. And many of these patients have already seen many people. Many of these patients have had many splints. Some of them have very low faith. They have lost their confidence, their faith, and they think that we're going to be just one more person. And sometimes we are just one more person. We don't have the answer to all the cases, and we don't have the answer to everybody's problem. For the dentist, for us, we only become conscious of forces when we have issues. And usually when we think of forces, we think of articulating paper. And a big dilemma has always been, what kind of articulating paper do we use? Do we use the thin articulated paper? Do we use the thick articulated paper? Do we use a stripe? Do we use horseshoe shapes? And my answer for you today is that there is room for all of them. Sometimes we have benefits utilizing thin articulating papers, stripes, but very often we need to use the horseshoe because we want to capture the whole arch. And yes, there are thick and there are thin horseshoe shapes articulating paper. And there's an advantage also in thick articulating paper because when we put it up to the light, we can see translucency in the more intense contacts. And that's a major benefit because it will give us an idea of penetration. When we don't do that and we don't look at penetration in the articulating paper, we are losing a major benefit because most of the time, very often, some of the marks that we get from the articulating paper is the ink touching a tooth, but there's not necessarily a contact. Some of these papers have a lot of ink and we might be adjusting areas that don't have a contact at all. So when we think of forces, we also think of orthotics, of appliances. And when we went to dental school, we were taught most of the time a single device or two devices. And it was the stabilization appliance with anterior guidance. That's the most taught device in the world. Most dentists, as they go through their training in dental school, they learn how to do the stabilization appliance with the anterior guidance. However, utilizing only that device is equivalent to only using amoxicillin to treat all the infections that we have in dentistry. We cannot treat everybody with amoxicillin. There's some groups that are allergic. There are some bacteria that are not going to respond to the amoxicillin. And it's the same with the splints. When we think of splints, we have to think of mechanics. We have to think of what are we missing in a system, in the stomatognatic system. What effects do we want to create to be able to build splints that are specifically designed for that specific problem that that specific patient is presenting? So forces become really relevant when we have a disaster. When we deliver a new bridge, a set of crowns, and we see that things are breaking, things are collapsing, the work is still under warranty, so fixing that is on us. So we have to understand that forces, the best way to deal with forces is to prevent them, to manage them, to divert them the right way, or to even eliminate them is possible. And yes, there are ways to eliminate the forces. Forces have to do with interactions. And the way that forces interact is by opposing each other. Very important to understand that interaction is the whole deal, because depending on the angles of that interaction, the elimination of the force or the vectors are going to be created. And these vectors are going to reflect somewhere within the stomatognatic system, in the head and neck system, even in the head, neck, shoulder system. And these forces, these contact forces, will have an action at a distance. And these are called distance forces. And these distance forces can create in our field problems in the neck, in the ears, in the head. And it's very important to understand this, because when we are dealing with implant dentistry and we're doing all-in-fours and we're doing hybrids and we're doing all this beautiful work that we do, forces are usually having an action, they're having an effect, and they can help us or they can destroy us. So it's very important to understand how to control the magnitude, the direction, the burst, the vectors of these forces. And traditionally, all that we have utilized have been the articulating paper, when in fact we have so many ways today to visualize and control and manage forces. These forces can be balanced or can be unbalanced, and depending on how they are, they will impact what we do today in dentistry. The human body is designed to withstand functional forces. However, parafunctional forces are the ones that create a big problem. And we see that we have so many different schools of thought, so many publications from every ethnic group, from every country, from every school of thought. And what we have to understand is that at the end of the day, what matters is to get a patient better, to help the patient through the issues that they might be experiencing, the pathologies, the suffering that they might be having. And this involves the fact that forces induce remodeling. And when the remodeling capacity is not enough because the forces exceed the remodeling capacity, then we have damage. And when we have damage, we have to handle the consequences of the damage. And very often in implant dentistry, we are confronting a situation like this. We are faced with areas in which the edentulism happened because of the impact of these forces, or the forces were a component of this edentulism. If we only blame it on bacteria and we only look at bacteria, the major problem that we're going to have is that, yes, we're going to build a beautiful implant surrounded by beautiful bone, in a beautiful crown, with a beautiful abutment transition, beautiful soft tissues, but how much stability are we going to have if we don't consider the fact that this person might be having some abnormal parafunctional habits? And if we don't understand how that parafunctional habit behaves within that system, we're not going to be able to protect this system. And that's why our friend Carl Misch developed his implant protective occlusion scheme. The implant protective occlusion scheme that he proposed was supposed to be individual and independent to each implant and each system. And it had to be specifically custom made to protect those areas. He didn't make it universal. He stated that it had to be independent, individual, and it was to be developed after a careful exam and diagnosis of whatever was happening in that system and how forces were impacting this implant abutment crown bone interface. We know that forces are going to have a mechanical load. We know that we can have the damage because of not using a structure. If you get locked and you're not opening and closing, we're going to have problems with the lubrication of the joint. We're going to have changes in the muscles. We're going to have ligamental changes. We're going to have all kinds of anatomical situations. And we're going to have problems at the cellular level too. If we overuse the structures, we are also going to have problems. And when there are forces, we might have micro damage. We can have bone remodeling. I mean, the sky is the limit. And the thing is so complicated when we think that these forces can convert and affect the cellular stimuli that are affecting bone formation, for example, because we know that cells convert the mechanical stimulus into chemical activity. And that's how we know about mechanotransduction. And we have studied mechanotransduction for decades, understanding that the cellular responses to mechanotransduction are variable and give rise to a variety of changes and sensations. And the problem is this: unbalanced forces will induce changes at the cellular level. It will impact the areas in which you are grafting. It will impact the bone surrounding your implants and the soft tissue surrounding your implants. And of course, it will impact your ceramics, your resin, whatever you are utilizing. We also know that forces, as I said before, are going to have an effect in bone formation. And we are very familiar with the role of the osteocytes, with the role of sclerostin. We know that when we have more sclerostin, we have less bone formation. We know how the levels can drop or can rise, depending on damage or not, or injury. And we know about the delicate balance and relationship between forces and the production of sclerostin. We also know that the mechanical stress is affecting the alignment of the collagen fibers, and it affects bone strength because of this same collagen alignment as this new bone is being formed. Dr. Spagnoli, yes.
Sorry to interrupt. I just I texted you how the screen is actually looking. There are few scratches, like highlight scratches, as if you used the mouse, and then there were few scratches. If you can take a look at your phone, you
I don't know where they came from. They are not supposed to be there, so we're gonna have to go with it. I have no idea where they came from.
Doctor, can you stop sharing the screen and reshare it again?
Okay, I'll try.
Yeah, it's on the red button on your right side. I will do it for you. I will stop sharing.
Okay.
Okay, can you share it back?
It's gone. Thank you.
Perfect.
Okay. So just to close this part that have to do with the introduction of forces, in a TMJ center, like the one that we have here in Miami, we have to follow a very delicate treatment protocol. And our main purpose is always to eliminate pain and eliminate also the forces, reduce them, and try to repair the consequences. So we want a patient that doesn't have pain, that is able to function, open, close, chew, talk. And once we have that clean patient, we treat him as a normal patient. And these patients now can undergo any kind of implant treatment or any kind of dental, whatever treatment that they need. Our protocol usually involves an initial visit in which we separate this patient from the group, and we understand if we can treat the patient or not, and we give them a percentage of possibilities of being successful or not. If this patient is, if we decide that this patient is going to be treated by us, we do an electromyography, combine CT, and we also utilize 4D jaw tracking devices, which I'm going to share with you eventually in the lecture. We perform a comprehensive exam, a facial pain evaluation. Most of our treatment is splint therapy, pharmacotherapy, physical therapy, biofeedback. And at the end, again, we go through the final part of the treatment, which sometimes involves implant, because many of these patients have the tendency to lose some of their molars or some of the anterior teeth. One of the big problems is that TMJ presents in different manners, and different specialists have the tendency to see different things, and that might be one of the reasons why TMJ is so difficult to study, because it's very hard to unify the groups. Periodontists are getting the result of one part of the problem. Oral surgeons are seeing a different type of effects in the human body. Then dentists are seeing different effects. So it depends on what are we seeing and what are we treating. So Noshir Mehta has a beautiful publication on something called the wiggling theory, where he explains why are we seeing different situations in TMJ. We all know also that the goal of implant dentistry is to place and restore implants, trying to produce restorations that will resemble nature in form and function. We want beautiful teeth, we want beautiful soft tissues, we want great anchorage, and we want to do the best that we can do for these patients. Now, the first part that I'm going to show you have to do with a patient that came to our office diagnosed with trigeminal neuralgia. Trigeminal neuralgia is a very dangerous type of diagnosis because once you diagnose a patient with trigeminal neuralgia, it's going to be very hard to actually convince this patient that they don't have a trigeminal neuralgia, that what they have is TMJ, facial pain. And the big problem with trigeminal neuralgia is that it is usually a diagnosis made by a physician. When a physician makes a diagnosis of trigeminal neuralgia, he's going to have more reliability at the eyes of the patient than we. We are dentists. They are God. They are big neurologists. You know, they feel empowered to make a diagnosis and not to be contested. So this lady actually was diagnosed with trigeminal neuralgia, was on the very, very aggressive medication. This is a CEO of a company, a finance woman running a major company who cannot work anymore because of pain, but also because of the effects of the medication. She's now doing perfect after 3 weeks on their treatment, and this is what we had to deal with. These are the maxilla, the upper teeth, and the lower teeth. And if you occlude them, you're gonna see that the occlusion of this lady is incomplete because she has no molar support and she's basically rocking on the first premolars. We usually start with a reconstruction. So we have a 3D image. This is called ProFace, and this is the 3D HD scanner of one of the major City companies. Beautiful HD definition that is automatically made, overimposed with the bone volume of the patient. And you can do a lot of things with the software. You can make so many things. It's part of an integrated software that is available now in the market. But very important in this type of patients to be able to overimpose. Look at how she's lacking the posterior upper area and the tremendous curve of speed that she has in the lower, so aggressive. On the opposite side, she's also losing molars and there's no occlusion in the molars and premolars. So we're dealing with somebody that have no occlusion at all. This is the lady when we see it in occlusion, and we can see again, tremendous curve of speed, a deep bite. Also on the other side, we have the same problem. And as we start looking at biomechanics and we look at the midline, we're gonna see that this patient has a dental midline that is not well positioned. But remember, we have two kinds of midline. We have the dental midline and we have the skeletal midline. The dental midline can move because we can move teeth. So the dental midline can agree or can disagree, but the most important midline is going to be the skeletal midline. And if we look at the dental midline, we see that the lower teeth are in one position, the upper teeth are in a different position, and there's about 1.5 millimeters of disagreement in the dental midline. When we look at the position of the skeletal midline, which is usually in agreement with the frenum, with the interincisive frenum, we're going to see that we have a major displacement to the left side of that skeletal midline, which means that if the whole mandible is shifting to the left side, the condyle is shifting as well into the fossa of the left side, and the condyle of the right side is also shifting to the left. And we have a major mechanical problem because now origins and insertions of the muscles are going off. If we look over here, we see this molar in the air, and eventually we're going to see that the premolars are also in the air. There's no occlusion, and there's a major shift. This is a lady that also wants to have her teeth repaired. She wants dentistry as well. And of course, part of what we're going to need here is going to be implants. So if we look at the occlusal plane, we're going to see that this occlusal plane is off as well. We have a canted arch, is higher on the left side, lower on the right side. Now, if you look at the lower, the mandibular occlusal plane is higher on the right side, lower on the left side. It's a crazy crazy situation created by a restorative dentist that decided to fix her dentition without utilizing a face bow, without doing it right. The person was only filling in the spaces. Look again at the over eruption with mesial tipping of this molar in the back, in the posterior. It's very important to articulate models and look at models from each and every single standpoint. Very important to diagnose occlusion. Look at the situation with the curve of SP. Look how this over eruption is gonna kill the whole plane of occlusion if I don't do anything about it. Look at the opposite side. Problems again with the curve of SP. Major problems. It's not just the spaces. It's not just the missing teeth. It's how mechanics affects this woman when parafunctional forces are acting. It's how mechanics affect this woman when the forces are applied and when she goes into eccentrics, which she goes all the time. In this picture, you can even see better the major discrepancy on the midline, because we see over here, it's gonna be in Spanish, so I'm gonna move this part. Now, look again at these videos of these reconstructions and the facial scanner overimpose again with some of the plans that we are starting to build. We are starting to recreate digitally a good plane of occlusion, a good curve of SP, a good table, occlusal table in each one of the molars and premolars. We're starting to offer solutions now to the patient, because now the patient is a healthy patient. It's not in pain anymore. The so-called trigeminal neuralgia, which was actually a spasm of the medial pterygoid and lateral pterygoid, is gone. These are cases that are very grateful. If you diagnose them right and you treat them right, these patients evolve super fast. So now we are presenting a treatment plan, which is going to involve changing all the restoratives, creating a major number of implants, single implants to replace each one of the missing teeth, and it's a very happy patient. So how did we treat the problem to begin with? The problem starts with a good management of biomechanics, customizing the splint therapy for this type of patients. And again, you have a convincing, you have to look at the condyles in the coronal sagittal way, axial way. She's relatively healthy. I don't see major destruction on the condyles. The disc was relatively healthy. The spaces, the interocclusal spaces, when we started working, got better because we repositioned the mandible with the splints. And the whole idea is that we can transfer the dimensions with the new dental work that we're going to be doing for this patient. This is the device that we created for her. We created first a maxillary device in which we extended the area to cover the missing teeth areas. And we tried to create a perfect plane of occlusion. Then we created the lower device, articulating versus the upper device. And now this is a patient that can bite and bite comfortably. This is a patient that can move and she's not gonna be banging on the over erupted molar anymore. Everything have been improved and everything have been excelled. This lady also, I gave her a little extra vertical dimension because I wanted to stretch the muscles. According to muscle physiology laws, when the muscles lose the distance between the origin and the insertion, they have the tendency to go into spasm. And this happens when people lose vertical dimension. If you lose vertical dimension, the insertion of the masseter, for example, versus the origin of the masseter is shortened. The masseter will have the tendency to be more spastic. Once you open vertical and give the vertical back, the muscle fibers are going to have the tendency to adapt, and they are going to usually respond very, very well. The same happens with the temporalis, the same happens with all the muscles. These are apropos of all muscles. So a little extra vertical dimension is going to create this effect. It's going to accelerate the effect, and it's going to help a little bit. If you want me to give you a cook recipe, -1 millimeter increase of vertical dimension usually works pretty well, and it works well for most cases. Of the 100% refractory to treatment cases, about 85% of the cases will respond well with -1 millimeter increase of vertical dimension. This is an appliance that is simple to understand, although it might look confusing. It's basically balanced occlusion. Balanced occlusion is one of the occlusal schemes that exist to handle patients, and we use it on dentures a lot. Well, it's the only occlusal scheme that has been designed by an engineer based on the biomechanics of the human body. And it works pretty well with TMJ patients. It's an excellent occlusal scheme to have as an alternative to manage cases and treat this type of patients. We can see over here that little by little, as we do the periodic adjustment, we go from a mandibular position that was off to a more centered mandibular position, utilizing the frenums as a point of reference for this type of movement. We can see also that the spaces that were edentulous, we extended the area in the appliance to try to give this patient an area that would give support to the mandible as the patient was biting. In the lower, we did the same also. We did an extension, and we were able to go now from an unhealthy patient to a patient that would require corrections. And we start today using these corrections virtually. In the past, we would do a WhatsApp, and then the WhatsApp would be converted into temporary crowns, and utilizing that system of segmented dentistry, we would be able to actually temporize the patient, being able to transfer the mandibular position obtained during the TMJ treatment to a mandibular position that is going to give restorative integrity, but also a good three-dimensional position for the mandible in which the patient is going to be able to function well and be free of pain. This is the proposed plan for the patient. This is the proposed implant treatment that we are hoping to perform. And this is how I advise you to address these patients, treat these patients, be able to explain, increase the IQ of the patient to be able to manage this type of disorders. Let's look at a different situation over here. This is another patient. This guy is a banker from Dominican Republic, very successful businessman. And if we look at this situation, it's a horrendous situation. The patient came about 3 years ago with this situation, and we explained to him that he was 2 years later to remove that tooth. He just wanted me to put a little bit of composite on each one of the sides to be able to stop the wiggling of the tooth. And I said, my friend, I can't do that for you. That's malpractice, you know? But as I took my pictures and as I was looking at the situation, I was wondering why the plaque was only around these tooth over here. The rest of the mouth was relatively clean. I could see some areas with a fraction, and I could see some evidence of forces within this system. The patient decided that he wasn't ready to get any treatment, that his tooth wasn't bad enough. His wife wanted a new house, and he wanted to give her a new house, so he could not spend money in dentistry, so he went away. Then he came back a year later, and now he was able to whistle in 5 different ways, moving the tooth to one side or the other. He could whistle songs, and he was a happy guy. And he said, why would I remove my tooth if I can whistle in 10 different songs in 10 different type of whistling modes? So I had to sit down with him, show him the different images that we had taken. And one of the interesting parts was the localization of plaque. Plaque wasn't the reason of the problem. So I was wondering, how did we get to this point? What was happening over here? And in the meantime, I was doing my Convincity 3D reconstruction, looking at it in each and every aspect, trying to consider alternative treatment because there was a lot of destruction to that socket. If you could see over here, one of the things that I noticed was that he had a lot of keratinized tissue all over around the bone, but also surrounding the tooth itself. So although tissue was a problem, there was a way to work with the tissue that he was presenting. So in that sense, I was a little bit less concerned. He had 2 different layers of keratinized tissue. So again, in this type of cases, we always have to start wondering ourselves, what happened here? How did we get to this situation? Why it happened in only one tooth? Why didn't it happen to other teeth? And we have to understand that we are confronting a devastating damage in the alveolus. And the problem is not just soft tissue. We have hard and soft tissue in the worst place in which can happen with a person that is a terrible patient. And we see that some of the adjacent teeth have suffered the consequences of this specific problem. So then the next question is, what can I do about it? And once I remove the tooth very carefully, I see that, yes, I have keratinized tissue here, I have keratinized tissue here. So in a sense, it's not that bad, you know, it's relatively good. Then the question is, how do I protect the implant that I'm planning to place? How do I avoid this problem from ever happening again? So I need a diagnosis. And the diagnosis is trauma from occlusion after a careful exam of this person. And in trauma for occlusion, there are two different schools of thought. It's the school of thought of Ramfield and Ash back in the 80s and the school of thought of Kao in the 90s. Two different ways to look at the problem, two different conclusions. And it's important always to look at different researchers and different reports, because it gives us also a different perspective in how to look at things and how to manage them. So I happen to like more the approach of Kao, because Kao was very, very, very proactive. And to manage a problem like this, we have to understand what frenitus is. We need to understand how to diagnose it, but we also need to understand how to handle it and how to prevent whatever solution that we're giving to this patient. And it's very common. This is a different patient. This is another patient that got a root fracture because of the same exact problem, but he could not eliminate the root out of the socket as it happened with the other one, because the root broke before it got to that point. So we had to do the extraction, put some cortical cancellous bone, place a membrane, and then go through the process of placing an implant, placing a restoration, and look at the adjacent tooth, look at the crack. These crease lines are very important signs of forces being present. The crease lines are created by clenchers. The grinder don't create a crease line. The crease line is specific, related to clenching, not to grinding. Grinding creates more wear facets. It doesn't really create bad crease lines. Some patients, they grind, they clench, so they are going to have both. So we have to understand that we're dealing with three different types of problems. We are dealing with a patient that can clench. We are dealing with another different patient that can grind. And there's a third class that they do both. They grind and they clench. So again, we have to be very familiar with everything related to trauma from occlusion. We need to learn to recognize it. We need to learn to diagnose it. And then we need to learn to manage it. And we have to understand again that disease is not always group specific. It's specific to the individuals. And that's why we have to conduct very careful, very into detail exams. And in this sense, digital is a blessing today. Digitalizing yourself help you to conduct better exams and better treatment plans in your patients. Occlusion also, you have to understand that the concept can be super simple or it can be super complicated. I have the tendency to follow more Jablonski, because Jablonski is more comprehensive in the concept of occlusion. And I believe that occlusion have the power of affecting remote areas of the anatomy of a human being because of domino effects. We also need to be familiar with the role of the forces in the individual tooth contact. And we have to understand that when we have parafunction, we are increasing 10 times the episodes. So if the normal force is 25 pounds in the first molar area, and we increase it 10 times, now we're talking about 250 pounds per episode. And they have recorded 30 to 40 minutes per night per episode. Imagine. So 250 pounds all over the night being applied to the dentition is a major destruction of the whole anatomical structure that have any kind of relationship with this type of anatomy. So let's see how we handle a situation like this. We go through the process of doing an atraumatic extraction, cleaning the area, removing the infected tissue, irrigating copiously with saline solution, and we go ahead and we grab the socket. I'm a big fanatic of this membrane, because this membrane, I can leave it exposed and I know that everything of the biology is being developed under the membrane. It's a membrane that gives me very little complications. I've been using it for many years and it's a happy story. I am a big fanatic of nylon suture or PTFE sutures that can be clean and that can keep stability of the suture area. This is 4 months post-extraction. Ideally, I should have waited a little longer, but the patient now was driving me crazy that he wanted everything to be finished. We go through the process of doing the incision design, and I decided to extend the incisions because I wanted to explore the adjacent teeth, the two adjacent teeth. I go through a process of Osseodensification with the Versa burrs of Dr. Weiss. Sala did a great contribution to dentistry developing these burrs. And then we go through the final burr of the implant kit. And I happen to be a big fanatic of zirconia implants. And zirconia implants have had a tremendous development lately. Now they are very similar in surface treatment. They are very similar in components to the titanium implants, which with some alternative advantages. And these alternative advantages for some people are very important. The results of utilizing Osseodensification are obvious in an area where we had no socket at all. And now we see that we have a socket that is almost 3 millimeters wider than the adjacent sockets. So Osseodensification obviously works. And if we use Osseodensification combined with grafting and with some other techniques, we get to develop good implant sites in areas where we had no bone at all. You saw the before. So it's a great thing. Now, in reference to forces, I'm gonna at the end show you the physical properties of zirconia implants. So zirconia implants are big competitors today, especially in the anterior segment. Of course, we have to do a careful management of soft tissue because we don't have any tension. So we go through a periosteal incision, a careful dissection. I go inside with either scissor or needle holder or whatever. I go close and then I open to do my dissection until I get good reflection of the tissues so I can cover, graft again. I wish I would have put another TXT membrane instead of a collagen membrane. I think I would have got even nicer tissues over there, but I decided for whatever reason to go with a collagen membrane. But again, if I had to do it again, I would go again with a TXT in this case. I'm a big fanatic of utilizing cortical and cancellous bone because I have the two parts of bone formation, the two components, the two main components. And in this case, also PTFE suture. PTFE suture, for those of you that are not familiar with it, you have to do multiple knots. So we usually tie 6 knots per suture because it have the tendency to give a little bit. And this is the patient several months later. It's a beautiful recovery of the area. What we see over here is a little bit of some of the bone particles that was in that area. That goes away. And again, look at this. The area where we did the graft and the Osseodensification is wider, thicker than the adjacent areas. Osseodensification plus grafting works very, very good. Good position of the implant. We go ahead and we take the normal open tray impression. Look at the different positions for the cosmetic analysis. We know that we're going to end up doing a little gingivectomy. And again, this is not only a very bad non-compliant patient, but he also lives in Dominican Republic. So it's a problem to do the follow-up visit. But this is at the time of the delivery, and we do the gingivectomy. And we can see before and after, right after the gingivectomy, this case has been stable now 2 or 3 years. This was the first 2-piece zirconia implant placed in the whole American continent. It was done on this person for this specific case. Very happy with the case, very happy, patient very happy. He keeps on sending me a picture from his iPhone, which are not good enough to show over here, but it shows a beautiful system, a beautiful wife also, and he's very happy. But again, a terrible patient. So what do we do about occlusion? Because again, occlusion was a part that made his problem worse. Occlusion was a component that exacerbated the whole situation. So the T-scan is a perfect device to utilize in a situation like this because these patients bite, and we're gonna get not only the position of the contact, but the intensity of the contact, and we're also gonna get the center of forces. We're gonna get an average center of forces, and we're gonna be able to try to position the center of forces and study the closure mechanism. We can see that in the beginning, this patient was in the beginning hitting in the front. That's why the center of forces start more on the front. And as he's going into full closure, the center of forces displaces to the back. So what I had to do was that I had to alleviate the contacts in the front to try to eliminate this trajectory, this displacement in closure, to try to bring the patient to the perfect center of forces as fast as possible without having to have the frontis engaged in the closure mechanism. And this is the same occlusal balance, the same occlusal scheme that I showed you with the first patient. This is balance occlusion. This is a patient that closes from anterior teeth to posterior teeth, from canine to molar, and it have saliva contacts. And when he goes in excursions to the right, everything is gonna touch to the right, also from this contact to the right. And when he goes to the left, everything is gonna touch. So everything is gonna be helping everything, and it's gonna keep very good interarch stability, excellent occlusal scheme, and he's not gonna be hitting the anterior teeth. So he's gonna be protected when he's sleeping. Yes.
Just a quick reminder, we have another few minutes and then we're going to have to wrap it up. So we have a lot of questions from people, a lot of good questions, and we really want to accommodate as much as possible.
No problem. How many minutes do we have?
I believe we have another 2 minutes.
Okay, hold on. So let me get to.
Okay.
Let me get to something that I want to share with you over here. So one of the biggest advances that we're having now in digital dentistry, some of you may or may not be familiar with it, is the part related to 4D. I don't know if there are 4D devices already in Saudi Arabia. It's possible, but the reality of 4D is that 4D have been available since the 90s. I was in charge of testing one of the main devices for 4D as I was doing my residency at Tufts University with Dr. Noshir Mehta. And this is the new 4D device that we have in our practice now. And it's really been a major impressive device that is gonna change dentistry. Once they get it going the way, and they are around the corner to get it going, dentistry is gonna be changed forever. Because all our occlusal designs are gonna be perfect. Teeth are gonna come adjusted, and any additional adjustment is gonna actually be minor. So we are around the corner to get into fully adjusted devices. And this is what I'm talking about. So 4D was envisioned by Schuyler and McCollum in the 70s. And the Stuart articulator was the first 4D device that we had. It was, all this was envisioned in 1956. The problem with the Stuart articulator, it never really took off in dentistry because it was very difficult to learn. And ever since that, dentists have been trying to create the 4D devices. And the 4D, it's the actual 4D is a combination of a facial scanner with the Convincity volume. Beautiful machine, and it acts pretty much in the same fashion of the dual scan, the technique that we were using to scan dentures. So now we are scanning the patient, then we're taking with these devices, with the glasses and the intraoral positioner, we're taking a facial scan. And we connect 2 and 2 and the Convincity, which is the bone volume that we're getting from the Convincity. So once we tell them we have a patient that have been communicated, and we get this type of situation in which we can observe with very detailed, pinpoint detail, the movements of the mandible and the movement of the occlusion. Therefore, we can build in the future, not right away, crowns, bridges, structures, whatever we need that is already adjusted perfectly in centric and eccentric. This is gonna serve as a digital articulator because it's actually the same patient. These have soft tissues already in mind because this is a composite. You can see the Pocel diagram in the different aspect, in the sagittal, coronial, and axial aspects. You can see border movement of the mandibles, but now it's not in the Pocel diagram anymore. It's in reality. How we start rotation and go into translation. We can see opening and closing and study deflections. There's so much that we can see today with 4D, and it's a very important tool to have. And it's all now dictating what is going to happen in the future. I predict that in the next 2 years, we are going to have major advances, and most of those milling machines that we have, milling crowns, are going to be milling after designing the occlusion in one of these devices, considering every single aspect that have to do with every single possible movement that we can do, because we're going to pre-record the movement. This is a laterality, and we know that in laterality, one condyle is rotating and the other condyle is translating. And as a result, we can see how the teeth respond to that in different areas. So we're going to be able to adjust working and non-working contacts, or adjust our guides, our anterior guides. Many of you may remember the Bennett movement and all the different aspects related to occlusion, like chewing, swallowing. And again, I just send you an invitation to get involved with this digitalization of dentistry and this digitalization of occlusion. Hopefully, I will have the opportunity to share with you many more of these cases as the time was short. And I understand that this is a very long lecture, because it's a lecture that I've been presenting in about 3 hours. But I'm very honored that I had the opportunity to speak to the Saudi Dental Society again. I'm looking forward to go diving in your beautiful country very soon, because I know you have fantastic diving spots. I still have my visa active, and I send you a hug, and inshallah, you like my lecture.
Well,
I love
thank
you guys
very much, Dr. Alvaro, for the very nice presentation. I mean, you skimmed through the last slides, and you kind of broke my heart, because I saw a lot of good cases, and I wanted to see the how did you manage those cases, and I learned from you. But we're really thankful for today. We're just gonna have just a few questions before we start with the next presenter. In brief, what's your thoughts about number of implants in patients with parafunctional habits? Some people, they say, I'm going to do 8 implants, for example, to rehabilitate that patient, just because he's a bruxer. If he's not, I would probably. What's your school of thought in terms of that?
Well, I finished the TNJ program back in 1996. I spent 3 years with Dr. Mehta. And in the meantime, I was doing a minor in implants with Dr. Arnold Rosen. So I started placing implants in 94. And I got that niche of the patient with parafunctional habits. The patient that have parafunctional habit needs a lot of anchorage, needs the longest implant you can place and the widest. The wider implant will give you wider stability, and you're going to be able to build very good occlusal tables. So a molar is going to look more like a molar, and it's not going to look like a light bulb. You know, it's not going to have a skinny base with a very wide crown. So I like wide implants and long. I like a lot of anchorage, as much anchorage as I can get for those implants. It's very important, because once they start getting the forces, anchorage is what's going to fight the force once the patient is exposed to the force. We utilize a lot of Botox in the masticatory muscles, and many of these patients have been coming to us for 20 years to get Botox periodically, twice a year, 3 times a year, to try to keep the forces under control, because some of these patients simply cannot stop clenching. So we put the Botox to minimize the forces, and we use a lot of EMG. So we know that Botox reduces the forces 40 to 60%. The other 40 to 60% that we were not able to eliminate with the Botox, we have to manage by keeping the patient on a spleen, by building good occlusion schemes. But my advice is always as many implants as you can place, as much anchorage, as wide, long as you can.
Thank you. Very clear. Another question came in, very good question. You know, when you deliver your final prosthesis and you come and see the patients for follow-up a couple of years down the road, you would see that their occlusion kind of changed. Why do you think their occlusion is changing?
I totally agree. That's a major truth. Occlusion is not a static situation. Occlusion is a dynamic situation. And occlusion is dynamic in each and every patient, regardless parafunction. Occlusion is dynamic because occlusion have a lot of dependency from muscle. And you know, muscle activity changes. One day
Right.
your muscle can have a little bit of more tension or less tension. And remember, what elevates the mandible into closure is the muscles. So if muscle changes, if muscle tension changes, occlusion is going to change right away. The first contact of occlusion is going to suffer and it's going to feel the impact most of the time. So therefore, patients have to be evaluated periodically. And that's one of the things that we do. We evaluate our patients periodically. We do very frequent follow-ups on the patients to try to keep them stable. We try to keep these appliances because they all have an appliance at night. And some of them have appliances during the night and during the day, one on the upper, one on the lower, because we know, we are aware that occlusion changes. So we always evaluate occlusion. I see Dr. Tarnow looking good back there. Big hug for you, Doc.
Well, again, the questions are so many, Dr. Alvaro, and we're very appreciative for the material that you shared with us today. We're very thankful, and I have to say, thumbs up for you. It's such an inspiring story. I mean, the most valuable part of a dentist is his brains and his hands. And coming up after this incident, the shark bite, some people, they will just stop doing things. But I do think that you're probably going back to the ocean and you still want to swim again. So that's courage and bravery. So thumbs up for you, and thank you so much. And on behalf of the Saudi Dental Society, we'd like to, can I ask you please to stop sharing your screen?
Where do I hit it?
Okay.
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 Perfect.
All right. And we're very thankful again, okay, for the opportunity. And let me see that. Can you see that, Dr. Alvaro?
I do.
Okay, so please accept this humble appreciation, token of appreciation to you, a virtual certificate because of the current situation. Again, thank you so much for being with us, and I do urge you to stick around, as the next speaker is the most known speaker, I have to say. So thank you again, Dr. Alvaro, and I'd like to just smoothly transition into welcoming our next giant. Dr. Tarnow, are you with us, sir?
I'm with you. Can you hear me?
Yes, sir, we can. How
Great.
are you? Doing okay, sir?
Great. Shalom Aleichem.
Assalamu alaikum, sir.
Assalamu alaikum, yes. Assalamu alaikum.
I actually had the honors and the pleasure to actually see you back in 2012 in Loma Linda. And I never miss any of your lectures. And again, allow me just to spend a minute just to go and try to, as a formality, to introduce such a great speaker, mentor. And, you changed a lot of things in dentistry and implant dentistry and periodontology. So whatever I'm going to say is never going to be enough for you, sir.
But all right, you can skip it. It's okay.
Again, Dr. Tarnow is known for all of us. He's a clinical professor at Columbia and previous chairman at NYU, and he changed concepts in a very simple words. He's the guru. He's the giant. So again, without further ado, Professor Tarnow, please, thank you very much for accepting the invitation. And I'm going to stop sharing, and so you can share your screen too.
Okay. Kareem, thank you so much. You can share my screen, or I'll start again. Okay.
Please, if you may, sir, go ahead and share your screen. Okay.
Okay, I think that's coming up now. Good. Is that coming up okay?
Yep, that's pretty good. Yep.
Great. First, assalamu alaikum. I want to make sure that everybody is safe and everyone is safe. When we see cases like this, it's kind of scary. So what I thought I would do today, usually I give a lot of lectures on when to place an implant and how to place it in immediate sockets. And we have Dr. Chu and I just wrote a textbook for quintessence that you can look at for that. But when I see things like this is just horrendous, obviously. You have a situation where I don't know where this person was when he was trained, or if he was ever trained. Hopefully he did it on his own, because this is just a horrible thing. I want to show you today about the interdisciplinary approach to these problems. I want to give credit to my great team in private office in New York, in Manhattan. We have Dr. Chu is well known to many of you, but these are all Dr. Brown. They're all prosthodontists, periodontists, or orthodontists. Mark Hockman, an orthodontist, which I'll get to at the end. Dr. Fletcher, Marion Brown, John Zamzak right here, Guido Sanacchiaro, and Richard Smith. So most of the work was done with a combination of these people. All the surgery you'll see was done by myself. Prosthetics was done by multiple people in that group, and the orthodontist was done by Dr. Hockman. So I want to give them credit. I also want to give credit to the great group of technicians we have in our office, particularly Adam, as you see here. Adam is a master ceramist, and you'll see some of his work today. I want to give him great credit. And I want to say hello to all of my alumni. This is just a few of them, but first, Khalil Ali, I want to thank you for inviting me. Abdullah Al-Qiyadis, thank you for that. Amal Al-Simi in the middle with me, just wonderful people. I see Mohammed there also. I just want to let you know how wonderful it has been over the years to have alumni from our programs over the years. And today we have one more finishing perio program, and that's Sultan Al-Bashri, and we look forward to having him go back, I know, but next year. I know he's been accepted to Tufts for an implant program, but he's finishing the perio program. Wonderful, wonderful student, just as all of you were. So I wish you all the best. I want you to know that we still love you and are always in my thoughts. It was great being in your country a few times. So let's get to the work. Let's take a look at the variable situations. Obviously, we have a situation where you have the patient is always part of the center, the center of this. You've got the prosthodontist or the restorative dentist. You have a periodontist or a surgeon or a generalist or a prosthodontist who knows how to do surgery. That's the other, whoever does the surgery, and an orthodontist. And that combination is going to be what I'm going to focus on. So first, I'm going to focus on what the restorative dentist can do by him or herself. Then we'll bring in the surgical aspect, and then we'll bring in the combination for the most difficult cases at the end, where we talk about all of these things and put it all together, okay? So first, for the prosthodontist or restorative dentist, you take a look at Greg, and I always like using Greg as an example of something. Greg came into my office, and these are the kind of problems that I see all the time. The sad part is in our private office, 65%, about 2/3 of my cases are redo of other people's work. And this is why Dr. Musa was so careful about saying, know what you can do. I couldn't agree with him more. Know what you're capable of and don't go beyond it. Now, this was done by a periodontist, actually, who had the training, but he did a couple of mistakes. He put the implant too close, and every time he repaired it, it got worse. He tried to repair the papilla. And we're going to come back to that papilla problem during this lecture, because it's a major, major factor, as you will see, in these cases. So what I want to look at is obviously he's got this flat triangle, but the real problem is that he's lost attachment on the mesial of the lateral. So the only way I can rebuild that, I can't rebuild that surgically in any way. Look at the papilla on this side. Can you see my mouse? Is it showing up on the screen? Can you see my mouse? Does it move?
Yes, it's very clear.
Okay, good. Good. I just want to make sure. Thank you. So when you look at it, look at the height of this papilla and look at the height of this papilla, almost 3 or 4 millimeters off. So what I want to do is I want to bring this down, but the only way to bring it down, I can't surgically recreate it, not like that, not on an intact tooth. The problem is he's lost attachment here. So we're talking about forced eruption. We're talking about devitalizing it, make a new crown, bring the tissue down, because the tissue will, as you all know, the tissue will stay attached to the tooth. As you bring it down, this papilla will start to come back. We'll show a case like that later. But that's the problem. And I went through all this discussion with him, and he said, at first, I just met him, for a consult. And he said, "You're not listening to me." I said, "Well, we can do all of these things. We can bring this tissue down. We can orthodontically erupt the tooth. We can devitalize it, put a crown on it, then close this over, redo this, some soft tissue." And he says, stop. I said, "What do you want me to stop for? I just met you. I'm telling you, you want to fix it?" He says, "I just want you to fix this hole, but listen carefully. I hate you guys." I said, "You hate me?" I said, "I just met you. What do you hate me? I'm trying to help you." He said, "I hate all dentists, because every time a dentist has touched me, it's gotten worse. So I don't want you to touch anything. I don't want you. The only thing I want you guys to do is to put a new crown on, that's a temporary, put a new crown on and close the space. I said, well, what about over here? We could do a little bonding maybe just to close that volume down, blend it in better. I think we can help you that way. He said, no, I'm not letting you touch anything. So I said, you don't want me, you want my partner, Dr. Chubes, and the technician, Adam. So we came up with this oddball concept. I just want to show you prosthetically what sometimes you could do. And so Adam came up with this ceramic material. Notice that it's got a big bulge because he wouldn't let us do any bonding on that cavity. You had to go in at an angle. You have to almost hold it at an angle to get it on, squeeze it on. And here's what it looks like. And this is what it looks like in the mouth. Now, I'm showing this to you because, he looked at it and said, see, I told you you could do it. I said, great. I'm so happy that you're happy, because he looked like this. He looked like that. That's a smile. Now, I'm glad you're happy, but here's the rule. I said, if anybody asks you who does your dentistry, you don't even mention our name, okay? Because this is horrible looking. But for him, it's better. I mean, it closed the black space, but that's disgusting looking. And it didn't meet what we would consider high quality dentistry. Even though it was quality, it just was a fake pink. So but he was a happy patient, even though he came in angry and hated all dentists. Then he was happy because we did it what he wanted and we met his needs. So always remember that. All you young people out there and young clinicians, always meet the patient's chief complaint as long as it doesn't violate dentistry. And this is what he looked like. And so that's what happened to him. Let's take a look at another case. A strictly prosthetic. Now this is Gavette. She came to us I'm in New York, and she came to us from Boston. And what you see here is this huge defect. She had a big periodontal abscess, and the periodontist cleaned it up, but there was obviously a lot of attachment loss. Now, no question that she will need eruption, devitalization, two new crowns on these teeth and all kinds of stuff. But Gavette, unlike the first guy, by the way, Greg, the first guy, he had a lot of money. Money was not a factor. He was just emotionally completely spent. Gavette was a graduate student. She didn't have any money. She didn't have any money. So we came up with something for her, even though we told her what we had to do with all that, but she couldn't afford it. So the eruption was too expensive. So what we wind up doing with her, we came up with endotherapy, crowns, instead of crown length, all this stuff. She couldn't afford it right now. So what are we gonna do? So we came up today, we have different pink solutions, don't we? So these are different gum shades. So what we decided to do, just to kind of keep her going until she could afford the real dentistry, we first started with the gradier gum. We had different shades. And when I grew up in prosthodontist, I'm a periodontist and a prosthodontist. Most of you know me as a periodontist, but I did my own prosthetics, and I was trained in prosthetics also, and did my own prosthetics for the first 15 years of my practice. But what you look here is I only had pink, one shade of pink repair acrylic, used to call jet repair acrylic. Today we have all these pinks, magnificent, both in ceramic as well as acrylic. So we tried it with indirect composite. We filled that up, and when we put it in, just with some composite, we realized, my gosh, that can look a lot better. And this is below the smile line, so it didn't show the line. So even though she had a high smile line, we got away with this. So we liked this, and she was ecstatic. So that's good. So what we did was Adam made it into ceramic, and then we could bond this piece, and we bonded it only to the lateral. Otherwise, you would never clean it. You only bond to the lateral. So she had very good hygiene. This is not for everybody, but it shows you what's possible, at least in a temporary situation. And here's the ceramic going in. We bonded it only to the lateral, and then we showed her how to be able to go over the top and fill and clean that space. And then we keep an eye on it, and we'll see how it works out. And she did this, and this is now, the tooth was already bonded from the previous periodontist, but it filled up the space in there. And this is what she looks like. This is a 1-year recall. And when you look at her, you could never see her. This is what she came in with on the left. And this on the right side of the screen is what she looks like. You'd never notice it, even as dentists. This was a good masking and color coordination because it was thinned out and it was right at the lip line, was covering it. So I think we have a situation which was quite tenable, very good for the patient. We know that she comes in every year, and she comes in every year. This is 1.5 years. It's now been 3 years, and it looks the same. And we check for decay, check for periodontal problems, and she's been fine. And she's finishing her graduate program soon, and hopefully we can do something else. But right now, she's got such good hygiene that it doesn't matter. She's maintainable, and she feels great about herself. So it shows you strictly prosthetically what can be done. Now let's take a look at Mary. Mary's got a problem. That's her smile, and she shows this black abutment, as you see here. And now the bone was healthy on the implant. I'm going to come back to this concept. The bone was healthy on the implant, but just as like Dr. Boozer said, what's the biggest problem? As you all have seen, most of the implants that are placed too far forward are the problem. It over-contours the restoration, and with over-contour, the tissue moves up. So that's what happened here, as you all very, very familiar with. So just like Dr. Boozer showed so well, you've got to move this back. But the implant's healthy, though. We'll get to unhealthy implants in a bit. She had this for 8 years. She walked around like this. Now, you know, she was told, well, the implant's okay, it's integrated. Sorry, that's the best you can do. That's what she was told by her dentist. But Arnie Weisgold showed us on teeth in 77 that you can excessive contour moves tissue up. Now, this is what we look for. When this patient walks in, what's the first thing I do? When she walked in like this, and she has a problem on the buccal, first I look at the health of the implant. But what's the next thing I look at? I take a mirror out, and I look in the back of the mirror. What am I looking for? I'm looking at whether or not there's palatal tissue. If there's palatal tissue, now we have a different situation. So we take, there it is. We're going to take it off. And here's the key. And many of these implants do have palatal tissue. That makes it easier. It's not perfect, but it makes it easier because this is your blood supply for height right there. And the fact that it was deep enough for us to make a correction change in the angle, if we get extra tissue there, we can make a correction change, bring it in towards her, and then towards the palate. But this blood supply and the papilla are normal. So that's good. I don't want to touch the papilla. Now, Bert Langer deserves a lot of credit for many things, but one of them is this decoronation technique in 1994. Before he took a root out, he would decoronate it, and we'd have extra tissue grow over the top. So we started with that. And then in 2 weeks, the tissue kind of grows over it, under contour, and that's what it is. So we did the same thing here. Dr. Chu and I published a paper on this. We called it decoronation of an implant, like Bert Langer called it decoronation of a tooth. The decoronation of an implant is easy. Take off the abutment, put on a cover screw, and let it heal over to an extent. It gives you extra tissue to then do some surgery if you need to. So there's the whole thing is right there. That's the key, the palatal tissue. Put a cover screw on, as you see here, and put a bonded bridge on without any pressure. Not an ovate pontic. You leave it sitting out to the space. We just spot etch it. We do not drill on the adjacent teeth. And this is what the bonded bridge looked like that day. So we just made a little bonded bridge, leave the space open to fill in by secondary intention, and it will fill over. Now, I had to come back in 2 weeks. I had to come back in 2 weeks for me to be ready to do the surgery. You notice we went from this to this. I said, well, I was ready to do the surgery, like a connective tissue graft and submerge the whole implant. I got extra tissue, but I said, let's just let it go a little longer. And so I de-epithelialized the 2 corners and let it heal a little bit longer. And in 2 months, it looks like this, even better. So then this is the implant decoronation article. We published that in 2013 in Compendium. And you can see, look what happened. Wow. So we started with this, put a cover screw on, let it heal, and it heals over. Now, listen carefully. This is very important because the palatal tissue is there. It all fills in with keratinized tissue. This is Mother Nature's connective tissue graft. Beautiful. I love it. Now, there's always, listen carefully, when you do this, there's always a hole. You may not see it right away. There's always a small hole in there. Why? Because the cover screw, you put a cover screw on, don't leave the hole like this, but the cover screw has a little screw hole opening, and it covers with bacteria. And although the tissue grows over, it'll never completely close over because the bacteria in the screw hole, a hole of the cover screw, allows it never to close. It's always there, unless you surgically clean it and cover it surgically. But this is letting nature fill in by secondary intention. So look at that extra tissue, and look at the extra tissue we had. Now, because it was deep enough, now I have something I can work with, but I got to expose the implant, which is a little too far forward. So we just make a little releases. We want to flatten the abutment. Just make a little release, just enough to get a flat abutment on. Do not put the temporary on, because otherwise, notice I did papilla sparing. I just did a little opening just to create an opening, and then they still let the bonded bridge stay on. And here it is at 1 week. This is so no grafting right now. No, it's going to go up because there was a hole there, of course, where the abutment is, and then it's going to round off. And then we started doing some tissue sculpting with some pressure and decrease the pressure in the front, a little more over here, a little less over here. Then the temporary pushes the tissue up a little bit, but very thin in the front. And here's some vital bleaching. This is 14 months later. We wanted to see, she was ecstatic because she had a big black hole there before. And so now we went from this, see, this is what we started with on the left, to this. And that's where we are. So where we do, that's 4 millimeters of tissue that we gained just by decoronation and pushing and using an abutment that was very shallow. And so, and the tissue thickness was 1 to 1.5 millimeters. Now here we used a zirconia base, zirconia abutment on a tie base. Then we put that in. This is Dr. Chu to this, flattened it out, really flat, as you see here. The depth is what allowed us to make that change, even though it was coming out the bucket. And so we put that on. This is Ronald Jung shows you, 1 to 2 millimeters of thick tissue. And here is the final case. Now, I never did a connective tissue graft here. No connective tissue graft. And here's but she was a healthy implant. And how does it hold up? Here's 10 years later. So that's the case 10 years later. So even without a connective tissue graft, just letting Mother Nature fill in her own tissue, we're able to make this work. And obviously we're successful. Now, not all cases you get this. This tissue was particularly thick and allow it to come down. And the contour of the tooth wasn't too bad. It was not great. That's what caused the recession to begin with. But now we have a situation where we got the extra tissue and we're really cooking. So I think this shows you where we are with this. So let's take a look at, so then what about if you need surgery? Let's take a look at another midfacial. Now, Sarah's got a high smile line. I'm only showing you front teeth with high smile lines. Sarah's got a huge high smile line. And she's got very bad tissue up there. It's thin, she's got a depression, but the implant is solid. But what do I look for? What am I looking for? Now you got it. I'm looking at the palate. When Sarah came in, I just don't look at the front. Obviously, we know what the problem is. Recession, implants too far forward, all the classic things that Dr. Boozer showed and that we all know about. But I look at the palate to see how much work I'm going to have to do and whether or not it's going to be an easy case or not. That was a tough case. But it's easy enough because I have the implants high enough. You'll see in a moment the implant is healthy. There's no periodontal disease around it. And I have this what? Palatal tissue. Delicious. When I see that palatal tissue, nothing makes me happier because that means I've got vertical blood supply and I have papilla that are intact. We'll get to that in a few minutes. But look at the angle. This one is way off compared to the previous one. Now, today, I'd probably take this one out because I didn't take it out then. This is many years ago. I didn't take it out because at the time we didn't have reverse torque machines. Now we have reverse torque machines. And instead of doing a trephine or trying to take out a whole piece of bone with it or destroy the ridge that's there, this implant was healthy. I wanted to try and work with it. And today I probably would take it out because it's pretty far out. But I want to see what we can do because it was deep enough to be able to make the turn flatten the contour. Let's take a look. If it was too shallow or if it was diseased, we'd take it out for sure. Let's see what we did. There's the angulation. And we didn't even have cover screws for this patient. This isn't our patient. We didn't have so we found something that at least went on. We decoronated it. I put it on. Here you see it here. Steve put a bonded bridge on, as you see here. Okay, put a bonded bridge on, sorry. Look what happened. This is 3 weeks later. This one I know I'm gonna have to do a connective tissue graft of some type. But take a look at the hole. See, the hole's more obvious here. That's because that cover screw has the bacteria in there. And when the tissue grows over from the sides, it never completely closes because it's got bacteria from the mouth that slowly, as the tissue comes over, it causes a drainage, like a little fistula. So after 3 or 4 weeks, but look at all the extra tissue I have. Which would you rather do surgery on? This left one? No, I'd much rather do it on the right one. Now I can make an incision down at the crest. Here, before I'd have to take this tissue and bring it down and the alveolar mucosa with it, even if I did a graft. Now I can make an incision down here in this patient's own connective tissue. I don't have to change the mucosa, the mucogingival junction, and that's what I did. Now, what I do here is I do a papilla sparing incision, and this is very important. Now, this is controversial in some circles. I know some people like to open up big flaps. Some of the previous speakers will open up all these other teeth in some way. I don't do that. Not everybody has the skill of a Dr. Boozer, and so be careful with that. So what I do, I like to do if the papilla is there, I leave it there. I have an entire practice. I mean, 2/3 of my practice, not all of it, but 2/3 of my practice is redo of other people's work. You want to know what the most problematic one is? Too far forward, which Danny showed you, but the papilla loss. We're going to get to that in a few minutes. The papilla loss is the other problem. And a lot of times, in fact, most of the time, it was caused by an inaccurate surgical procedure done by a surgeon who didn't know what they were doing. When I say surgeon, it could be anyone. And so this is the problem. And even if you're a good surgeon, even if you're the best surgeon, you're opening a flap, you're opening that bone underneath that papilla, it can resorb. And we know that about 0.5 millimeter gets resorbed every time you open a flap at the crest. So Staffolino and others, we know this from perio literature from 35 years ago, nothing new. So every time you open it, you do it. So leave it there. Can you do all the surgery without opening it up? Yes. That's what I did here. So I took a very thick connective tissue graft from the palate. This is a big, heavy, thick graft, as you see here. Place it in, closure, and notice as this is 3 months later. Now it swelled actually a little bit. In fact, the ovate pontic, which was just barely near it, became a little pressure point, not a problem. Now the biggest problem is this, stage 2 uncovering, because the implant is so far forward. The implant is so far forward that if I'm going to do papilla sparing, which I still want to do, it's hard to close these verticals. You know, you're not going to close them. So you don't put a wide abutment on, you put the narrowest, flattest abutment. Whenever you have a healed ridge and you're exposing it, always in the aesthetic zone, always do minimal openings. Now this one's going to get pushed forward and it's going to have to fill in a little bit. Now that's not going to be a scar, it'll be a groove. It might be a little groove. Attached gingiva doesn't scar. Gingiva does not scar. That's why we can do a gingivectomy and you never see a scar. 2 months later, you don't see where you did your gingivectomy. So remember that. What you're looking at here, the mucosa scars up high, but attached gingiva does not scar. And that's what you're having is a groove, but it usually goes away on its own, or it can be plastied later. So this is pushed out, and then you wind up, then 4 weeks later, then we wind up contouring it. Then Steve makes it temporary, fill in the void, attach it. It's deep enough, you see, to hold on to this tooth. See the extra depth, and that's the key to be able to make the turn. So what we did here is make it flat, flat, and flat. There's the blanching that you see. Notice the scars, the so-called groove is still there. This one's almost gone, still early. It's only 4 weeks because of blanching. And here it is at 3 weeks. Now, this patient actually had a little groove before. This one's almost completely gone. This one's still there, but the patient was thrilled because she doesn't even see this. You're looking at it with the lip retracted and with but if it bothers a patient after a couple of months, you can always plasti it. Just take a large diamond stone and do a dermabrasion and you'll get rid of it. And that's it. There's no scar. And notice how far forward it was. But we did get the extra tissue now on the front, which is what we didn't have before. And we thickened the tissue. See, the distal one is completely closed. The medial one had a little scar here. You call it a scar, I'm sorry, a groove right there. But I could plasti that. The patient didn't even see it. She was so happy with the result we had with the temporary. So we started with this. Notice how high the tissue is. Palate tissue is there. And this is what we have now. So we started with this. And this is what we have now. Now you can't use zirconia here. So we gold plated ceramo metal. And so, because the whole piece in the front is gone. And we couldn't get the angled abutment for this implant, but we at least got this. We made a custom abutment and we angled it inward. And so this the metal has to be used here. You must use ceramo metal, else it would crack. And there's the implant. Remember, it was healthy. And here's the final case that you see here. So with this one needed surgery, of course. And let's see what it looks like. That's what we started with. Thin tissue, depression, and we brought down. This is strictly a mid-facial problem. The papilla were intact, and we left them that way. The last thing I want to do is sacrifice to get the mid-facial corrected. The last thing I want to do is create a papilla problem, which is far more advanced to treat, as you'll see. And as you know, so the mid-facial tissue is really not a big tool to do if the implant is healthy. Has it hold up? Here's 5 years. I showed you 10 years before. Here's 5 years. Okay, and we have what we want. Notice she had a little groove from whatever was done before, even before I touched her. So it's still a little bit of something there, but she doesn't even complain about it. It looks normal. She is absolutely thrilled, and of course, has sent patients to us over the years. Okay. Here it is 9 years later. 9 years later, and you can see that this is beautiful tissue. Still got that little semblance of what she even walked in with, the little groove, but you're blown up on a big screen. This is not visible to her at all. Notice that the teeth might have come down a little bit over 9 years, because this was a little longer before. The teeth, due to attrition, have worn down. That's a separate discussion, but this was not a factor for her. She didn't really mind it. She still looked great and felt good. Look at the beautiful tissue. Okay. What about Diane? Diane is a separate problem. She's got huge defects here. She was treated by some surgeon who put these in, and they were incorrect position. And look at the bone was that's there. Now, they had bone around them, but they came out the buckle. They came out the buckle. And take a look at this depression. Look at this depression. Wow, huge. So what do we do here? Well, we decarinate again. So we put on. She came in with this little makeshift bonded bridge. We got rid of the bonded bridge, let this heal over. Now we have a little bit of extra tissue, not much, but a little extra tissue, which we didn't have before, right? So that we decarn, notice the hole is always there. So now at least I have a little more tissue to cover my grafting with. Papilla sparing incisions, look at the distance. Before it was up here. Now I'm gonna go down here, leave my papilla. See, I leave all this tissue alone. Leave all that tissue alone. So it's not gonna go anywhere if I don't play with it, okay? This hole I'm going to cover up with a connective tissue underneath. So it gets narrow. It's okay. The implant's in. I'm just doing the graft. Got a big depression. Now in this case, as you see, cleaned it out. The implant was healthy. I'm going to release the flap. As you all know, this is the key to any ridge augmentation. Primary closure with no tension on the flap. So full release. Look at how much extra tissue we have on both laterals. Now here I'm using bone graft material. This is cortical cancellous bone graft. Here you see the membrane put over it. And on top of that, I did what? I have a hole. I wanted extra soft tissue. So I've got a triple graft. I have bone graft, membrane, and a thick connective tissue graft over that. And I suture it to the palate. That stabilizes both. With the one suture, I stabilize right through, stabilize this, the graft, that I tuck into the palatal tissue. And then And so now it's triple layer with the bone graft underneath. And there you have it. And now what you have here is sutured. Notice the passive closure. You don't see any major blanching or anything like that. The papilla is still intact, as you see here. That's the key. I'm not going to give up the beautiful papilla. Here it is 1 week later. Here it is 1 week. Then this is after 4 months of healing. Then Steve made a temporary just so that it had to come out the front for the temporary until he made the custom abutment. Now we're going to redirect this to the palate. There's the custom abutment. Redirect it in, straight in. And here's the final case on the left side. As you see here, look at the beautiful contour. We did the same thing on the left and the right side. And here's the right side. Notice the tissue is there. We re-angle it. Notice how far in it is compared to what we started with. And there's the right side. So this is quite, I think, a decent result. This is what she started with. Remember, big depression, no bone, bone over the implant, but big depression of the bony contour, and wound up with getting this. So here's the before and the after. And I think we got a decent result with what we did here. Okay, so and there's the final case. Now, what do you do with a case like this? This is when they first moved to Columbia about 10 years ago. This periodontal, when the periodontist came up to me and says, "Oh, nice to have you here, Dr. Anwar." I came in from New York University up to Columbia in New York. And they said, well, "We have a case for you to look at." I said, "Sure, okay." So they showed me this case, and it was an implant placement there, old amalgam tattoo from an old apicoectomy. But look at the defect. There's an implant in there that was successfully integrated, and they tried to graft it a few times. They had a big defect. But what do you do here? There's an implant under here. So it's a big defect. Could you pull the tissue down? Here, the palatal tissue is missing. And when the palatal tissue is missing, you got to change your thinking. That's different than the other case that I showed you where the palatal tissue is there on the palate behind you. So this is missing. This is through and through. This is a real type 3 Siebert defect. So height and width. But the good news is it's a V shape. So big, broad ones, we can move, coronally position everything, put pins in, do like stuff Urban does, great stuff. But here you got a V shape, much different. The good news is that the blood supply can come from the sides. So one of the things, we go back to Jay Siebert again in his famous article in 1980 on onlay connective tissue grafts. This is before we had guided bone regeneration. So I need soft tissue here over an implant. So what we do, I'll go through this quickly, we de-epithelialize the area. We de-epithelialize with a big coarse round burr. We see bleeding. That's how we know we're down to blood vessels. If you see bleeding, you're past your epithelium and you're into the connective tissue. I take a thick connective tissue graft in the palate. Look at the size of this. That's huge. And then, okay, and what we do is we suture it in like a jigsaw puzzle, suture it in, and we got this to get blood supply from the sides to penetrate in, and in 4 to 6 days, this will be perfused from the blood vessels from the side, will perfuse into the graft if everything works out well. And that's what we did here. Now, how do I cover the palate? Simply place a piece of triad material and we put it right over the graft. See, right there, put it right over it and it locks in interproximally. And let it stay there for 2 days without taking it off. And then when you take it off, the patient takes it off, you wash it up and you put it right back in and protects the clot. This is a true stent. No need for anything in there. The blood clot fills up against this and will take the same shape. And that's the key. And here it is 1 week. I looked at 1 week, I knew I had to take. Beautiful take. Everything looks good. Everything looks good. And when you look at this, that's 1 week. I got red, I got some white spots for some of the epithelium stuffing, but I like it. And here it is at 8 weeks. This is what we started with, and this is what we finished with. And that's really probably as nice a result as you could get with such a large graft, with such a big defect and a big depression. So let's not forget what our predecessors did, and let's not forget how to do these nice connective tissue grafts. And when do we take out an implant? Published an article in Compendium about this. Basically, we remove the implant for poor spatial relationships that you can't fix if it's not deep enough and it's too far forward. Attachment loss around the implant, that's a big one. And we can't have the prosthetic parts. We have people traveling, as you'd have, from all over the world, and sometimes we don't even know what type of implant or parts they have. But I want to make sure I comment on number 2, attachment loss around the implant. Notice I emphasized that the cases I saved, there was good bone. Here's the nightmare waiting for you to happen. If you try and fix this case, you're going to be sorry. You have too many things wrong. You got 2 implants next to each other in a central lateral position. You have bone loss around both implants, even though they're integrated. And you have a cosmetic deformity of the papilla and midfacial height. Don't try and be a hero. You're not going to get the bone to grow back to the diseased implant surface, plus the connective tissue thickening and the papilla to come back. This is way beyond what you're going to do. So if you have a healthy implants, you can submerge one and do that. But if you have unhealthy implants, these are the ones, if the patient has a high smile line, you take it out. If the patient has a low smile line, you fix them periodontally as much as you can and go on from there. But that's an important one. And there is implant removal kits. Everybody's got them today. And they come out, 90% of these come out with reverse torque machines. Now let's put the last piece together, and that's the orthodontist. We have the orthodontist here, and that's the last piece, particularly for the papilla. The orthodontist can do things that we can't do surgically with that interdental papilla. So let's put this case up. We know that we can get moved tissue with the tooth. Certainly, Stephen Brown and Jeff Ingrid started this work, but we credit for site development to the Salama brothers, Henry and Maurice Salama and Garber, and Francesco Amato and myself have published a series of cases in 2012, and Dr. Hockman, who did the next case with me, and Shu and myself have a summation of the kind of attachment we have to these teeth as we migrate them in orthodontic literature. So what the key is, when you move the tooth, the attachment goes with it. Now let's take a look at Kristen. We published this paper in 2014, but I want you to take a look at Kristen. She obviously has a tooth size discrepancy. This central is too small. This central is too wide. But take a look at the real problem. This is her smile. The real problem is that she has 5 millimeters of attachment loss right in here, right there. That's the problem. And look at the scallop on this side, the papilla here versus the papilla here. So here's Kristen, and she shows it when she smiles. And she's a pretty young woman, and she had an implant placed by a surgeon who lost the implant, regrafted it. He went back and grafted it again, and every time he opened the papilla got worse. And he had the papilla there to begin with. He admitted to me that he had the papilla there to begin with. It was just opening and closing 3 times to try and do the implant, made it too close, lost the implant, it was too close, lost the papilla, then tried to graft the papilla. Every time he went back, he opened that papilla again, and then it got worse. This is like Greg, the first patient that I showed you. That's why he hated every dentist. But here we got to fix this up. She's a young woman. She's now different than Greg. See, the implant was too close and caused this problem. Okay, so we're going to force her up this. What I wanted to do with Greg, but he wouldn't want to hear about it. And what we're looking for is to take the attachment on the tooth and bring it down, coronally move it, and that's where you get the supracrestal biologic width. The supracrestal biologic width is the key. Remember, if you rub the tooth, this attachment stays on it and holds the papilla up in the normal case, and supracrestal biologic width. So here's the case that we do to treat. Dr. Chu also has something made like a little proportion guide, 80%, and we know that this tooth is too narrow, this one's too wide. So we looked at the correct height, the incisal edge is correct, we looked at the height, and the height was the top of the red. When you hold this bottom piece up, you freely makes this for Dr. Chu. And if the red top is here, if that's the right height, the tooth should be 80% proportion height versus width. This should be out to the outside area here. So this should be out to here. So we should have a situation that we have, this has to be wide. So that's easy. But this one is the real problem, is right up here with the lateral. So we're going to expand that tooth. Now here's the key. You cleaned it up, took care of that, cleaned it up, but we always make it temporary. We can do prophylactic endodontics because this is going to be erupted quite a few millimeters, at least 5 to 7 millimeters. We know we're going to devitalize the tooth. And the other thing you should do is always make pink acrylic temporaries, make normal sized teeth. What does that do? It's a visualization for you and the orthodontist. See, are you good enough to bring this tissue down? Are you good enough to rebuild the bone and tissue here? It's your guide. Everything in pink acrylic is what you have to build up. It's a visualization of what you have to do. And she had a big smile, but she liked that. It of course looked better than 2 horse teeth, but it's not perfect. It's just fake pink. She wanted the best. So then Mark Hockman, our orthodontist, our partner, moved it down, starts migrating it. It's already devitalized. We bring it all the way down. Now, when do you bring it down to? You bring it down to the mesial papilla, which was up here before, is equal to the healthy papilla on the other side, over here. That's the height. Now, this is extra tissue. That's because that was the healthy part. So that's the healthy side. So that's going to just be resected back. Okay. This is the key that you need right here. You need to bring it down. So the orthodontist will always ask you, is it down enough? Well, when it's down to this point, then it's down enough. Then we can put the implant in. Now, always do the movement of this before you do the graft of the tooth and the graft of the ridge. Why? Because this is giving you blood supply on both sides of your ridge. It becomes a straightforward ridge augmentation, as you'll see. Once you got papilla here and papilla here, you've got blood supply on both sides. So that makes it easier. When the papilla was up here, you don't have blood supply, and that's a problem. So we're going to trim that extra tissue back. But take a look when we go in. This tooth actually, there was no pocket here, but actually the root was out of the bone. But we're going to keep it for cosmetic reasons and splinter to the tooth because it has these fibers. Notice papilla sparing, and then put some graft in here on both, put the implant in the correct position, grafted the defect that was there, put some extra graft over the tooth, and put a membrane in, resorbable membrane. The papilla stays intact. Here you see the initial healing, extra tissue on the distal. Steve just trimmed a little bit away. And we started with this. This is what she came in with. And we now have this in the temporary stage. So we started with this. Now at least we have a scallop. Now it's not perfect, but it's pretty close. Now we're going to save these two and join the two together. We're going to split the natural tooth to an implant. Now I could take it out and make an ovate pontic, but that'll tend to cause some tissue loss in the papilla. Not as bad as 2 implants based on garbage work at Salama, but it's still better than taking it out because it's healthy. It's a reduced but healthy periodontium. Right in here, you have a reduced but healthy periodontium. It's healthy. It was brought down. There's no pocketing of any significance here, but it's healthy. So let's keep it for the cosmetics to hold this papilla up, and that's what we're going to do here. And so we split the two together rigidly, no interlocks. Make believe it's 2 teeth. Make your abutment parallel to your prep, and there's your 2 teeth, and there is your papilla between the two, and there's the case, the final case intact. A little extra here, but notice the papilla is still a hair short, but we have a V shape. And this is what we started with, and this is what we have as the final case. The pill is still not perfect, but it's more than adequate. And this is still healing up here, but notice we got a nice pink tissue around the implant and around the tooth. They're splintered together rigidly because the tooth was weak. Here you have it, finished in the mouth for a little bit. And here it is 4 years later. So you can see what we have 4 years later. You can see that we have the scallop, which we didn't have at the beginning, and we have basically a happy tooth. So we can do a lot of stuff with orthodontics. So what's the best way to finish up? The best way to try to be on time, the best, because I know it's late in your country, the best way to look at this, I want you to go back to Greg. Let me just finish with these 2 slides. Okay.
Take your time, Doc.
Okay.
Take your time. We're enjoying it.
Okay. I know we're trying to stay on time. You got Greg here. Remember the first patient? The patient I said that we just filled in with pink, that he had the same lesion. Identical problem. Mesial lateral was receded. And he didn't want to, he stopped us from doing anything except doing a prosthetic solution, which didn't look good. And that's why the guy that we said that he hated all dentists, but he was happy. Now, Kristen, she went ahead and got everything done. She was a younger woman. She wanted the best cosmetically. She didn't want any fake pink like that would show. So she went for the whole thing. Take a look at it. But you know what was interesting? Same lesion, but both were happy patients. This is something to learn. They were both happy patients. We met their chief complaints, both met in different ways completely, but we met their chief complaints. And so they were both happy. So without sacrificing quality dentistry, even though I don't like Greg's cosmetic result, there was nothing wrong that he couldn't clean. There was nothing wrong. We weren't hurting him in any way. So if you don't hurt a patient and you meet their needs, you can make them okay. Just don't do anything stupid that will obviously stop the patient from cleaning or creating a periodontal problem or decay. So that's what it is. So interdental recession, orthodontic forced eruption, align the interdental papilla, retain the natural tooth adjacent to the implant. I think that's important for supracrestal biologic attachment is what the name of the game is. Rigidly connect the 2 together. Split the tooth to the implant. And even though you're told it doesn't work, it does. And you do it rigidly and put in with strong cement. No retrievability. It's a 2-unit bridge, 2-unit splint. And that's the key. No interlocks and no telescopes. That's where things march out, or the tooth intrudes. Just rigidly, once you're in for a week and everything's comfortable, then it's permanently cemented with whatever you rely or whatever material you want, like you would on 2 teeth. So thank you very much. And I wish you a safe and happy time and listen to any questions that you have. And again, for all my alumni, love you all. And thank you, Khalil, and thank you for all of your work, both Khalils. Thank you so much for inviting me. It's my honor.
Thank you, Professor Tarnow. It's been a great lecture as usual. We didn't want that lecture to actually end up, but I guess we're gonna have to ask a few questions because we have plenty actually. So one of the questions is how long after the tooth gets extruded you'd actually wait for these fibers to mature before you actually do your surgery?
Great. We usually wait a minimum of 2 months, and they don't need maturing. What needs maturing is the bone around the implant,
right,
and the stability of the tooth. The ligament gets stretched, as you know, and then when a ligament is stretched, just like any orthodontic movement, when ligaments get stretched, the bone is stimulated to fill in behind it to shorten the ligament space again back to 1/4 millimeter. So it gets stretched. That's whether you move it this way or vertically, it doesn't matter. So the ligament is still there, that's healthy. And the attachment, the gingival fibers don't stay on the tooth. They're not being changed. They stay on the tooth, exactly, and the epithelial attachment and the gingival fibers, the supracrestal fibers on the tooth that you're moving, they never move. They always are on there. You're waiting for the bone to heal, and that's why you stabilize it for at least 2 months minimum before you activate anything, or before you take the splint off. Otherwise, it will tend to retrude back up because the tension on the fibers. Then the bone will fill in after 2 months minimum, and then shorten that. So it's a great question.
All right. One of the other questions is material-wise, does it have to be always subepithelial connective tissue, or would you, in these cases, for the dehisced facial surface of the implants, or could you use something other like alloderm or mucograft?
I've used alloderm. Alloderm doesn't work. Alloderm can work. I have cases where I've used alloderm, but I find that when I have that hole from the fistula by the decoronation, that the connective tissue, I want fresh connective tissue underneath. See, alloderm gives you the thickness, and the connector is a barrier. I published on that along with others. I published with Dr. Fletcher on a case showing that if you use it for guided bone regeneration, alloderm. The problem with alloderm is that it's connective tissue, but there's no vascularization to it. It takes months before that revascularizes like a fresh connective tissue graft, like I showed with that big thick onlay graft. That's revascularized in 7 days. Whereas alloderm takes a couple of months before the penetration of the vessels come in, before the penetration of the vessels come in from the bottom and on the flap to get through. So if you have a hole in there, I want some fresh connective tissue, like a fistula. I want the fresh connective tissue underneath. I still find it gives me my best results. I sometimes put alloderm underneath the fresh connective tissue, like I did that collagen. Sometimes I use alloderm as the membrane, and then over that, or perioderm, which is what I use a lot. I'll put that in and put the fresh connective tissue over that and suture it. So that I have done, and I have other cases that I didn't have time to show today. Sure, but you can do both. Yeah,
sure. And is it always narrow abutments, or is it case by case, or just to help?
When you uncover when you have any implant, if it's submerged. Now we do like I said, Dr. Chu and I just published a book by Quintessence on the single tooth implant. All this is in there. I mean, not the repair, but how to prevent the repair, how to make it work the first time with immediate sockets. And we have a whole discussion of it. But if you, for some reason, have a submerged implant, like we're doing here after we decarinate it, you never put on a full-sized abutment. The flattest profile one you could find, especially on the front, since the implant is facing forward, you want to bring the contour in right away when you uncover the implant and let it heal before you stretch it with the crown. So every implant that you uncover that has a healed ridge, we always let it heal. We always put a healing abutment on, and the flattest one we can find on the cosmetic areas where it's too far facial. Then we stretch it after 4 weeks of the soft tissue healing. Then we can stretch it with the blanching, with the crown, with the proper contour.
Can we ask something a little bit on a previous topics?
Sure.
The usual lecture on the dual zone. I think there's a lot of confusion on that and the understanding of that. And some people prefer that technique. Some people they do the Hersler and Zur, the socket shield and the surgical veneering. I mean, what's your thought about these, Doc?
Sure. There's a place for everything. Like my alumni will tell you, I have this funny comedian who's called the Banana Man. The Banana Man has a pocket filled with bananas, and his pockets. He comes out. He's a comedian. When I was a little boy, he was a comedian, and he would come out with this big black coat and was filled with bananas, and he never said a word. All he would do is amaze everybody with how many bananas he had in his pocket. And you go on bananaman.com, and you'll see this guy. Go on Google, whatever, and bananaman.com. And this old comedian, he had this big coat, big black coat filled with bananas. And all he would do is, ooh, banana. And what I tell my students all these years, every procedure you learn is another banana. And put it in your pocket. That's what we teach you. We're teaching you as students, undergrad, grad. How many different ways can you handle a class 2 restoration on a lower molar? I mean, there's 20 come to my head right now: indirect, direct, amalgam, composite. I mean, think of all the inlay gold. Just handling, how many bananas do you have just to handle a class 2 decarious defect on a mesial of a molar? There's 20. You have to have so many bananas. Well, this is the same thing with immediate extraction. There's a lot of ways to get across the street. The question is for the patient in the chair, which is the best way? We have found that the easiest way for us, and the least invasive way for us, and with the great predictability that we published on, as Dr. Chu and myself, and it's in that book, is that we do what? We do the dual zone concept. I came up with that because when I was doing the surgery, I had some extra graft material. And I said, let me stick it up instead of just to the crest, let me bring it all the way to the free gingiva. And then we'll seal everything off with the temporary or the custom healing above it. And we saw the results were incredible. And they thickened the tissue without a connective tissue graft. And we published that with the thickness of the free gingiva. So what I will tell you is that there's a place for everything. They can all work in the hands of qualified surgeons. I mean, you're taking a connective tissue graft and putting it in the way Otto Zur and Marcus are doing. Yeah, not everybody has their ability, and doesn't mean you can't do it. But you're reaching to fix one tooth. I think it's way overkill. I think we want to make it simple for the rest of the world to be able to do it, who don't always have the skills of a Hertzler or Otto Zur. And although I think I'm skilled, I'd rather do it simple. So it's the KISS principle. So which is the best for that particular patient? Doesn't mean you can't do that. Of course you can. But you're also invading the tissue. You're going to another side for the connective tissue. It's more time, more costly, and you're invading that buccal tissue. And you, of course, when it works, it's great. But if you look at Jaime Lazoda's work with the connective tissue graft, 20% of them had more recession than they started with. So it's not always perfect, even in quality people's hands. So it's been published. So all I'm saying is you see beautiful cases on the lecture circuit, but not everything's perfect. We've even seen problems with our dual zone. What was the problem? That's why we now go to small particles, and we stopped using BioOS, which we love for other reasons, but we stopped using BioOS in the free gingiva part because the particles don't get resolved, and they can sometimes work their way out the front and create a little, like a splinter coming out the free gingiva. So we use small particle cancellous bone, and that seems to minimize that chance. It's only rarely we see it, but now we hardly see it at all. And as far as socket shield goes, when do you use it? It's technique sensitive again, you know, and I know my good friends, Maurice and Gluckman, they're good people and good friends. And it has a place, and Mitsias from Greece, one of my former students. It has a place, but what's interesting is that it's much more technique sensitive. I'll tell you where I think the place, you know, is there a place, like I said, it's another banana. Where can I see it being used? One is where you possibly have, if you have an ankylosed tooth and you clean out the major infection, but the piece of ankylosis, if you take it out, you rip out the buccal plate. That's one place where we have used it. And I've done it that way for sure. Where's the other possible use? Think about this. If you have a tooth that you're taking out that has a healthy buccal attachment, you're taking it out because there's apical or palatal lesions, but the buccal is intact. But when you look at the CAT scan, there's no buccal bone on the front. It's not probable. It's like a cuspid or a central. It's not probable, but on the scan, you can see that there's a buccal dehiscence. And if you do sound it, instead of the bone being 3 millimeters from the free gingiva, you're at 5, 6, or 7 millimeters up. And if you take it out, you're now, instead of having a type 1 defect with lots of buccal bone, you really have a type 2 defect just by taking the tooth out. So that might be a place where we keep that piece of root and don't create the buccal dehiscence that's there. In other words, leave the piece of root there and take the rest of the root out. And that might, I presented this at the AAP meeting, the Academy of Periodontology meeting this past few months ago. And I think that might be the ideal place to think about doing a socket shield. So certainly it can work. We've seen enough documentation, but if you look at Gluckman's work, 20% of them had some problems. Not all were terrible, but they were treatable, but 20% did have some problems. They're learning. You got to cut it back enough. You got to make sure it's not sticking out too far. And so there's a place. And I think where there's a buccal dehiscence that's a healthy tooth on the front, but a buccal dehiscence may be the ideal place to now consider that.
Sure.
I hope that helps.
I just want to make a few comments, if you allow me, sir, for the connective tissue group, for the Loma Linda group. I mean, I think that those cases that were presented, they were residence cases. I think they were just learning, but I'm looking at the systematic reviews that were published in 2017, comparing the addition of connective tissue graft whenever doing an immediate case versus no connective tissue. And they're showing that the connective tissue groups were not necessarily coronally migrating the tissue, but it's thicker enough to prevent any exposure of the soft, material, the restorative material, the abutment material.
Well, it's thicker than the normal. It's thicker than the normal tissue. Sure, it's thicker than the normal tissue. Which I agree with. However, we documented that we got documented that without having to go there, by doing the dual zone technique, we documented the extra thickness of the free gingiva. Go look at our article that Chu is the lead author. You can see that we actually measured the extra thickness with and without the dual zone. So we even with the platform ship, we got better results with the dual zone and the thickness of tissue.
That's right.
We increased.
And then when it's your call, sir, and you're doing that immediate implant, do you always advise on immediately provisionalizing that implant?
Right. We get pretty good stability. We get over usually 30 plus. Usually with the new ones we're doing, the inverter implant that Dr. Chu devised, we're actually getting as much as 50 to 80 Newton centimeters torque at the apex. And then we graft the rest of that. But you really can get, once you're at 30, 35, we're totally comfortable. Take it out of occlusion, tell the patient to stay away from it. And why do I want that? We want that one to be the same contour that you like. Just take it out of occlusion and protrusive and centric. because it's helping hold the papilla, not just the midfacial tissue. It contains the graft. It's prosthetic socket seal. Paul Weigel in Germany, he came up with a good term. Prosthetic socket seal almost 10 years ago.
Right.
So it's prosthetically socket sealing for the graft or the connective tissue, whatever you put into the gap. And you're supporting the tissue during the healing for shape. But also, listen carefully, you're getting what? You're getting the papilla doesn't go away. When you have healthy papilla on the adjacent teeth, the papilla stays there. Why? Because the attachment, as I showed you in the last case, the attachment on the adjacent tooth, if it's healthy, holds the papilla up and it stays. It's beautiful, and that's what we do.
Can you tell us more? I'm very, I want to know about that new implant system, sir, the inverted that you're using with Dr. Shu. Everybody wants to know more about this. I mean, it looks awkward on the outside. It's not the usual implant that we're used to. So what's the idea?
Incredible. I'll tell you, first, when Steve first showed it to me, the concept, he only had a little bulge at the bottom. I modified it a little bit to give it much more length and stability. I'll tell you, it's amazingly stable. It's the Southern Corporation has it, and it has two angles. It comes straight or it can go angle. And the coax one, the one that has 12-degree bend, has been around on the Southern implant for quite a while. That's not new. We didn't know about it and really didn't use it because we saw with if you have an abutment, if you have an implant that has a 12-degree bend, how do you put it in without it wigging around? Like, ooh, it's going to work when you put the abutment on. But they're smart guys. The guy Dow in South Africa came up with an abutment with the same bevel, 12-degree bevel. So when you put it attached to, it actually goes in perfectly straight. So it goes in straight, and then you just make sure there's a notch on the front, make sure that's in the front, and that means the screw hole's in the back. And it's screwed down. Today we want to avoid cement. And 80%, based on Joe Kahn's work, 80% of the implants are in the labial part of the ridge, as you know. Right. And those implants, it's hard to come out the cingulum for a lot of clinicians. We've been doing it for so many years, but even still, even as an advanced clinician, some are just too far forward. And to come out the cingulum for a screw down, a lot of times you get pushed off the palatal bone and you move into the incisal edge. I'm sure everybody's experienced that, where they tighten the implant down and suddenly they start at the cingulum and suddenly it starts moving slightly forward as you tighten it down because you're hitting the palatal bone and there's no buccal bone because of the gap. So Steve came up with this idea to get stability at the base and give us more room at the top for grafting so that we wind up with a thicker buccal plate radiographically. We fill that with bone, the gap fills with bone. The buccal plate's there, and similar to what Mariano Sanz just showed, we fill it with to prevent the ridge from coming in. We put some graft material in, and then seal it with the temporary. And the other interesting thing is by having a narrow, it's not really narrow, but it's a little bit narrow at the top, besides the platform shift, by having a body shift, it doesn't hit the palate. And like when I drill, I use the incisal edges of the teeth as my guide, not the cingulum like I always do. Otherwise, I can bring my implant, I can have it go into the apical bone and better and the palatal bone. So aiming, which we don't like normally, aim at the incisal edge. Now I can aim at the incisal edge, but my screw hole is going to come out the cingulum and do a beautiful screw down because of the 12-degree bend. So the Southern implant has had that for years, and now we got the inverter, which even gives you more room on the palate as well as on the buccal to put graft material in and thicken the bone on the healing.
Got you. Can I throw in a couple more questions if that's okay with you?
It's okay with me.
For a central incisor, maxillary central incisor versus a lateral incisor versus a canine, what's the diameters that you prefer? Providing that whatever diameter you're using, you're going to get a stability. What's the impact of that diameter?
Right. Well, that's why we have the body shift. That's why we like the inverter. We like the thinnest. But we don't like a 3 or 325 millimeter implant for a central. A lateral, sure, but for a central or a cuspid, which is going to get a lot of force, I'd like to get at least 2 or 4 millimeter implant. 3.7, 3 or 4 millimeter would be my minimum. So that it can. But I like the narrowest one. The key is, like you said, which one, as long as they have stability. If they have stability, that's fine. Same stability, great. Then it creates more of a gap, and that's what the inverted part, the top part being narrow, allows you more room. The more room, the better, because it's safe zone. Because in the future, we're also seeing with all the work by Deftari and by Oded Bahat, we're starting to see that the buccal bone over years, 10, 20 years from now, the buccal bone might move in, even on normal teeth, let alone implants. And Torsten Yem showed the same thing over 30 years in his documentation. So we want to increase the thickness of that buccal plate and stop the grayness of the color coming through wherever possible.
Gotcha.
So the thicker the better, as long as you got stability, thicker the better. That's just stability. I mean, ability to withstand forces. So I don't want a 3 millimeter implant in the central incisor or cuspid. I'm going to at least a better 4. The lateral is fine.
Sure, sure.
Okay.
Well, I think we're about, that's about it for tonight. I mean, there's a lot of other questions, but I really want to thank you, Professor Tarnow. It's an honor, and if I may ask that you kindly stop sharing your.
Oh, okay, sure. Okay.
All right. Let me do that for a second.
I think I stopped there. Okay.
Okay. So again, thank you so much, Professor Tarnow. It's been an honor, honestly, for us to have you with us. Learning again from you never stops. Just listening to you, you could inspire tons of clinicians, thousands actually of clinicians across the world. We have a lot of people attending inside Saudi and outside Saudi, so I'm pretty sure that everybody enjoyed it. Everybody got a lot of new information. So again, thank you so much for accepting our invitation. And this is just a small token of our appreciation. Please, Professor, stay safe and be well. And we really hope to see you in Saudi Arabia sometime soon. Anything we want to say to the people watching you? Happy to be around you.
Assalamu alaikum. Thank you so much for inviting me, and to all my alumni. I love you, as well as the people in Saudi and Middle East. Thank you so much for attending. I know it's a lot of sitting, a lot of time, but stay safe, okay?
All right. Thank you so much, Professor. And it's an honor for us. All
My
right.
pleasure. Thank you.
Abdul Karim, Dr.
Yes.
Abdul Karim, this was great. This was great ending of a great Congress. So the same, I'll use this opportunity to thank you for running this session on behalf of the Saudi Dental Society, the British Dental Academy, and all the Saudi societies who are part of this big success, the Saudi Dental Society of Periodontics, of Prosthodontics, of Restorative Dentistry, Orthodontics, Pediatric Dentistry. We were so grateful for all of these societies gathering together to give us this opportunity to learn while we are home. It's the responsibility of all of us to stay safe, to keep our countries, our people safe. Abdul Karim, you did a great job. Thank you so much. I cannot thank you enough. Yes, this was so great.
I actually enjoyed it. I enjoyed working with you and with Prof. Khalil and all the scientific committee people. Thank you so much for having me tonight. It honored me, honestly, to be part of this. Even if a small part, it still makes, it still counts. And hopefully, inshallah, everybody stays home safe, and this issue, Corona issue, passes safely for all of us. Thank you so much.
Hopefully soon. Hopefully soon.
Inshallah.
For all the people now, I want you to stay with us a little bit. I want to remind you of the program tomorrow. We have a great program covering implant dentistry, aesthetic, restorative, and prosthetic dentistry. We promise you an excellent program and something to wait for. So I hope to see all of you tomorrow. We crossed the numbers today. We have more than 2,500 people with us on Zoom platform, more than 10,000 watching us through the live streaming on Facebook. So we promise you an exciting program tomorrow. So I hope to see all of you tomorrow. Meanwhile, please stay safe, stay home, and thank you so much. Assalamu alaikum wa rahmatullah.